Right. Okay. Okay. Hello, Nor. Can you hear me? I guess you're not in there. You fell out. Oh, there you are. Okay. Hello, Nor.
Hi, how are you doing today?
Good. How are you?
I'm doing great. Thank you.
Okay. Now, where's your camera on? Let me get mine off here. Oh,
Yeah. I turned on my camera. I guess I'm just trying to set it up. Actually,
okay.
yeah, I
Okay.
attach I attach DSLR usually with the meeting.
Okay. Here's what I want to do. Okay, Nor. But I want to see your face while I'm talking to you.
Yeah. This is
Okay.
my
Okay.
laptop one.
Here's what I want to do, Nor. Okay. Chandra's coming in. He may take a little more time than he's
Sure.
allowed. Okay, because he says he has a couple more cases. So I'm wondering if you could do like 20 minutes, talk about the projects that we've done at the WFNS, and
Yes.
then talk about the future projects and talk about what we're trying to do with these webcasts, about with trying to reach the medical student and residents. You know what I'm talking about, right?
Exactly, I do.
And you won't have a hard time talking.
Okay.
Once the whirling dervish starts, whoa,
Yeah.
hard to stop her.
Oh no, thank you so much. You're so kind. There's a lot of going on right now with the WSC and MSMR. So we are already doing the
Well, Nor, uh, let me tell you my theory. Okay. I think because I televised some interviews from Bogota
yes.
with Victor and stuff. And it's not full, which no one expected it to be full. But I was thinking, you know what? I think a lot of people are going to start going to these conferences, and once they're there and have gone home, they're going to say, "Hey, that really wasn't worth the whole trip. I could have
Yeah.
just done that on video." You know, no, really, I really think it's going to change the industry. I mean, the face of the medical conference industry.
You are absolutely right because there are several problems that are actually keeping people from attending such conferences and workshops. I'm not a very old resident. Even a few years back when I joined my own residency, say about 4 years ago, we did not have these privileges to attend every conference and workshops. And many of my junior trainees, unfortunately, they cannot even afford to go abroad and just take all these expenses to bear all the expenses. And even if we can, then we are not allowed to leave our hospitals. Like they do not give us leave to go and just attend a workshop or seminar, whatever. So I think that this possibility should never be shut down because this is the huge privilege that we are going to offer to the generation that needs to get trained. I don't think that these conferences will add that much to us when we will get senior, because at that time we will have learned a little more. Like, neurosurgery is a continuous process, and you have to learn at each and every step with every different level as you advance. But we need it the most during our early
Excuse me, Nora. I sent you an invitation to be a co-host. Okay.
I haven't yet got it.
Yeah. I'll send it again. Okay.
Sure.
Because I sent it to you. You should have said accept. Because
Oh
it should be
no,
there. Are you co-host?
let me check.
Okay.
Yeah, I'm all done.
Okay, I'm
Fantastic.
gonna do a little last minute marketing. I'll be back, okay?
Sure, sure. Thank
In
you.
a few minutes, just admit people, okay?
Sure, I'll be writing that in.
They'll be coming in, so please admit them, okay? I'll
Sure,
be
sure,
back.
sure,
I'll be
sure.
back.
Are we supposed to make them?
Hello. I can't hear you, Noor. Uh, you need to unmute yourself. That's better. I still can't hear you.
Okay, Chandra, can you hear me?
I can hear you quite well, John.
Okay.
Good morning.
Good morning.
I've just added a couple of cases if there is time.
Great, great. Let me just tell you how we want to do it. Let me get my camera working here.
Yeah. I am seen and heard, right?
Yes. Oh, my camera just went
Trying
out.
to look for some Bombay virtual background. Let me see.
Dr. Sam is also here.
Hello.
Hi, Dr. Same.
Has Dr. Same joined us?
Yes, he has just joined in.
Hello.
Hi, Dr. Same.
Okay.
How are you?
Okay.
Hello.
Hello.
Seem to be busy. Hello.
I am in the waiting room. Thank you, Professor Chandra, for accepting our invitation.
We can probably see some live surgery, Dr. Same, if you're
Yeah,
operating.
Unfortunately, this waiting room is not prepared for live surgery. Okay, I will join you from time to time unless they prepare the next operation.
Okay.
Okay.
Oh, okay. Okay, greetings. Okay, Sam, here's what we're gonna do. Chandra's going to add a few more cases. He's been nice enough to do that. And then Noor is going to give a talk on the WFNS presentations that we've been doing. So that should take up the first two slots, okay?
It's okay, but Professor Stabanova will get in her time because she has.
Okay, that'll take up the first two IPE slot also, and then we go back on the schedule. Yeah, and
Okay,
I realized you weren't prepared because we added this. You know, you weren't, you know, so this is, but we'll get through it. We'll get through it. Okay.
Okay.
Okay. I think we got all the people coming this morning, and I don't want you to hurry surgery. Just do what you got to do.
We are here to help out, and you don't have to worry about anything.
Yeah, I just got the camera working. So, does that sound like a plan, Sam? Can you hear me? You can't hear me, maybe.
I think he's muted.
Okay. Let's see. So you've been in.
Okay, it's okay.
Chandra, you
Okay,
there?
Yep.
Oh, okay. For some reason, I can't see your camera. Oh, that's strange. View, okay. Oh, okay, there we go. You know, I can't see, you know, usually you can see the panelists, Nor, but I can't see them all. Can you see them all?
Yeah, yeah. I'm adding them up, but no, I
Yeah, I've
think
got to
that,
make a setting change, I think.
No, they are all there. There are 11 panelists in our panel right now, and there are 7 attendees. I have promoted them all to the panel, but I think there's a little lag between our invitation and their acceptance. So we have so far 11 people
Okay,
in the panel.
excuse me, Nor. Sam, Alvaro, did you contact Alvaro lately? Because he's scheduled in an hour.
Yes, he will be in.
I think I got his Facebook account. Maybe I'll just text him.
Time.
Okay.
He will join us in time.
Okay, let me text him right now.
Okay.
Well, I'll text him during the Chandra's talk. But other than that, the Segru, this Australian neurosurgeon, you know him, right? Michael. He's coming at 2:15, and then there's Sarath from Sri Lanka, and then there's Dr. Kabulo from the Congo. I'll check with all of them to make sure they. No, yesterday with Dr. Lawton, I could see the link in that message he sent you. So he had the link in the message, but it doesn't look like a Zoom link. Do you know what I mean?
I know I have sent him the Zoom link.
No, it doesn't. No, you sent him one too, but he had it right on the message, but it didn't look like a Zoom link. And he could have got in if he just clicked that link on his message.
I repeated the message more than one time, and I know this is his list for this week. That's why he may not.
Okay, so Chandra, how you been? Oop. Chandra? Oop. I don't know if he dropped off again. He dropped off once. I hope his connection's okay.
I guess there's some.
Are you there, Chandra?
I'm personally feeling that there is some issue right now in the internet, because today when I was on Google, I consider that it's showing a little delay. I can see he's back in.
Sam fell off too.
Yeah.
What's going on here?
Sam.
Oh, there's
no, he's there. He's there.
Zoom logged us all out. That's why we lost all.
You just fell off, and Chandra fell off. Chandra, is your connection okay?
My connection is okay, John. I
You
think
fell off
there
a
was some
couple.
problem about being an attending access panelist, and that's
Okay.
why I think I got cut off for a few minutes.
Yeah, I was wondering why you just dropped off there a couple times, but
I'm having problems as well because when sometimes, it's like it disconnects and then reconnects. So I don't know what's happening right now with the
I
Zoom.
can't hear
I
no
hope
so
it's not
well.
Zoom. If it's Zoom, they're gonna have big problems.
Yeah. I guess because it is Saturday and it's
No,
not
they're a super company. When something's wrong, man, they jump on it. It's such a huge business. They've gotta.
Yeah, exactly. But I think that at times,
Did you
there
see
was
how secure it is now? I don't remember they had some security issues, but now, wow, it's tight. They've got really good security.
Absolutely.
You know, and I haven't seen any people jumping in. Remember how people used to jump in and hack the Zoom? That didn't happen much, but it happened a couple of times.
well, I think that it is all about the settings, so Professor Barbara is quite into that setting, so it makes it much safer and much better to use if you just stick to the to your panel. So at times.
Okay, Nor, okay.
Yes. Yes.
Okay, we're gonna start. So Chandra, how long do you figure? Well, you can go 35 minutes if you want, 30, 35. It's not tight. And then Nor is going to speak, right, Nor, for about 20 minutes or so?
Yeah, sure.
Okay,
Sure.
we'll just go free form. Okay?
Okay. Yep.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett. For Neurosurgical TV, we have the pleasure of having the second day of the updates in neurosurgery, produced by Samuel L. Morsi in Cairo. He's in the OR, he can't join us this morning, but I'd like to introduce the host, pro temp for Sam, Nor. Welcome, Nor.
Hi, thank you for having me here.
Okay, you want to introduce Dr. Well, I can introduce Dr. Diopujari. Everyone knows who Dr. Diopujari is. He's a well-known neurosurgery educator, especially in India. He's based in Mumbai, and we've done lots of webcasts. He's very active in education. Okay, welcome, Dr. Diopujari.
Thanks, John, and thanks, Dr. Sameh and Noor. I have been, I think we will start off with the first talk of the day, and I'm going to take you through our experience with endonasal endoscopic skull-base surgery in children. Can you see my screen and hear me?
We can hear you fine now. We're not seeing the screen share yet.
Not seeing the picture?
Not seeing the screen share, yeah.
I will have to share the screen again then. Why is that? Share the screen. Can you see it now?
Yeah, you're on the way. Okay.
Okay.
Yeah, you want to make it full presentation size, right? Presentation mode. Yeah, perfect.
So thanks once again for the opportunity to share some experience in endoscopic skull-base surgery in children. Basically, if you look at the evolution, there have been very few references to endoscopic surgery for children for the skull-base lesions. In fact, there is none in neurosurgery literature till this millennium. In 1990s, you see a couple of papers. This is what I could actually get in English language literature, which are all in head neck surgery and otolaryngology, where they talk about possibility of transnasal endoscopic surgery for some of the lesions like congenital defects and nasopharyngeal angiofibroma. And one of the papers talks about nasal dermoid. But what we understand are the true skull-base lesions. If we look at neurosurgical literature, you find that there is mention of pediatric skull-base surgery, but most of these references till about 2010 or so are all for the transcranial approaches. So today, in fact, if you see with development of endoscopic surgery, CSF leak repair has become almost a complete kind of a package. With endonasal surgery, very few cases require transcranial surgery. Endonasal surgery always plays a dominant role in developmental anomalies like meningoencephalocele and odontoid invagination, and in neoplasms like pituitary tumors, craniopharyngiomas, chordomas, as we'll see later. Special considerations and challenges are mainly the restricted space due to small nasal aperture, ill-defined turbinates, delayed development of sinuses, and intercarotid distance. These are the main worries if you are considering this kind of surgery in children. The size of the airspace in the nasal cavity depends on child's head size. Skull base growth centers should not be disturbed much in prepubertal. That's another care you have to take. Taking all this point in consideration, it is better to no. My screen is gone. Some other screen has come with extradural or subdural hematoma.
Yeah, I see that. You were virgin. Okay, we're watching someone else's screen. That is very strange. I'm sorry about this. Okay, let me get that person off. I don't even recognize the name.
Yeah, I've done that. It was Trian Ongoriano.
Okay, go ahead, Doctor. Screen share again, please.
Please go ahead, sir. I've managed the issue.
Can you see? Oh no.
Yeah, you can
go back to sharing screen.
Yes.
Can you see again?
Yes, I can see. Yes, we can. Presentation mode.
So the maxillary sinus is the first sinus to develop and is filled with fluid at birth. But though it is the largest paranasal sinus, it usually reaches adult size by about 18 months. On the other hand, the ethmoid sinus is usually seen in almost 100% of newborn children, and they are also fluid-filled cavities and pneumatize almost up to the age of 12. Sphenoid sinus, which we are mainly interested in, is identifiable as early as 2 months of age in very, very few children. Pneumatized sphenoid sinuses are identified when you are looking at children above 3 years on axial images and above 6 years on sagittal images. Almost all children beyond 9 years, you see some amount of pneumatization in the sphenoid sinus, and which is one of the prerequisites of endonasal sinus surgery, though it is not strictly true, as we'll see later with some experience. Frontal sinus is housed in the frontal bone superior to the eyes. Developmentally, this is the last sinus to pneumatize, and it is about 14 to 15 years by the time almost over 90% of them grow to adult size. So 3 important factors to remember is that the pyriform aperture is likely to limit only in the youngest patients under the age of 2 years. Sphenoid pneumatization, which is required for plain.
He's muted. Hello, sir.
Yeah, once again, that's so strange. I'm
You know,
sorry, Dr. Deopuja. I don't know what's going on.
Does it,
with Zoom. Let's try again.
John, I've sent you a message too. I guess there is a little thing that's going on.
That was strange. After I was talking about how efficient Zoom was.
Yeah. We are still having a few issues. Will you please refer to the message I have sent to you?
Okay. I see the problem.
Yeah.
There's someone that came in that just started sharing the screen.
Yeah, exactly. That's what happened. So we are going to limit the the speakers list, like Professor Barba and I do, in the DWC. And in our course, we also limit that list, in the panel only, the speakers. So we are just going to allow speakers in the panel only. Dr. Sami wants that as well, like we do in our course.
Yeah.
So I think I totally agree with that.
Okay,
So,
okay, Nora, I think Dr. Diopajari is.
he's there. He's back in.
Okay. Okay, Dr. Diopajari. Reviewing his screen, can't hear.
Yeah.
All right.
I think he's settling down. He's on his way.
Can you hear me now?
Yeah, yes, exactly.
Yes.
Okay, I'm sorry, I don't know what's happening.
It's not you, it's Zoom. It's Zoom. It's Zoom.
Okay.
Would you please to want to start from the beginning, as there are more interruption of your lecture?
Okay, go ahead, Dr. Diopajari.
Okay, so I think three important points when you're operating on children is that the pyriform aperture is a real limitation, mainly under 2 years. Sphenoid pneumatization starts at 3 years and is complete by 10 years, and intercarotid distance does not change too much over a period of time. And if you have about 10 millimeters, you can probably consider endoscopic endonasal surgery in that area. Now my slide has stopped moving. Can you hear me and see my slides?
Yeah, we can see the slide, we can hear you, but you're trying to advance it, right? It's not advancing.
Okay. I'm hoping that it starts working again.
Okay. I guess you can just do it like that without putting it on the presentation mode. Do you know what I mean?
Okay.
Oh,
the other issues of importance in small children are the amount of blood loss during surgery, and you need to have proper set of instruments. We actually use, apart from using a pediatric scope, we use micro ear instruments for these surgeries. Virtually everything is available which you need to use for repairing the defects or removing the tumors. Reconstruction of the defect is an extremely important consideration, and you have to look at the feasibility of vascularized flaps, which have become the mainstay of closure in adults. So if you look at these issues, you will find that there are microscopic transsphenoidal procedures performed by Dr. Law's team way back in 1994. And there is another paper which shows Delalande's team in France who have been able to do all more than 12 cases where they found a problem because of the incomplete pneumatization, and found that was a limiting factor, but in many other cases, so about 20% cases, they could not proceed. Our experience, I would like to share first for the pituitary tumors. This is a young boy who actually came at the age of 10 years to us with, you can see Cushing's with high cortisol level, high ACTH levels, and petrosal venous sampling had shown a right pituitary location. And you can see a nicely well-defined tumor next to the cavernous sinus on the right side, very well delineated here as well as here. And you can see that with endoscopic endonasal surgery, a complete excision has been achieved, normal gland has been preserved, and there was normalization of ACTH as well as cortisol levels. And you can see this boy after a year. It is virtually impossible to recognize that it is the same boy whom we have been treating. Another child who he actually came at 12 years of age to us, and there was increased ACTH level. You can see the photo. And this boy had surprisingly two adenomas. The petrosal venous sampling had shown that the left side was showing higher levels. So we first went for that. You can see that the sella is being drilled, and you try to go carotid to carotid. You eggshell, and then you remove the thin bone at the end, which is being removed now with rongers. And then you will find that the tumor is coming out nicely from the left hand side. And then we also explored the right side as there was doubtful tumor, and we found a small tumor on the right side as well. So this is a rare case. We have two other cases like this where we have been able to find two microadenomas. In one patient, it was prolactin secreting and Cushing's in the same patient. In this one, both stained positive for ACTH. So both were Cushing's microadenomas. You can see the post-op scan with normal pituitary, and this boy has actually just graduated at a US university, and you can see him how he has grown about 6 years later. The problem comes with giant pituitary tumors. Fortunately, they are not so very common, but prolactinoma is a common tumor in children. And this is one 13-year-old girl who presented to us with visual problems, and she had a prolactin level about 3000. She was started on medical management, and you can see that she had this kind of a field defect which improved remarkably, and you can see the gradual decline in her prolactin levels for about 6 months. And after 6 months they started rising again, and by the time she came back to us, it was already back to 1296, and the tumor and her vision was getting worse. And at this time, we had to step in to go for surgery. You can see a fairly large tumor going into the right cavernous sinus and going into the third ventricle. And before we discussed with the tumor board, who suggested that probably this patient will require a combination of all three, but surgery for debulking is probably the next step to be done. And we proceeded to do that. You can see the vascular encasement, which would definitely tell us that we cannot remove this completely. So this is where the sella has been opened. You can see that some of the tumor has come down into the sphenoid sinus, but you need to open the sphenoid sinus as much as possible so that you can instrument properly to remove this tumor. And therefore drilling of the base plate of Wurmer is very important, so that your suction and your forceps can go without too much of obstruction. And the tumor we have started removing the tumor. Now we are seeing the area of the cellar floor, which was not so much eroded. And then we have maximized our opening. We have gone beyond the tuberculum, as you can see here, and we are here into the anterior cranial fossa. This is what is required for an extended kind of exploration for a giant tumor. The beauty of this is that with endoscope, you can beautifully see the normal gland, which is at the back. It is plastered at the bottom and at the along the clivus, and rest of the tumor is sucking out nicely. So in that sense, we were lucky. We continued removal of the tumor further, as you can see, and you can expose more and more of the normal gland. Then you go towards the cavernous sinus, remove the tumor from there. We are then removing the tumor from the other side of the cavernous sinus, and then getting up to the top of the clivus, and that's when we start removing the tumor from the top, so that the diaphragm doesn't fall early and create issues with tumor removal. I have lost the video somewhere, but you can see now that when you start removing this tumor from the top, you can start seeing the optic apparatus, and then you start removing tumor from which has gone above the diaphragm, and then you are slowly entering into the third ventricle. Two suction technique works quite well. If the diaphragm is prolapsing down, we like to hold it up with a swab stick, which works as a nice retractor. You can use it like a patty with a good control. As the swab stick, you can hold in your hand and maneuver it, and the last bit of tumor are coming out from the third ventricle. You can start seeing foramen of Monro on both the sides and the choroid plexus. We know that there is some residual tumor in the cavernous sinus, but most of the midline tumor has come out. Sorry, the postoperative picture seems to be missing, but we got a good removal. I followed this by putting the patient back on cabergoline, but she also received complementary radiation at this time. So pediatric pituitary tumors have been treated now with endoscopic endonasal approach in some centers, and this is actually Dr. Locatelli has written about 4 centers from where he has collected the material, about 27 patients 18 years or younger, and reported satisfactory results despite the technical difficulties, and a good outcome. Dr. Prevedello and his team has also written about this being a satisfactory procedure for pediatric pituitary tumors. And you can see that transsphenoidal surgery can be now extended to craniopharyngiomas, as we have seen that you can take out larger tumors. And the first descriptions were by Dr. Jain, Dr. Laws, and then Dr. Locatelli also reported from Europe. We started doing this in about 2009, and we initially limited ourselves to predominantly cystic and salar, what we call infradiaphragmatic tumors, as you would see in this young girl. This is a 13-year-old girl who presented with this kind of a tumor with a little stunted growth and beginning of diabetes insipidus. So you can see the sella has been opened. We have exposed the tuberculum sellae, but this looks like an infradiaphragmatic tumor, so no need to do a proper extended approach. You go ahead and start drilling the sella once you have seen the tuberculum. And this is very important, the kind of septae you get, and you will find that this septum is taking you to the carotid here. So good exposure of the cellular floor is absolutely necessary. And then we usually like to eggshell this and then remove it towards after removal of the drilling of rest of the thick portion. And then you can see that I want to get into the corners. We are making sure that we have gone almost up the carotid on either side by use of Doppler. And then you can see that this constriction is the anterior intercavernous sinus. So what we are doing is we are taking one incision below, one incision above, and then we ligate the sinus to make sure that you do not get bleeding from the anterior intercavernous sinus, which can be quite troublesome, especially in children. It is important to open it in the midline, because laterally, if you go, you can interfere with small branches of inferior hypophyseal artery, which supply the optic nerve and the chiasm. And as far as possible, you should try and preserve them. You can now see that the cyst wall has been opened. It's a thick cyst wall. This is the kind of material which you get when you get inspissated cholesterol, and sometimes you get thin wall, but in craniopharyngiomas, usually you get a fairly thick wall. and you can now start separating the wall after you have finished the decompression, and the wall is nicely being uh, cleaned up from the pituitary, which is lying at the back and along the diaphragm. You can see the diaphragm is falling very well, and this is a sharp dissection to make sure that you keep the diaphragm intact and get the cyst wall almost completely out. We have been able to achieve that. The last bit is coming out, which is still attached a little bit to the diaphragm. So we know that a small uh, capsule remnant may be there, but it looks more like a gliatic vein, and we do not get any CSF in a typical infradiaphragmatic craniopharyngiomas. This is the child at 3 months age, but because we said that we have left a little bit of capsule, this child has had a delayed fractionated LINAC radiotherapy. This is a classic example when you can see the pituitary is plastered at the back along the clivus. There is a large cystic component, and this is the best way to go because the lie of the craniopharyngioma is such that transsphenoidal approach works the best to go into the longitudinal axis of the tumor. Again, the same thing, you're opening up below and above the anterior intercavernous sinus, ligating the anterior intercavernous sinus, opening in the midline, and then most of the calcium has actually come down into the anterocranial fossa just above the sella, and we are able to open this enough to get to the anterior margin. And then once the calcium has come out, the capsule is being now separated with the tip of the suction. It is important that we use graduated suction. So the suction is applicable only when you put your thumb on the suction, otherwise it works just like a dissector. And this kind of modification is necessary to do in this technique. This is a girl about 1 year after surgery, and we think we have been able to do a reasonably good excision in this patient. I was talking about well aerated sinus. In this is a patient where 8-year-old, where there was a tumor which is cystic plus solid, and if you look at the CT scan, you will find that there is completely non-pneumatized sinus. And in such patient, with the use of navigation, it is possible to go from anterior to posterior intercavernous sinus. The 4 blue lines guide you, which was a very good way where we could demarcate this tumor and could remove it completely. And this is a post-operative MRI at 1 year, which shows that the whole lesion has come out. If the stalk is good, you can go even lateral to the carotid artery, which is usually not recommended. But in this patient, as it was predominantly cystic and there was a very wide neck, we thought we should go ahead with a nasal approach. And you can see that we have been able to save the stalk. And this is the suprasellar component of the tumor, which is now being dissected off. Very thick wall being dissected off from the optic apparatus first, then the third ventricular floor. And once we have removed the sellar and the suprasellar component, now we are looking at the component which is going laterally. So we maximize our incision laterally. Once you have seen from inside, you can be sure that you are not damaging the superior hypophyseal artery. And now the capsule is being gradually pulled out from the side. It is coming down nicely, and it has been possible to remove this further. And if you look at this afterwards, you will find that we have been able to keep the stalk intact, and we have opened up the sylvian fissure actually through here with the large gap, and you are able to see actually the carotid the middle cerebral artery quite well with a 30-degree scope. This patient has had a very good excision and remained quite asymptomatic for 6 years, but then had a small nodular recurrence and was given radiotherapy. So I think the key lessons which have been learned and which have been very well described by Capabianca is that it is a straight route. It gives you a very good longitudinal access, and you have to be very, very clear about the anatomy, which is should be preoperatively examined properly, and other principles of treatment remain the same, especially the dissection from the hypothalamic interface. Some patients we have used a little different approach. This patient, 9-year-old, came to us with acute clinical presentation with early morning headaches, vomiting, relieving headache, typical raised intracranial pressure signs. There was the boy was drowsy, irritable. When we saw him, there was severe papilledema, and you can see the reason that there is a cystic plus solid tumor, which is causing obstructive hydrocephalus. And rather than putting just a EVD, what we thought was, till we get this child investigated, we will first put up the endoscope. We started the child on steroids. We went for an endoscopic aspiration of the cyst, which is lying at the dome. You can actually open that nicely. We have done a septostomy first, so that if at all there is any CSF diversion is required, you don't have to put bilateral shunts. So this is one strategy which we use, as well as we will now, once you have made a good enough opening, made sure that you have gone into the opposite ventricle, then we are coming back for the cyst. We have made a small opening and we are putting a ventricular catheter there. You can shorten this catheter because occasionally the holes come into the, after the cyst collapses, it comes into the ventricle, and several times you find that, especially if you are going to use intracavitary treatment. And the child immediately improved after that in his level of consciousness, became more cooperative, was completely worked up for hormonal levels, etc. We did a CT which showed that he had a precellar or a conchal kind of a sphenoid sinus, but it wasn't too bad. We had to drill about this much of solid bone before we could get full access, but we thought it was easily approachable. And you will find that after 3 days, he was taken up for a definitive surgery. When we went from carotid to carotid, started removing this tumor, the normal pituitary is seen at the back. You are working in front of the pituitary. You are trying to maintain the pituitary stalk, as you will see later, which is above and behind. We are trying to get the solid portion of the tumor down. The cyst has been already decompressed, as you have seen 3 days earlier. Once this calcium comes out, it becomes much easier to dissect the capsule from the surrounding structures. Again, a blunt dissection with the suction tip, which works as a very good dissecting equipment. Very occasionally, you require a sharp dissection, like on the one side where it was quite badly stuck to the surrounding structures, and calcified components have also come out. One of the important findings we have seen now, we have more than 20 cases where we have used this approach, is that the capsule peels off very nicely once you have decompressed it from the top. And now we start seeing our catheter once most of the tumor is coming out.
Excuse me, Dr. Diapujari,
Yeah.
5 minutes, okay?
Okay, so I then need to go a little fast. The complete excision of this lesion, 3 months later, you see that the lesion is completely out. The fat packing can be seen. And on contrast, there is no residual tumor left. So this combined approach for a large tumor with cyst, we have found very useful, and we have written up our experience of first 20 cases here. I think other supracellular lesions have also been tackled in this way, and we have treated now 57 patients with about 65 different kinds of surgeries. 11 of these cases are under 4 years, under 12 years, another 24 cases, and 13 to 18 years, 22 cases. And these are the various lesions which we have treated. Primary endonasal surgery has been performed in 54, redo endonasal surgery in 7, redo endonasal CSF leaks in 6. So altogether 67 procedures. This is a Rathke's cleft cyst, where what we have started doing is, once you have tried to decompress the cyst first. Once you have decompressed the cyst, this cyst has more inspissated material. Then what we do is, if there is no CSF leak, we actually put a mucosal flap. The surrounding mucosa is created as a passage for, if there is any further collection, it would drain out outside rather than inside. And this is a post-op 6-month scan which shows a complete removal of the cyst. And this is now being recognized as a good way of treatment by a couple of other groups. Another patient, if you have a CSF leak, of course, you cannot do that, and then you need to repair it properly. This is another Radke's cleft cyst coming out nicely. You can see that the stalk is preserved and the bottom of the cyst is being separated from the pituitary. That is at the level of the stalk. And this has now completely come out. But then you require a proper flap repair in such patients, which is being done now at the end of the removal. There's a last bit of cyst wall coming out. And we actually put the bone back whenever possible, if it can fit nicely into the same slot, or we take a nasal septal cartilage to repair that. We've written up about our experience of some 30 odd cases in world neurosurgery. Suprasellar epidermoid is another surgery which can be safely done. This, with the silver dissectors, we try to get this cyst out almost completely and decompress the optic pathways. 100% removal can sometimes be difficult. It is badly stuck to the arteries, but in this child, we could manage to remove it quite well. This is a rare case of a meningioma from the clivus, top of the clivus, and we could not only remove this, you can see a beautiful ventral demonstration of the brainstem after removing this. So I think evidence-based review by Dr. Liu and colleagues have also shown, they have actually looked at 93 studies, 574 patients, and they have found that this is an effective way and a safe way. I will just talk about a couple of other indications. One is a residual compression, ventral compression from odontoid. This is a child where we have been able to do that. So we do a combined endonasal and transoral surgery to drill this out, as you can see, and eventually the tectorial membrane pouts out and you get a complete excision of the craniovertebral junction, again described by our group in World Neurosurgery. I think endoscopic endonasal surgery has proved to be a safe and feasible approach for the management of a variety of skull-based pathologies, and optimal outcomes are expected. In very small children, we now have, as I told you, about 10 cases under the age of 4 years. And this is actually an 11-month-old child with a sphenoethmoidal encephalocele, which was not only excised but properly repaired. You can see a flap which has healed nicely. And we have described a good healing of flap in about 4 patients. Same thing has been described by Lucknow group as well. And you can see a nice healing in these patients. So I would end up by saying that pediatric endoscope is absolutely necessary. Micro-ear surgery instruments, till we get well-designated instruments for pediatric use, may be used for this kind of surgery. And the partnership with a good ENT colleague and a craniofacial colleague is really important, because sometimes in very young children, you may get, we have had only one patient where we had to do what should you say, a repair procedure for the nasal bridge in a child whom we had operated at the age of about 8 months. Postoperative care can be difficult, especially to prevent synecdoche. and therefore the important need to be told to the family about at least 2 to 3 cleanings under GA will be required after surgery, and saline spray should be continued for 2 months. We have written up about our experience of first 50 cases, and it is available in child's nervous system. Thank you for a patient listening.
Okay, thank you very much, Chandra, and thank you for all your continuing efforts to educate online around the neurosurgical world. We're a little tight on time, so if you have a question for Chandra, please post it in the chat box. And we're going to move along to the next talk with Michael Sugru, neurosurgeon originally from Oklahoma, and now he's in Australia. And I'll let Noor do the proper neurosurgical introduction. Hello, Noor.
Hello there. Yes, I'm here. Thank you so much, sir, for the wonderful talk. We are honored to have you, and we are really pleased to introduce our next speaker, Dr. Michael Sugru, who is an associate professor of Prince of Wales Hospital and Community Health Services, Sydney, in Australia, and he has got some special interest in minimally invasive surgery. We are really honored to invite him today to talk at this webinar on the updates on neurosurgery. So thank you so much for coming, and kindly share your screen now.
Can everyone see me?
Yes.
Okay, great. So today I'm going to talk about intracerebral surgery, and specifically, how do we reduce the cognitive damage we do during intracerebral surgery? So when we remove a tumor like a glioma from the supratutorial brain, what we're trying to do is to make the scan on the left look like the scan on the right with the fewest number of problems possible. Now, most of us have a pretty good idea how to prevent hemiparesis, and language mapping has shown that we can preserve language in most of these cases. But what we're not good at is preserving cognition, because in part, we don't understand how the anatomy of it is. And ultimately, when I trained at UCSF, and I think I got very good training, I was taught that there were eloquent parts of the brain and non-eloquent parts of the brain, and you wanted to stay in the non-eloquent parts of the brain and not cut the corticospinal tract. Now, this is all pretty good advice, but it doesn't get you everything you would hope to have. For example, we have a lot of people who have neurologic or cognitive problems that we don't have an explanation for. And a very high percentage of patients have depression, around 90%. And while you might think it's depressing to have a glioma, this is far in excess of pancreatic cancer, which is an equally bad prognosis. So it isn't just a bad prognosis that's making people depressed, it's something we're doing to their brain. Now, ultimately, when we talk about the term oncofunctional balance, what we're trying to do is to first get the tumor out, because if we don't control the tumor, like on the patient on the left, because we're trying to be dainty and avoid any sort of neurological problem, that's not realistic, because this cancer has already caused some of these problems. So we have to get the cancer under control. But there's an important point. While extent of resection matters, it's not worth it. It's not that beneficial to the patient to push the boundaries of the tumor on the right to get one more cc of tumor. The survival benefit is not so great. This is not a cure. And so if we leave this patient aphasic to go from 98 to 100%, we're not doing them a favor. So there's a point we need to stop where it stops becoming in the patient's best interest. And when we tried to think about how do we preserve cognition, I found that there really wasn't a lot of good advice. So when people say that stay out of eloquent areas, that's a great idea. But what about the rest of the brain? It didn't just appear there for no reason. It's not there to suck CSF. And alternately, when people say everything is eloquent, we know that's not true either. I mean, everyone here who's done more than one brain surgery knows that there are trajectories you can take into the brain and parts of the brain you can remove, and the patient's basically fine. So we know that not everything is eloquent. And ultimately, what we need to do is to understand the brain better and to adjust our thinking as we learn where to put the boundaries. So I've written a paper and have given this talk for a while now about how to reduce the cognitive footprint of brain surgery. So the first thing we could do right now is to minimize damage to large-scale brain networks. We can also begin to think about the brain as a global computer and utilize other techniques to learn about where in the brain we should focus. We can use artificial intelligence. I'm only briefly going to talk about this. And finally, we should acknowledge that we can actually change the connectome with non-invasive brain stimulation, and we should do this. So when they say the term network, this is new to neurosurgeons. It's not new to neuroscientists, because they've known for years that there are parts of the brain that are not next to each other. that when you look at their activity pattern, they're not identical, but they overlap a lot. And when we look at the brain and we say, how many networks are there? Well, it turns out there's about 7. So some of these are familiar, like like vision and sensory motor. But we also have networks like central executive, that's in orange, default mode, that's in red, salience in pink, dorsal attention in green. Now, we might wonder where things like language fit into this scheme. And ultimately, if we change the threshold, networks break apart. So for example, if you look in the upper right, the sensory motor system has a face motor part and an arm and leg part. But the default mode network also splits. So if you look on the far left, you see that language is part of the global DMN, but it's actually closer to itself than it is to the core of DMN. So for example, if you look on the right, the parts of the brain in yellow are the core of the default mode network. If you look at Broca's area and Wernicke's area, the language areas are basically closer to themselves than they are to that yellow area in activity. So this gets very confusing because there's lots of ways you can define networks. And so what we began to call it was the big 5 non-traditional eloquent networks. These are the core of these networks. So the default mode network, the salience network, and the central executive network, we call these the control networks, and the dorsal and ventral attention network. These are the attention networks. Now, how we find these really requires artificial intelligence. There's no easy way to do this any other way, in part because if you look at the anatomy of something when we look at the whole brain DTI, this is too complicated for us to learn everything that's in here. All these twigs mean something, but we only know what a few of them really do with the naked eye, like the corticospinal tract. So this is why tractography hasn't really revolutionized our practice. It's been helpful, but part of the reason is we're not really using all the information that's there. And when you look at things like fMRI, we also need artificial intelligence because this is the raw image. It's not very useful. But even if I showed you that at that crosshair, that's the activity signal, and that's happening at hundreds of thousands of places in the brain, well, that's still not very useful. But what I'll show you is you can find some really important information out. Now, when we start looking at really complicated data sets, it's necessary that we simplify this into what's called dimensionality reduction. This is the easiest and best way to dimensionality reduce the brain, which is parcellated. Now, parcellating means we divide the cortex into different areas based on what they're doing. Now, Brodmann did the first one of these. So that's the first parcellation scheme that really had any traction. But this is a more modern one from the Human Connectome project done on my brain. And every time you see a change in the area, this means that those two areas are doing slightly different things. And so we spent many years studying the scheme, in part because if you look at the scheme, it often we see that there are important areas that sit inside sulci or cross onto 2 gyri or tucked into clefts of the brain that we don't normally look at. And what it taught us is that the brain does not care that we call this something the superior temporal gyrus. That's not how it's organized. It's organized like this. And so what we began doing when this paper came out is writing anatomy papers. And this got so out of hand that we eventually had to put it into a single issue of neurosurgery because there's so much information here. Now, in order to leverage this, what we have to be able to do is to figure out where on an individual's brain these areas are. And more importantly, we have to be able to do it in a brain that's distorted by tumor. So a few years ago, we made an algorithm that now is the basis of an FDA-cleared software. It's also cleared in Canada, Australia, India, South Africa, and soon the EU. And what it basically does is it looks at the whole brain DTI and readjusts the boundary of these regions to address the fact that a tumor may have moved things. So, for example, the algorithm knows that voxel belongs to Broca's area because it connects to Wernicke's area, and this one doesn't. Now, if we have a patient with a tumor, it knows that there can't be Broca's area in the middle of the necrosis because there's no tracks. And so what it knows that it needs to move the boundary somewhere else. Now, what it allows us to do is to study a patient whose brain has been so distorted by tumor and surgery, for example, this patient here where we've removed the frontal lobe, that it still can find the basal ganglia, can find brain regions. And that really brings to the forefront that we can map brain networks. We can see them and we can preserve them. So for example, we've known for a long time that butterfly gliomas are bad. And if you go in there and just take out the tumor, there's a fairly high chance that the patient's going to be worse for that. But why? Because we cut the corpus callosum all the time. Well, some of it is the fact that these tumors dumbbell into the brain. But even if they don't, let's say they're only located in the corpus callosum, which some butterfly tumors are, these tumors make a 270-degree bend around the default mode network. And that's not one of the most important cognitive systems in the brain. So of course, if you damage that on your way to the tumor, the patient's not going to do well. We can begin to then start to think about tumors like insular gliomas, which basically have tugged the language system, the corticospinal tract, et cetera, as a series of disconnections. So instead of going in there and just sucking blindly with the CUSA, we can see the networks and preserve them. Now, sometimes we can't. So in this particular case, when we look at the fact that this tumor is wrapped around, not only wrapped around the default mode network, but has the salience network fibers, if you look at the bottom, wrapped around the tumor like a ball, then it's really unlikely that we're not going to cut something, at least somewhat important. We can save a lot of this, but there's likely to be some consequences. But at least now we have an idea what those consequences are. We kind of know where we should be aggressive and where we shouldn't. And so what we've begun to do is to annotate the connectome. So when I was in college, I worked on the Human Genome Project a little bit, and they always talked about annotating the genome. I mean, figure out what all these things do. So what we did, and we spent the last roughly 10 years mapping areas to this atlas. And so what you do is you take everything, every piece of paper, every paper that's ever cited a point in the fMRI literature, you map it to these areas, and now you have a map of network. I can't go through everything we've studied. We've written over 50 papers on this now, but I'm going to talk about the area that's probably the most useful to neurosurgeons, which is the control networks. Now, this is not new to neuroscience. There are thousands of papers on this. It's just new to us because we haven't been keeping up with this literature. But what the neuroscientists have shown clearly is that there's an interaction between the default mode network, which is what's on when you're thinking to yourself, the central executive network, which is what does things externally, and the salience network, which is the switch between these two networks. And these networks control other networks, the DMN being located predominantly in the posterior cingulate, the anterior cingulate, and the lateral parietal region, the salience network being a middle cingulate and anterior insula network, and the central executive network being a three-part network as shown here. Now, we know a lot about this, and we know that the control networks cover a lot of cognitive processes that have been linked to this. And more importantly, damage or dysfunction of these causes mental illness. In fact, it is the cause of mental illness for the most part. And so while we don't totally understand mental illness, we know these networks play a key role in it. Now, if we begin to look at the how these networks talk to each other, we can begin to start to answer questions like, what happens in the medial frontal lobe to people who have akinetic mutism? And you can see how these networks articulate with each other. They also notice that the SMA is not really a motor area. It's a cognitive area around the motor system. And so we can begin to think how damaging this would prevent you from leaving the default mode network world of thinking to yourself and turning on the active world. Now, again, it isn't just our theory. There's actually a paper in PNAS showing the same exact anatomy. So we call this the initiation axis, and damaging this is like damaging an eloquent part of the brain. There's also networks called attention networks, and they do interesting things. So the dorsal attention network keeps your attention on a task. And when you damage it, your IQ drops, not because you become less intelligent, because you can't focus on the task. And finally, the ventral attention network, which is right-sided only, is the neglect system. So how do we use this information? Well, we're cutting next to these networks all the time. So just because we don't know about them doesn't mean that they're not there. They've always been there, and we've been cutting across them for a long time. Now, what evidence is there that we should try to not cut them? It's possible that it's fine. We know that probably we're doing something wrong in people, but how do we know that these networks specifically are good, important things to not cut? Well, I reviewed the literature recently for submitting to the European Union for a medical device. And ultimately, I found in the last 10 years There are over 1,300 research papers showing that damage or dysfunction of one of these networks causes a cognitive, emotional, neurologic deficit. And this is across many, many disease states. So it's replicable. So while we can't say that cutting it in your individual patient will cause a problem, it seems like a good thing to not do if you can avoid it. And tractography, while it has some challenges, there's brain shift and whatnot, is a useful tool to protect things that are near your tumor. At least gives you an idea and a reasonable chance of not damaging it. If you don't have any idea where a tract is, you're more likely to damage it. And what we found is that if you look at insular gliomas and insular opercular region tumors, about 77% of the time, one of the known eloquent areas is next to the tumor, which is not surprising. But when we begin to look at the non-traditional eloquent areas, meaning the big 5 networks, they're in the tumor 98% of the time. So we're always encountering these. And when we begin to look at skull-based surgery and interaxial surgery, we know that skull-based surgery is very difficult technically, and there's a lot of risk. But one advantage that skull-based surgeons have is that the anatomy is completely known. It's visible to the naked eye. So we don't know, as far as we know, there's no invisible 13th cranial nerve that we've been cutting. Whereas we don't see any of the things that are important in this patient on the right. And so this is really the challenge of interaxial tumor surgery. We need to put anatomy where we don't see it. And there's a lot of evidence that tractography can help us do that, including a couple of randomized controlled trials, but also just a preponderance of the evidence. This is actually a small number of the papers. And so when I began writing a book about this many years ago, what we were trying to do is say, given what we know about networks, what are safe cuts? So for example, if we have to remove the frontal lobe, where should we stop? And recently we began to build this into a software called QuickTome. Again, I pointed out it's cleared in multiple jurisdictions now. And what it basically does is you tell it what part of the brain you're operating in, and it basically makes objects to put on the image guidance so that you won't hit them. And as people begin to work with it, what we found is that many times the shortest path into the tumor is the wrong one. So for example, in this tumor, that blue arrow shows you the shortest path, and it goes through the dorsal attention network. So a longer path is better. But also when we begin to do really big operations on a big tumor like this, instead of us thinking about this as this indiscriminate blob that we're here to suck out, it's actually better to think about it as a series of disconnections with networks. We may not be able to save all these networks, but the reality is it's important to note that we're not doing biopsies. We're doing aggressive resections. But you can see here, if you would go in there and take out the basal ganglia or take this tumor out of the default mode network to get a little bit more tumor, it's hard to say these are good moves for the patient. Now, when we begin to think about cognition, it's possible that there's other things here, because higher cognitive functions like math are multi-network functions. And we start thinking about how all the networks can interact, this becomes really complex. And so one way to look at this is to turn the brain into a giant math equation called a graph. So it looks like this. So what you do is you take the DTI, you parcellate it, and you make a calculation of how much every area talks to every other area. And I'll show you two things that we've learned by studying this. We've published a lot of papers on it. The first is hubness. So if you look in this diagram, the guy on the right is the biggest hub on this cartoon because he's connected to the most parts of the brain. And we know hubs express different genes. They're more susceptible to Alzheimer's, and they use energy differently. So they're different parts of the brain than non-hubs. But who are the hubs? So we studied this and published it several years ago. And what we were just trying to say is, who are the hubs? Well, this is the top 10. And you might not know what all these words mean, but those guys are what we would call eloquent. These would get you the score in the Spencer-Martin scale. These guys should get you the score, but they weren't in Spencer scale. And the bottom line is hubs are eloquent. The next question we asked was, how often does someone have a hub where other people don't have a hub, an unusual hub? And without going into too much detail about this paper, which you can read, the answer is 7%. So 7% of people have a hub in the wrong part of the brain, meaning in the frontal pole or some weird area. And are these the people that we make worse with surgery when we think a minor surgery in the frontal pole is safe? It may not be for some people. Another question is when we talk about how the brain interconnects is what's called path length. So if I was trying to go from those two places, that's the shortest path. But if I remove it, that's not the shortest path anymore. It's a different path. And we know that path length matters because the shorter your paths are in your brain, the smarter you are, the higher your IQ is. That's been shown multiple times. So what we did is we did an experiment where we basically took the brain and we calculated all the paths and measured a thing called global efficiency. But then we made an algorithm that ran every reasonable brain surgery. We didn't take out parts of the brain on opposite sides of the brain. We took out things that were next to each other. And we did every conceivable surgery to that graph and recalculated global efficiency. Now, what you can see here is this is us doing brain surgery, every possible brain surgery that was reasonably possible on hundreds of individuals, and they all look like this. So what this means is, for example, if you look at that little sawtooth, each one of these lines is a different operation. And you can see that there are operations where it'd be better off to take off more parts of the brain than do an operation where you remove less, but remove certain bad areas. So we spent 3 years trying to figure out how that worked. And this is what we found, which is under review currently. And it ultimately is that there are some parts of different patterns of individuals, we call them connectotypes, that where we can predict ahead of time what is the worst area in that individual. And it's not the same in everyone. So again, this is another reason why artificial intelligence will be necessary for us to really keep pushing this boundary forward. Finally, let's say we cause a deficit, or we know we're likely to cause a deficit. Well, it turns out that there are tools that we can use right now to begin to reorganize people's brains to help them heal quicker. So if you're not familiar with TMS, you need to become familiar. It's been around for 30 years in psychiatry. And what it does is it repeatedly stimulates the brain with a magnet. And what you can see, it makes kind of a field like this on the right. That red area is the area of maximum stimulation. Now, while it delivers a field, you really need that red area over what the target is, what the most important area, because that's the only thing really getting treatment level dosing. And people were afraid for a long time to do this in post-craniotomy patients because of the risk of seizures. I can tell you right now, we've done hundreds of people. We've never had a seizure. This group here in Germany recently published a randomized controlled trial. And what they showed is a profound benefit to doing this in people who have postoperative hemiparesis with a number needed to treat of 2 and a increasing long-term benefit. So the fact of the matter is, this is what we've seen as well, though obviously not within a randomized trial. So we should be doing this. But then the question is, if we want to go past just motor weakness, how do we even aim the thing? Where do we put this? And we can look at resting state connectivity. And what these red squares are, you can see all these little areas. These are different parts of the brain, different parcellations. These are the same areas. And each square tells you how often they're talking. And in a normal person, the language system is a network. So it's going to be red because it's highly correlated. These areas are firing together. On the right is a patient with a glioblastoma in the arteriovasculus, and it's blue because the tract is gone. So the areas aren't talking correctly. Well, that's pretty interesting. We can see aphasia, but that is that part of the brain. So we can basically pull that out, stimulate it, and try to make it better. This is a patient that we did that on. This is not a tumor, but an MCA stroke. She's a 1.5 years out from the stroke, has significant language problems. And when we studied her, what we found is that the only thing still communicating with what's left of Broca's area is the right SMA. So we stimulated that. And 4 months later, she grew tracts to the other side. But more importantly, her language improved to the point when she could attend college again. So that's a pretty significant benefit for something that's extremely low risk. So the future is ultimately utilizing adjuncts to begin to figure out how the brain is working and determine where do we aim our therapies to try to take control and wire the patient in a way that's beneficial for us. So thanks, everyone.
Okay, thank you very much, Michael. You know, there's a couple of questions in the chat, especially from Uday.
Yes. So what I'll, as far as it goes, if you look me up on ResearchGate, most of my papers are on there for free.
Okay.
So you can find a lot of that. I've also written an entire textbook called the Glioma Book, which will get you a long way there. And as far as tractography misleading us, The answer is that while there are false positives, if you use what's called tract filtration, you can often reduce that problem. And the reality is, while there might be some fibers here and there, for the most part, if you've done tract filtration, the gross anatomy is pretty reliable. And so I will say that you can't trust anything blindly off the cliff, but it's not bad. And I would ignore it at your own risk.
Okay, Michael, you can leave your email address if you want with Uday in the chat. Thank you very much for taking the time. Sorry it was inconvenient for you. Thank you very much.
Thanks for letting me go early, guys.
Okay, very good. Okay, we're going to proceed on with the next speaker, Abdul Rana. He's a neurosurgeon. Abdul, are you there? I'm going to make sure he's here first. Hello, Abdul.
Hello, John. How are you doing?
I haven't seen you in a couple of years.
Of course.
How you been? I'd like to introduce Dr. Abdul Rana. We've done lots of videos together in Parkinsonism. We did 60 videos at one point, very quick videos, 10 to 15-minute videos answering questions about Parkinsonism. And they are our best viewed videos to date, Dr. Rana, on our channel. So, okay, Dr. Rana is a neurologist from originally from Pakistan. He's in Toronto. I don't know how long he's been there, but I'd like to welcome him and thank him for taking the time. Welcome, Dr. Rana. It's all yours.
Thank you so much. Thank you, John. Well, because of the time, I'll be speaking about the management of Parkinson's. Can everyone hear me?
Yes.
Sure. Yeah. So as we know that Parkinson's has motor symptoms of bradykinesia, rigidity, resting tremor, and postural instability, and non-motor symptoms. The list of non-motor symptoms of Parkinson's is every day increasing, and there has been many descriptions in history about the non-motor symptoms of Parkinson's before the description of the classic Parkinson's disease in 1817 by James Parkinson. So the list of non-motor symptoms is quite lengthy and includes some of which, like facial masking, loss of sense of smell, depression, anxiety, panic attacks, speech and swallowing problems, drooling, dizziness, fatigue, memory issues, cognition, as well as visual hallucinations, sleep problems, urinary dysfunction, sexual dysfunction, constipation, you name it. So I often say that there is no system of the human body which is not affected by Parkinson's disease. And in 2012, we decided to review the literature, and we came up with this handbook of 50 ways Parkinson's could affect you.
Excuse
And
me,
then
Dr. Rana, are you sharing a screen share? We're not seeing a screen.
Oh, really?
Yeah.
Okay, let me.
And thanks for alerting me, Dr. Benally.
Okay,
Sometimes I'm not sure if people are screen sharing or not.
I don't know what is wrong with this.
Okay. Zoom is kind of acting up today. I don't know what's going on. Yeah, just screen share at the bottom. You know how to screen share, right?
Yeah, I'm clicking it.
Yeah, okay. For some reason, Chandra had problems too with the screen share.
I have no idea why it's not working.
Really?
So
Do you want to email me the presentation? I can screen share it. It's a PowerPoint, right?
there's some patient videos, so I unfortunately can't share these with
Okay,
anyone else.
whatever you want to do. Whatever you want to do.
Or we can just make him, we just report him into the attendee and then make him a panelist again. It might help.
Okay, try. That's worth a try.
Yeah, sir, I'm just putting you back in the attendee list and then I will promote you.
So he
again
needs
as
to
panelist.
leave the webcast and come back,
Yes.
right?
Yeah.
Yeah,
No, even if he does not leave it, I just put him in the attendee list and then make him a panelist again. Or you can do that. You are the
Yeah,
main host, you can do that. Yeah,
It's
please
probably
do that.
sound advice. I can't understand that, Dr. Ron. Do you understand what she's saying?
I do it. I try to do
Okay.
it. I don't know if I can, but I try to do it. Just wait a minute.
You're trying to remove him and bring him back, right?
Yeah,
Oh, there he goes. He's off. Okay.
Yeah. So I can do
Okay.
that.
I think
Okay,
he
yeah.
understands and he's going to come back, hopefully.
Yeah, exactly. So there's some problem that's taking place. I don't know what's happening.
Yeah, there's problems today with Zoom with screen sharing.
Yeah, exactly.
So
No, there is,
he's the second one that's had a problem.
but he's gone now. He's not in it again. You know. Can you see him in the attendee?
I'm looking for him now.
No, I cannot see him. He's neither in the panel nor in the attendee list now. I don't know, but there's something going on with it with Zoom today.
Well, hold on. Let's wait a second here. We put Dr. Rana through the ringer here this morning. I'm sorry, folks.
I think he has left. He has. Do you have his contact? We can contact him again.
Yeah, I just he's starting clinic, and everyone can relate to that.
Yeah.
So we may just wait a second here. We may be moving on, Nor, but just give him a minute here.
Yeah. If we just try to give him
Yeah.
a little try so that he can just get back if possible.
Alvaro standing by, but Dr. Rana.
But he has left. I think he has left the Zoom. If you have his contact, then you can just ask him to get back
Yeah,
in.
we have to make a decision, unfortunately. Okay, why don't we move on? Okay, we're going to move on to Alvaro Campero. He's going to present next. Alvaro, are you ready?
Yes.
Okay, very good. I'll let Nor do the proper neurosurgery introduction. Hello, Nor.
Hi, sir. Thank you so much for having me here. Sir, thank you so much. It's a great honor for us to have you in our webinar today. Professor Alvaro Campero is a very famous neurosurgeon. Almost everyone of us know him very nicely, so he doesn't actually need that much of an introduction. So everyone who has got an interest in skull-based surgery and petroclival meningiomas are well known, as he's well known to them. Professor Alvaro Campero is the chairman of Neurosurgical Department of Hospital Padella, Tucumán, Argentina, and a full professor of School of Medicine of Universidad Nacional de Tucumán, Argentina. Sir has written several state-of-the-art very wonderful, innovative papers. And one of the very important works of Professor Campero includes the 3D neurosurgical videos. Many of us have seen them, have read that wonderful article and appreciated the wonderful concept. It's a great honor for us to have him and welcome him today in our webinar. So the floor is all yours now.
Hello, everyone. First of all, thank you very much, Same and his team, and also thank you very much, John, for the invitation. Could you hear me?
Yes.
Okay, perfect. So I'm going to talk about classification and management of pontocerebellar petrosa bridging veins in trigeminal neuralgia decompression. So we published recently this paper. Actually, it is impressed about the classification of that veins. So the objective of this class and also the paper is to study where and identify the veins that drain into the superior petrosal sinus and classify them in relation with the suprameatal tubercle and determine the implication of their coagulation in the trigeminal neuralgia surgery. So as we can see here, this is the trigeminal nerve. We can see also the superior cerebral artery in relation with the entry zone of the trigeminal nerve. Usually we have in this project, we have some veins that sometimes we have to coagulate, and we would like to know if we have some consequence about that. Usually in that portion of the cerebellum, and this is the 7 and 8 cranial nerve, we can see here the 5th cranial nerve, and this is the superior petrosal sinus. So we have some kind of vein that go from the lateral surface of the cerebellum and also from the brainstem to the superior petrosal sinus. So in this picture, we can see here the suprameatal tubercle. This is the 7 and 8 cranial nerve. This is the 5th cranial nerve, cerebellum, pons, and so on. So this is the suprameatal tubercle. So we classify the veins in posterior to the tubercle, at the level of the tubercle, or anterior to the tubercle. And the methods, the veins, like I said, we classify in 3 groups: retromeatal, meatal, and premeatal veins. And the neurosurgical postoperative complication scale, Landry et al., was utilized to assess complication from venous coagulation. So in this picture, we can understand better this is the premeatal veins near to the trigeminal nerve. This is the meatal veins at the level of the suprameatal tubercle, and this is the postmeatal vein posterior to the tubercle. In relation with the results, we studied 28 patients that we operated in the last 3 years who underwent trigeminal decompressive surgery. In the retromeatal region, we find 7 cases with vein, and in the 100% of the cases, we sacrificed that veins because we have to reach the entry zone of the trigeminal nerve. In the meatal region, at the level of the meatal regions, we found 11 cases, and in 91% we had to sacrifice the veins. And in the premeatal region, 14 cases, more or less half of the cases we have to sacrifice the vein. But usually in the premeatal region, usually we can find 2 veins. So sometimes we had to sacrifice just 1. So with the complication, the post-op complication, 27 patients were grade 0, so without any complication, and we had 1 patient with grade 1B in the Landry scale, but just because of post-operative meningitis, nothing in relation with the coagulation of the vein. So no patient suffered vascular complication. I think it's better to show some idea or some concept with examples. So I will show some examples. Case 1 with the retromeatal vein. We can see here, this is the suprameatal tubercle, tentorium. All the patients we operate in the semi-sitting position. So we can see a retromeatal vein. We had to coagulate in order to access to the trigeminal nerve. We can see here the trigeminal nerve and the superior cerebral artery that is in contact with the nerve. And after we put the Teflon between the nerve and the artery above. Another case, also retromeatal veins. We can see a huge retromeatal vein. This is the suprameatal tubercle, tentorium, the vein going to the superior petrosal sinus. So if we want to access to the entry zone of the fifth cranial nerve, in our opinion, it is almost impossible if we don't coagulate and cut this vein. So after the coagulation and cut the vein, this is the suprameatal tubercle, the arachnoid of the 7 and 8 cranial nerve. Now we can see the entry zone of the fifth cranial nerve. Here the fourth cranial nerve and tentorium and superior cerebral artery. And after we put the Teflon between the nerve and the superior cerebral artery. Another case, retromeatal vein. We can see two big retromeatal vein. This is the tubercle. This is the tentorium. So we need to coagulate and cut in order to access to the entry zone. After the cutting of the vein, this is the suprameatal tubercle. This is arachnoid from the 7 and 8 cranial nerve. And here we can see a big compression of the superior cerebral artery. The artery is like here and then go like here. So it is indentated in the fifth cranial nerve. This is the fourth and lateral wall of the pons. So we mobilize the artery outside the nerve, above the nerve, and also we put two pieces of Teflon between the nerve and the artery. Another case of retromeatal vein. We can see here, this is the suprameatal tubercle, two small veins, tentorium. So we cut the veins. This is arachnoid. And now we can see a huge compression. This is the entry zone of the trigeminal nerve. This is the superior cerebral artery. And after we put the Teflon, the nerve below and the superior cerebral artery above and the Teflon in the middle. Another case of a retromeatal veins. We can see here a little bit more superior, but going finally to the superior petrosal sinus. So in order to access to the entry zone, we have to coagulate, in our opinion, and cut that vein. We can see after the coagulation, and we can see the entry zone of the nerve and an artery here. So at the end of the surgery, with the Teflon between the nerve and the artery. Let's go to the meatal veins. So veins at the level of the superior meatal tubercle. So we can see one here, two veins. This is the suprameatal tubercle, small. This is 7 and 8 cranial nerve with the arachnoid. So we cut and coagulate the vein in order to access to the nerve. We can see here a huge compression because vascular artery and also the superior cerebral artery, both compression with the nerve very compromised because the compression, and after we put the Teflon between the nerve and the artery, the vascular artery, and also the superior cerebral artery. Another case of meatal vein at the level of the suprameatal tubercle. We can see here a vein not posterior to the tubercle, at the level of the tubercle. So in order to access to the entry zone, we have to coagulate and cut. And after that, we can see, after cutting the vein, we can see the arachnoid at the level of the trigeminal cistern. This is the suprameatal tubercle. And now we can see an artery here. This is the fifth cranial nerve. This is the fourth cranial nerve, 7 and 8 cranial nerve. So here is the compression, but we can see also that we had two veins at the level of the premeatal region that we didn't coagulate and cut, because in that region it is easier to to keep the veins without cutting. And at the end, with the Teflon between the nerve that we cannot see now and the artery here and the two veins that we didn't coagulate and cut. Another case of meatal vein at the level of suprameatal tubercle. We can see the suprameatal tubercle. We can see a vein going to the superior petrosal sinus. This is the tentorium, and we can see a little bit the fifth cranial nerve. So we coagulate and then cut this vein and the arachnoid in order to access to the fifth cranial nerve. In this case, the patient didn't have a compression at the level of the entry zone, but has a big vein at the level of the vein that go into the Meckel's cave. So we put a Teflon between the vein and the trigeminal nerve at that level. Another case of meatal vein, so at the level of the suprameatal tubercle, we can see this is the suprameatal tubercle. We can see a vein above the suprameatal tubercle. This is the tentorium. So we coagulate and cut that vein in order to access to the entry zone of the nerve. And we can see here a huge compression. This is the trigeminal nerve and also the superior cerebellar artery. So we mobilize, first of all, the artery, and then we put a Teflon between the artery and the nerve. And let's go to some cases with vein just in the pre-meatal region. We can see here nothing before, so we can mobilize the cerebellum easy. So we can see two veins, one superior and inferior, but at the level of the nerve. This is the fifth cranial nerve, tentorium, arachnoid. We start to open and we coagulate the superior vein in order to can mobilize more medially and to access to the entry zone. It is very important to explore and watch all the entry zone 60 degree in order to avoid some compression that we didn't see. So we can see here, this is the vein that we preserve. This is 7 and 8 cranial nerve, and we can see here in the inferior portion of the entry zone of the trigeminal nerve a big artery, Ica artery, that performing the compression to the nerve. So at the end, we mobilize a little bit the 7 and 8 cranial nerve, and we can see the loop of the artery, the Teflon, and the nerve above the Teflon and the artery. Another case of premeatal veins, we can see two big premeatal, because this is the suprameatal tubercle, this is the arachnoid of 7 and 8 cranial nerve, but these two veins go in front, anterior to the suprameatal tubercle. So in this case, we open both veins, but usually we try not to coagulate the veins at the level of the premeatal region, because that veins come from the brainstem. So we can see also here, but also it is important to access and to explore in a good fashion the entry zone of the trigeminal nerve. So this is the trigeminal nerve, the superior and inferior vein, tentorium. We can see here an artery in relation with the superior portion of the nerve, and finally the artery above the Teflon and the nerve below. The superior cerebellar artery was that artery. Another case of premeatal vein. We can see here not vein before we access to that region without any vein before. But we can see here the tentorium, and we can see here some veins. This is the 7 and 8 cranial nerve, many arteries, one artery here, another artery here. We have some veins here with the arachnoid, but we have to access to the entry zone in order to see and to watch the compression. And look that with some medial mobilization of the cerebellum, we can see this is the artery. We cannot see, we see something here, but with some mobilization, we have, this is the artery that are compressing and disturbing the nerve. So we mobilize and put the Teflon between the fifth that is here and the artery that is above, and the Teflon in the middle, and we can preserve the veins at that level. This is the 7 and 8 cranial nerve. And another case, I think the last case, in the left side, we can see the tentorium and some premeatal veins. This is the suprameatal tubercle. So in front of the tubercle, and we can see here, this is the fourth cranial nerve, tentorium, and the superior cerebellar artery. And we start to open the arachnoid, one superior, another inferior vein, and we have some window here in order to access to the trigeminal nerve. And we can see here, trigeminal nerve and superior cerebellar artery. And finally, we have the nerve below, the Teflon in the middle, and the artery above, and with the good decompression. So in conclusion, I would like to say that we propose to classify the veins into retromeatal, meatal, and premeatal in relation with the suprameatal tubercle. The retromeatal and meatal veins can be, at least in our opinion, in relation with our paper and our study, can be safely sacrificed. But with the premeatal vein should be coagulated only if in just justified cases. So if we can preserve and work between windows, between one and the superior and inferior, because usually we have two veins, that is better. Thank you very much for your attention.
Thank you so much for the wonderful talk, sir. The questions will be posted in the chat section for you. And again, thank you so much for the very insightful talk. Now, we have to move on to our next speaker, Dr. Surat Sanjaya Manan Singh. Is he here? Thank you. Dr. Surat is a consultant neurosurgeon at the Ministry of Health, University of Sri Jayawardena in Sri Lanka. We are really honored to invite him today as our speaker. Dr. Surat, can you please share your screen?
Thank you, Nu. Can you hear me? Thank you, John. Can all of you hear me? Right,
Yes.
thank you.
Thank you.
Welcome, Sarat.
Thank you, John. Thank you for inviting me to this distinguished event, and I'm privileged to present my experience and share my experience with you. And I hope you can see my screen, John, is it?
Yes.
Right. Okay. So when you invited me to talk, give a talk on this updates on brain surgery, actually, as a peripheral neurosurgeon in Sri Lanka with working with poor resources, so I thought of talking about innovative neurosurgical approaches rather than updates as a single surgeon experience. Because in my practice, I had to change, or I had to look for alternatives because of several reasons. So today I'm going to share my experience with you on few areas where I have changed my practice. Actually, rather than change, I had to look for alternatives. So as you all know, people look for innovation because they need a better outcome in a certain kind of a procedure, or they look for novel techniques, or sometimes lack of resources in my case. So this is one of the favorite areas for me, ICH evacuation, which is, controversial. And especially what I saw in my country, in my part of the world, and especially in my area, there are a lot of patients presenting with hypertensive ICH, deep-seated ICH, supratentorial, where the mortality is very, very high. It is not 40 as mentioned in literature in my province, my area. It's maybe around more than 60, 70. And most of these patients being not managed properly. And even these patients, initially they come to the medical ward due to lack of accommodating facilities in the neurosurgical unit, and most of the time they are being mismanaged. And especially when we say conservative management, there is a question whether it's true conservative management, because we know conservative management is not doing nothing. There is I mean a lot of observation with HDU care, ICU care, which we don't have. So we don't have a proper care. We don't have HDU care, ICU care for these patients. So we are unable to identify the point of deterioration most of the time. So without any ICP measuring capabilities, and also with lack of theater time, so lack of post of care, so surgery under general anesthesia is not possible most of the time, anesthetist being not very happy to go ahead with anesthesia without a proper post of HDU ICU care, which I think very reasonable. So in Sri Lanka, we don't have a proper rehabilitation pathway as well. So most of the time we see these people die of chest problems, aspiration. So I had to find out a way. I had to look for an innovative way, which is quick and can be done even under sedation or local anesthesia, or if feasible under GA, with an acceptable outcome and with a minimal morbidity and without a post-op ICU or HDU care. So I had to send these patients usually to the ward post-operatively, sometimes at the tracheostomy. So this is what I did. So how I changed my practice was I was using this Burhall evacuation of deep ICH. I know the first the slide I'm showing you is not a deep-seated ICH, but I'm showing this every time. This was my inspiration. So this was a patient who was on warfarin, present with a GCS of 5. And the anesthetist did not want to anesthetize this patient because we did not have ICU beds. But I did this case under local anesthesia. So you can see it's a reasonable, bit bigger craniotomy I had done. And then, this is the post-op CT after 24 hours, and this is after 2 weeks. So this was my inspiration actually. So this video was taken 2 weeks after. She was GCS 4 or 5, as I can remember, and presented walking to the clinic in 2 weeks time. So it was an inspiration, and it was the turning point for me. So I decided on doing these cases even without GA sometimes, to save the patients' lives. And we were able to save so many patients' lives with this. So this is a bit sometime back, 2 years back when I started doing this. So initially I did a slightly bigger craniotomy or a craniectomy, and I didn't even put the bone flap back. So all these cases I have done. I will show you a few cases first, and then I will go into the discussion. So all these cases, hypertensive ICH, and as the time goes on, I reduced my the size of the craniotomy. This is another case. See, this is on admission. This is after 48 hours expansion of the hematoma, and this is after the evacuation with a small craniotomy. This is again 2 years back. So this is post-op day 10 CT. And as time goes on, I reduced the size of the craniotomy. So you can see it's been coming down and down. So, right. So then I will discuss about the technique a little bit more. So mainly the indication, my main indication for the surgery is clinical deterioration of these patients. And I usually intervene if the GCS is less than 9 because of the lack of infrastructure, as I mentioned you earlier, which correlates with the radiological expansion. And also when there is mass effect like midline shift, and also the ICH volume. And also I don't usually operate on patients who are more than 65 years of age. So I will give you some details of my technique. So as you know, I don't have the navigator or any other guidance. So I basically depend on my craniometric point measurement. So I would like to have a 3D image of the ICH, of the hematoma, depending on the CT, the craniometric points. So what I do is I identify the entry point and use it as the fulcrum. So the entry point can differ depending on the hematoma location. But I would like to prefer the starting point mainly in the posterior aspect of the hematoma, going from posterior to anterior, and also going from a point superior to inferior in a trajectory. So usually I start at the posterior third of the hematoma because depending on the head position, it is easier for a right-handed surgeon. So the approach could be at the transgyral or transsulcal. The problem with the transsulcal is you find the blood vessels. And usually in basal ganglia ICH, I usually try to go through the middle temporal gyrus. So as I mentioned, the incision is small, 3 to 5 centimeter incision, and the opening is slightly bigger than a burr hole, and open the dura in a cruciate fashion. And as I said, either transgyral or transsulcal, going to make a small cortical window, go through it, a very small window, and get into the cavity. And I use the sucker and the bipolar as my main instruments, and a lot of saline and suction. And with the bipolar, let the hematoma, let the blood clot come towards my sucker. And if I use the Rancho, if the hematoma is bit dense and bit hard. So the problem with this procedure is I had to move the microscope in all 4 directions because you are weaving through something like a tunnel. And most of the time you had to change the position of the table as well. I never use retractor forceps, but sometimes I use the sucker from one hand and the snake retractor from the right hand if it is necessary. And usually the whole procedure takes around 45 minutes, but I would like to have around 10 minutes for the hemostasis. And the bone flap, I usually don't put, if it's a very small, I usually keep it as a floating bone flap. I don't usually fix it. And you can see, this is the opening. And all these patients, I'm showing you, presented with a very, very low GCS. All of them GCS of less than 8. And you can see you don't need to take the whole clot out. You can take it around 80 to 90% of the clot. That's more than enough. Especially the clot which is adherent, it's better to leave it. So this is another case. You can see this is another case. See the opening here, a bit larger, a bit bigger than a burr hole. So all these patients presented with very low GCS. You can see the date, 10th of February, this is 11th. So all these CTs been taken after in either 24 hours or after 48 hours of the surgery. Here you can see again a patient presented with GCS of 6, and the trajectory here is a bit higher in this case. So this is post-op day 10. This is the CT of post-op day 10. So he was obeying commands, and now he's a bit aphasic but walking with assistance. So this is another case. I can show you so many cases. So again, this is the opening. This is the initial CT he presented with, but initial GCS was 12, so there was no indication actually for me to operate, but he then deteriorated. At the time of deterioration, there was nothing else than probably the expansion of the hematoma. And I had to directly take him to the theater rather than going for another CT, because I don't have an emergency theater. I'm doing all the cases in the limited time frame which I'm given within the routine theater time. So it's very difficult for me to find out theater time. So I had to postpone my routine case and do this. So the GCS was 7 initially, and this is the post-op day 12. He went home on post-op day 12. We had to do the tracheostomy. The tracheostomy was closed. Went home. See this one again. See the opening. It's very small. Right. So this one you can see the trajectory was a bit higher because I used the location where it was closest to the brain, to the surface of the skull. This is post-op day 8. He was obeying commands. So this is again another case. This was the initial one, but she deteriorated. I don't have the CT scan once she deteriorated. So again, you can see small clot. This was done under sedation. This is post-op day 5. She was obeying commands. Another one, again, did under local anesthesia because the anesthetist didn't want to anesthetize this because we didn't have post-op HDU ICU care. So this was again done under local anesthesia. The patient was not very cooperative, so I had to, I couldn't evacuate as much as I wanted. So, but no problem. So see, this is post-op day 14. He was walking. Another one, recently done. You can see floating bone flap. These are the recently done ones. So the bone flap is just kept, small opening. All these patients went home with now the modified ranking scale of 2 or 3. Another one, a doctor's sister. Again, small incision, small opening, removed it. Very bad, pretty bad, GCS of 4. Right. This one, again, a recently done one. Apparently, it was the patient's age was mentioned as 60, and patient's initial GCS was 7. That's why I wanted to operate on this. So another small opening, but so this is the size of the incision we use. It's very quick, but actually she survived. And when I asked her daughter what is her age, and she said she's 78. I'd have never done that if I knew that she is 78. But it was apparently 60, which was mentioned in the bedhead ticket. So I went ahead with surgery anyway. She survived. So this is actually what I found out. So I started doing this from June 2019 to December 2021. So until this time, I had done 96 cases, but I have lost around 24 cases during follow-up. And so I could follow up around 72 cases for at least 3 months. So these are the number of cases, and this is the pre-op GCS. You can see most of the patients had a pre-op GCS of 8, and 3 cases with the pre-op GCS of 3. So this is the mortality I found. So the total deaths at 2 weeks, 6, 1 month, 8, and at 3 months, 14. So the average hospital stay was around 8.2 days. This was the age group. And 19 out of 72 patients, they needed tracheostomy because of these issues, mostly aspiration. So we did the surgery under GA with proper GA with endotracheal intubation and GA with laryngeal mask airway. Sometimes we had to do with sedation and also local anesthesia and local anesthesia only. So this was actually the important thing. So the mortality at 3 months for my study was 19.45, which was remarkably different from what we see. So that's why actually I have not even published it as a case series, because there is a big discrepancy anyway, even though it's true. So what I want is actually I need to increase the number of cases. So that's why I have not even published it as a case series. So I think there should be more and more cases for me, and I should at least follow up these patients for 6 months, and also at least not at least if possible up to one year. The problem with the patients in our setup is usually it's very difficult for us to follow them up regularly, because if they get well after the procedure, they don't come, and if they don't get well, they usually don't come. So it's very difficult in our setup to keep a proper follow-up. But so much with this so much difficulty, so I have been able to follow these 72 patients for at least 3 months. So this is the outcome, the modified ranking scale. So most of the patients are in MRS 2, the scale of 2, and only few patients in the bedridden state. So which I see a very remarkable difference here. So that is all about deep-seated ICH evacuation. I thought I would also talk something on cystostomy as well, because it was actually a game changer for me. during the last 2-3 years, because we get a lot of trauma patients in our setup. So as the only neurosurgeon in the previous hospital as well, I had to do so many trauma cases, especially patients with severe traumatic brain injury. So we used to do lots of decompressive craniectomies, and what we have seen is there are a lot of high number of survivors with severe disability. And in Sri Lanka, we don't have a proper rehabilitation pathway as well. So sometimes we see it's actually a big burden to the family when a survivor of severe traumatic brain injury is there without a proper rehabilitation, because sometimes we have seen lots of families being disrupted because a single family member getting into that situation. So in decompressive craniectomy, we see there is a second surgery, cranioplasty. So actually, from an economical point of view, as a third world country, it's a burden for us. So I used to keep the bone flap in the abdominal fat most of the times, because usually I don't have the facility to keep it refrigerated. And also we see in decompressive craniectomy, the complications like hydrocephalus and VP shunts, and also we see slow recovery and longer hospital stays in most of the cases. So I heard of cystinostomy in 2013, and I wanted to experiment it in 2015 when we were senior residents. But unfortunately, in my country, no one was practicing that. And even during overseas training in UK, in Queen's and King's College, no one was practicing. So I thought of experimenting it when I came back in 2019 because of the resource limitations. So, and I had a good outcomes, and I have seen some remarkable recoveries with cystinostomy, which we don't see in decompressive craniectomy. So this is a patient, a young patient. All these are young patients. This patient presented with a GCS of 5. This is axonal injury. So we did the cystinostomy, and this patient survived. Now he is doing very well. See the CT scan. Pupils bilateral fixed and dilated, 16 years old. I didn't want to operate on this patient, but because of pressure from the various parents and some doctors known to this patient, so they wanted to go ahead with surgery, even though the prognosis is poor. GCS3 pupils almost bilaterally fixed dilated. So I don't have a picture. I don't have a CT where you immediate post-op where the tube is in the cisterns. At that time, we didn't even have the EVD tubes. We had to insert a small engine nasogastric tube for this patient. So this is him. This is actually 6 months back. Now the peg is out and he's talking, and he's doing much better. He understands what we say, and he had. Considering the fact that presenting with the GCS of 3, he had a good outcome. Another case, young girl, 21 years of age, acute subdural, pupils 4 millimeter, unreactive bilaterally, GCS of 3. This is at the time of surgery, brain herniating. So we did this cystinostomy and tracheostomy at the same time, and we had to do the PEG as well at the same time. I think I have presented this before. So this is post-op day 5 CT, and this is post-op day 20. So we did the cranioplasty. We could do the cranioplasty very early because she was remarkably improving, and we discharged the patient on post-op day 28. So remarkable recoveries. Right, another case recently done, diffuse axonal injury, 16 years old young boy, fallen from the bus. Pupils right side 5 millimeter unreactive, left side 4 millimeter unreactive, GCS of 3. So actually, I didn't want to do this again. I didn't want to proceed with the surgery because I always tell these parents, because there is no point in doing operation and providing a patient in a vegetative state. But this is the problem with people in my country, because they want at least. They are happy even though their child is in the vegetative state. So even though how much you explain to them. So it's really difficult sometimes. So I didn't want to operate, but so I keep the patient for 24 hours. So this is the CT after 24 hours. And I got so much pressure from doctors and everyone. She had real connections. Why don't you operate on this patient? So again, I had to operate. So this is what I did. Did the cystoscopy on the right side. I didn't keep the bone flap. So you can see. So sometimes I'm still in doubt whether to keep the bone flap or like do both the cystoscopy and keep it as a decompressive craniectomy. But this is the post of day 9. So he presented with the GCS of 3 and he's being collapsed now. So it was a remarkable recovery. And I'm quite sure just doing a decompressive craniectomy, I'm yet to see a patient with this type of early or remarkable recovery. So this is what we have seen. So what I have seen is we have seen the cases with remarkable recovery and early recovery with a short stay at hospital with patients with cystoscopy. So I have done around maybe around 50-55 cases of cystoscopy. So in my setup as a third world country, it's if you put the bone flap, you can put the forward flap. So I have so many cases where I have put the bone flap. So there's no need for cranioplasty. So cost-wise, so it's beneficial as well. And complication-wise, this is what I have seen as a single surgeon. We don't know, so we need further cases and further prospective randomized trials. And the theory regarding CSF shift edema, what you have seen, because we are doing so many cases, we are doing decompressive craniectomy, cystoscopy. So we have seen that the clinical and radiological evidence behind that is quite correct. So who knows? Maybe the outcome as well may be better with the cystoscopy. So, and I understand that it needs expertise. For example, as the only neurosurgeon in my hospital, I can't let my medical officer to ask to do a cystoscopy in the middle of the night because he doesn't have the expertise and experience in vascular surgery. So that is true. So it needs expertise, and we need prospective randomized control trials, which is very true. So who knows? It may be the future of severe traumatic brain injury. Never knows. All right. And this is my last case to share with you. So this is the case of brain tumor. So there are so many patients with brain tumors in my ward waiting and waiting for weeks and weeks, sometimes months and months for a ICU bed for them to get operated. So I have changed my practice in some cases, in selected cases, to do it under local anesthesia. So if the patient is cooperative, so I have started doing it under local anesthesia with a good scalp block with the assistance of the anesthetist. So this is one case I did recently. So this was done completely under local anesthesia and with a straight incision. The problem with me is that I don't have the navigator. So as I said, even in the intracranial hemorrhages as well, I had to be spot on, especially when you are, if you are going with a straight incision and if you are going with a small incision. So I had to be spot on with my craniometric points. So until now, I never had problems with identifying the correctly identifying the location. So I have never opened and closed the case even for ICH. So this is the patient. She did really well. So this is at just after the theater. So outside the theater, 5 minutes after the surgery. So this is the team. So she did really well. So I had to change the practice in a way where the outcome of the patient is also better, and also reducing the morbidity as well, considering my poor resources. So I think that's all about my experience as a single surgeon in a peripheral area in Sri Lanka. So that's not rather an update, actually, that is some kind of a change, or we could say an innovation. So thank you very much, John, for giving me the opportunity again. Thank you.
Okay, thank you very much, Sarath. Do we have any questions from the panelists? And yeah, I appreciate that talk. You've given a couple of talks from Sri Lanka. And I didn't realize you were such a believer in cisternostomy. And I wished I could have been here today.
Yeah.
Because he was scheduled actually, but I guess he's on the road. Any comments, Nor?
Hi. Hello, can you hear me now?
Yes.
Yes, yeah, it was an amazing talk. Thank you so much for the wonderful talk. It was so nice to hear someone from some updates from Sri Lanka. Again, this was so great to see all those things and how you have achieved so much excellent results. We have a question for you in the chat box. If you please refer to that question, and you will find interesting. Thank you again for coming in and delivering your excellent talk. We now have Dr. Gabulo next.
Thank
Yeah, I'd
you.
like to say a word about Dr. Gabulo first.
He's a wonderful friend of mine as well. He's from Congo and very brilliant since always.
Oh yeah, okay, yeah. Dr. Gabulo has been doing these webcasts for a while, and thank you, Sarat. But Dr. Gabulo has been doing these webcasts from the very start, and I appreciate him, bringing us to the Congo. Are you there, Dr. Gabulo? I believe he's in. Are you there, Dr. Gabulo?
He has shared his screen as well.
Yeah,
he's muted.
He's probably here. Well, I'll just introduce him. I see he's got the.
Yes, Dr.
Hello.
Okay, there you are. There you are. Okay, yeah, I was just saying we've done a lot of webcasts with you, and we look forward to doing a lot more in the future. And perhaps Nora wants to give the neurosurgery introduction for you. Go ahead, Nora.
Okay, sure. I would be really pleased to Dr. EWNC Kabulo. Dr. Kitanaga Kabulo is a very brilliant neurosurgeon from Congo. He has completed his training from Zimbabwe and has always been really active in all the neurosurgical academic activities, from attending various workshops around the world and delivering his talks and sharing his research work, and also attending all those webcasts and sharing various talks on different topics. So it's really a matter of great honor to have him today at this webinar on updates on brain surgery. Dr. Kabulo, the floor is yours, and again, thank you so much for coming.
Thank you so much, Dr. Noor. Thank you, Dr. Bennett, for inviting me. And it's a pleasure to meet again, Dr. Nuru, one of my best friends. We always meet when we go and learn abroad. Thank you so much. So I will talk about the update in neurosurgery in Congo. My talk for today is not educative, rather informative. I just prepared something to tell you how neurosurgery started in Congo, and where are we today, and what we are doing, and how it's risen up to now. So all pictures I'm going to show today about patient, I got consent from patient. So I only selected a few cases from patient I managed to reach. Neurosurgery, like everywhere in the world, comprise surgical intervention involve the management of central and peripheral nervous system. So this is Congo. This is my country. Is the second biggest country in Africa after Algeria. Algeria is the first one. Congo is the second biggest country. And in Congo, in terms of population, it's the fourth one. So Nigeria is the first. Congo is the fourth populated country with about 95 million population. And with that 99 million population with only 14 neurosurgeons. So the issue of neurosurgery in DRC, how it started, the first neurosurgeon was Professor Shako Junga, who was born in 1938 here in DRC. And he graduated from Free University of Brussels, where he did his medical school and also his training in neurosurgery. And thereafter, he completed his fellowship in New York, where he did also his PhD, and came back to Congo, and he worked from 79 to 86 in Kinshasa, the capital city. So at that era, it was very difficult because he didn't have CT scan, MRI scan. So he was just using X-ray, sacroradiculography or carotid angiography. Unfortunately, he died too young at the age of 48, leaving a void in neurosurgery. But the moment he was working with some doctors like this Dr. Belchica, Antoine, who was working with him, and he left at some point, went to do his training in France, and he graduated in 1987. So he came back and started now after Professor Shako died. So Dr. Belchica, when he started to practice, that when the CT scan was brought in DRC. Like you can see, the first pictures was horrible. So it was in 1988. Then there's another Congolese who works in Belgium, who was now coming to cover, and Professor Kalangu, who is well known in the world, who is the head of department of neurosurgery in Zimbabwe, and he's also the director of postgraduate training. He's the past second vice president of WFNS. So he started also to come from 2008 to 2016 as a visiting professor at the University of Lubumbashi in my town, where he was giving lectures. And from 2016, he was appointed as a professor at the University of Lubumbashi. He is now the head of neurosurgical unit at that university. And he started also his private practice since 2016 here in Lubumbashi at this private hospital, where he has 2 operating microscopes. He has also CUSA. He has, good instrument for neurosurgery. And at that hospital, we do major operations. We can do even skull-based tumors. We do also scoliosis surgery. So this is the group we call like a transition group from the old to youngest. So there are these guys who came. There's Professor Nsambi, who was a general surgeon. He went to train in Belgium, and he came back in 2012. He's the current head of department of neurosurgery in Kinshasa and the director of postgraduate training in neurosurgery. So also 2 came from Senegal and 2 came from Morocco, who trained, like Dr. Jeff Talaja trained in Rabat Center, and Dr. Ngamasata. We only got the first MRI scan in 2014. That's when the MRI scan came to DRC. And from that time, because the number of neurosurgeons were now, the number was increasing, neurosurgeons from diaspora were now coming to help, like I mentioned before, Professor Kalala, Professor Kalangu, Dr. Makese. They were coming from abroad, coming here to help. And then after the transition time, young neurosurgeons came from 2019, 2020. 4 neurosurgeons came back, first to Dr. Shweka from Zimbabwe. Dr. Sarah was the first female neurosurgeon in Democratic Republic of Congo. He graduated from Senegal in 2019. Then Dr. Denis from Senegal, and I joined coming from Zimbabwe. And 2 more came with the second female neurosurgeon. We have so far 2 female neurosurgeons here, and they came back with Dr. Feruzi. They came from Senegal, and this is the youngest neurosurgeon, Dr. Engaenga, who just graduated from University of Zimbabwe in December 2021. He joined also, which is now making in total permanent neurosurgeons 14 for this biggest country. We have 6 in the capital city. We have 6 also here in Lubumbashi, the second city where I work, and 2 in the east of the country in Bukavu. So 14 neurosurgeons. So in November 2015, the Congolese Society of Neurological Surgeons was created in Kinshasa. And in 2019, the colleagues from the other Congo, Brazzaville, they joined the society. Instead of having 2 Congolese societies, So they joined our society. We have only one. So you see the logo moved from this one, and we have now this logo, which is having both two flags from this Congo Kinshasa and Congo Brazzaville. Now, like they say, if you learn something new, your future brain will thank you. And Albert Einstein said, once you stop learning, you start dying. We want to learn more. So what is our perspective? We want to develop now subunits in Congo. So we want to push young neurosurgeons to do their fellowship, to do subspecialties, so we can have many subspecialties, and we will know that if it's vascular, we will send to this one and to this one. That will help again our neurosurgery to go ahead. But so far, we have two, Ntalaja and Sami from Kinshasa, who did a course. They have a diploma in Arab spine course. And we have also this professor from Kinshasa who did a fellowship in neurovascular in Japan. And the two also did skull base, Dr. Ngamasata and Tsambi. So in training, so far we have more than 27. They are in Senegal, Morocco, and so on. But in DRC, we have 7 who are in training in the capital city in Kinshasa. Most of them are general surgeons. So this is my country. This is Kinshasa. So if you can see, before 2013, there was only one center where neurosurgery was being practiced, and everywhere else in the country there was nothing. And after 2013, you see there is now Kinshasa. This is my town, and that is Bukavu there. And very soon we'll go there. There will be also a neurosurgeon. So you see, to fly from my town here, Lubumbashi, to Kinshasa, it's 2 hours, 10 minutes. So patients were suffering, and patients who didn't have money at that time were dying because they couldn't fly to go and follow neurosurgeons there. That's why at some point, there was one neurosurgeon from Kinshasa, Dr. Ntalaja, who was flying to Lubumbashi to cover for 1 week, 2 weeks, then he goes back and so on. We also do with the society some humanitarian missions, like we do hydrocephalus and spinal bifida camps. We did in different towns, and more than 100 kids were operated. So we are moving around the country to operate. Like you can see here, this was in Lubumbashi. There are also pictures from Goma in the east of the country. In terms of scientific committee, scientific organization, in our society, we have now a scientific committee where we are talking about research. And also we managed to organize in 2019 a very big international conference in Kinshasa, in the capital city, where neurosurgeons from Europe, from all over Africa came to attend to that conference. And the president of WFNS that time met our president, and they spoke. The president promised to help the Neurosurgical Society. So then our giant met at the University of Kinshasa. Then they spoke about the schools. That's the time they decided to open neurosurgical schools in Congo. So far it's only in Kinshasa where the school is already working, and here in Lubumbashi, the next academic year, the School of Neurosurgery will start. So we'll be training neurosurgeons locally with Professor Kalangu. In Kinshasa, there are also Professor Ntsambi and others. So here in my town, neurosurgery is being practiced in public hospital, 2 public hospitals. This is the provincial hospital where I work, Jason Sendwe. This is the university teaching hospital. So the public hospitals, those 2, the neurosurgeons, we are practicing there. But in private, I will just give a case of a private practice where I work. This is a Coptic hospital from, this is Egyptians doctors who build this hospital. So we do also major operations there. Like you see, this was like the end of our rods and screws, a successful rods and screws fixation. And at the end of operation, we took a family picture. This is the mite anesthetist I work with at that hospital, Dr. Kiro from Egypt. And there was also a team coming from the capital city. This is the anesthetist from Kinshasa, Dr. Richard. and the neurosurgeon from Kinshasa. This is only professor we have of anesthesia here in Lubumbashi. He's a Congolese. So we also work with him, and we also do big surgeries with him. Like there you see that skull tumor we removed last week. And we also do spine, we put cages, we do grafting, we take iliac bone and put plates, we do rods and screws. This case, this is our colleague. Like I told you, I'm showing you videos, I'm showing you faces because I got informed consent. This is our colleague. This is the youngest neurosurgeon who just joined. This is me. This is our colleague. We trained together from beginning to the end in medical school. We finished together, but he came with 5-month history of complete loss of vision. And when we did a CT scan, we saw this huge lateral sphenoid wing meningioma. So we operated him yesterday. This is the picture of yesterday. And this is the part of the tumor we took for histopathology. Today, I can switch off the light and he can recognize that the light is switched off. If I switch on, he sees the light, but he was completely blind before operation. Already 24 hours post-operation, he can appreciate light, which is a good sign. We'll see, and tomorrow we'll do a repeat CT scan. We'll see what will happen. So what are the reasons of delaying evolution of neurosurgery? Lack of funds. The health system in Africa in general and in DRC is based on public health priorities in which neurosurgery has no place. And also the main challenge is young neurosurgeons. When young neurosurgeons are finishing their school, they have difficulties to be integrated into the system, public hospitals or universities. When they come back, I remember one time a neurosurgeon came back and applied to the university. They were asking, do we need him? So that is also a big challenge for them to get integrated into the system. Lack of neuroanesthetists and neurointensivists, lack of training centers. It is also delaying neurosurgery, and also limited access to basic neuroimaging. So challenges we are facing, you can see, we have to motivate young people. We have also, there is access to microsurgery training. We need also that in this side. But usually we have late referral of patient and economic challenge. Patients are reaching us because before neurosurgeons, general surgeons were helping us to see patient, to operate, to do few small cases. And now there are cases which were working, there are cases which were doing well, others were wrong. So people, to convince them to come and get operated, they are sometimes like reluctant. They don't want, they say, no, if they touch your brain, your spine, you won't walk anymore, you die, and so on. Or sometimes others, they don't know that now they are in neurosurgical facilities. They keep patient until it's now late, then they send patient. Like you see this young boy who, it's a very rare case of very deep intracerebral hemorrhage. He was involved in an accident. He was riding a motorbike and before he came here from far, and Glasgow Coma score was 9, and he started to deteriorate. His brother said, please, can you do something? We just did an extended bell. We aspirated that hematoma, and you see this is 4 days post surgery, and this is, he was hemiplegic, and now he could walk. And went back to his village. This baby was born with myelomeningocele, with the meningocele and the hydrocephalus. So the doctor who was close to the family was telling them, now those patients don't grow up. If you try, they will die. Just leave the baby to die, and so on. But we tried to convince the family and operated the baby, see how beautiful she is, and she can walk now. So those are challenges we have. And in terms of equipment, Before 2014, CT scan machine were few, like in my town, we had only 3, but now we have 6, and there were no MRI scan machine. And now we have 2, 1 is not functioning, we have 1. And in capital city, we have more than 30 CT scan machine and 6 MRI scan. So in conclusion, the number of aging population is expected to rise abruptly in the future, such that more than 1 in 6 adults globally will be 65 years or older by the year 2050. So advancing age of the elderly would obviously correlate to a rise in the burden of neurosurgical disease. And rapid technical and technological advances in the neurosurgical field in the past decade, like you saw, have revolutionized better outcomes and prognosis for patients in DRC. So I insist again, we need to push young neurosurgeons to do subspecialties so we can fill some gaps in Congo. These are my few references. Thank you so much again.
Thank you so much, Dr. Ketanal Kabulo, for your excellent talk. Thank you for sharing your kind words, and we totally agree with that. And we have seen you working so hard to achieve several of the goals. You have done so much good and dedicated work and promoted several of your fellows. Again, thank you so much, Dr. Sami. Would you like to take the floor? We have got Professor Stavropoula Shomekaris. We are really honored to have her today. She's the first woman neurosurgeon who has been duly trained to perform both neurological surgery as well as endovascular procedures. She's a professor at the Director of Fellowships in the Thomas Jefferson University. Dr. Sami, would you like to proceed?
Thank you, Professor Stavropoula, for this.
Hello, can you hear me?
Yes.
Okay, great. Dr.
Professor, for joining us today.
Okay. So thank you, Dr. Hassan, for your kind invitation. I'm delighted to talk about advancements in neurovascular surgery as it pertains to aneurysm treatment. I'm Dr. Stavzu Makaris from Thomas Jefferson University in Philadelphia, where I'm a professor of neurosurgery and the first dual trained female to be doing this in the United States. So these are my disclosures as they pertain to the lecture. And this is Thomas Jefferson University in Philadelphia, where we have a dedicated neuroscience hospital, the Vicky and Jack Farber Institute. This is the conventional operating room as we know it, where we clip aneurysms. And this we have been doing for the last 50 years. And this is the new operating room, the minimally invasive cerebrovascular endovascular suite, where we can do minimally invasive cases or joint cases with open microsurgical technique. This is our hospital, again, the Vicky and Jack Farber Neuroscience Institute. And this is the tri-state area where our catchment area in Pennsylvania, New Jersey, and Delaware. We have a team of dual trained neurosurgeons, stroke neurologists, and critical care intensivists that we jointly take care of all these patients. So I'm going to start by, as you know from my name, I'm actually a neighbor, I'm Greek. Anevrisma is the original term of aneurysm, and it means to widen within. And this is the evolution of endovascular neurosurgery. We started back in the mid-1990s with coiling embolization, then liquid embolic agents, and then in the early 2010 decade, flow diversion with a pipeline device revolutionized the way we treat aneurysms, and now we're looking into intrasaccular devices. This was a disruptive innovation device. Can you see me?
Yes, yes, we can.
Okay. And this is the typical flow diversion device, which is 3 times lack of porosity as opposed to the conventional stenting. And that was enough to occlude the aneurysm without having to go inside the aneurysm. Currently, the FDA-approved devices in the USA are the pipeline device as of 2011. And most recently, we have the surpass device and the FRED devices. These are linear flow diversion devices. So in other words, bypassing the aneurysm. And now we have an endoscopic device that you'll see, the web device. So the first on-label indication limited the treatment of aneurysms from the petrous carotid all the way to the superior hypophyseal. So very limited portion. And these were some of the original cases that we did. This is a cavernous aneurysm treated in 6 months, complete aneurysm obliteration. Similar with this large cavernous symptomatic aneurysm. If you look at this aneurysm, this is an intradural ophthalmic artery aneurysm. You see that it has 4 distinct lobes. For those of us who also practice open surgery, this is a challenging aneurysm to take care of. You have to drill the clinoid and you will need multiple clip reconstruction. And you see here that the ophthalmic artery comes off of the ophthalmic aneurysm itself. So potentially leaving a little remnant behind to maintain patency of the artery. With a single stent, as you see here, you have complete reconstitution of the vessel and aneurysm occlusion in 5 minutes. There are some things that we learned from us performing these procedures, and one of them, if the communicating artery is fetal, in our series, 100% of the patients did not have aneurysm occlusion when treated with flow diversion. And this is an example. So once we see a fetal PCOM artery, we don't bother flow diverting anymore. This case needs to be treated with microsurgery and clipping. In 2019, following a plethora of different publications, the pipeline from the FDA to now cover from the petrous segment all the way to the carotid terminus segment. We actually did in my institution the first pipeline flex device for commercial use. And obviously we expanded our indications and published on this. This is a patient, as you see, he has a left pica artery aneurysm at the 4th segment. You can see here there's a Murphy's excrescence within the aneurysm, and partially the aneurysm is fusiform. So this kind of aneurysm would require a pica to pica bypass and completely obliterating the aneurysm from the circulation. However, this is with a single stent device. You can see here the deployment of the device. The aneurysm is completely gone, as you see here, 1 month follow-up, and the artery has reconstituted. How about giant aneurysms? This is a 56-year-old male that presented with left-sided hemiparesis. You can see this giant partially thrombosed aneurysm almost behaving like a tumor with associated posterior MCA edema. And this is a very challenging case to treat it open. Actually have to use the two-step device to remove some of the thrombus. And then once you're closer to the aneurysm and a lot of these thrombus is removed, then you can clip reconstruct it. So a very prolonged case. However, this is the angiogram as you see. This is a distal M1 artery aneurysm, which gave us the capacity to land a single stent. This is a 3-dimensional reconstruction. And you can see in 6-month follow-up, complete reconstitution of the vessel, a removal of the mass effect, and the patient did very well postoperatively. How about these challenging cases, such as an unruptured AVM in the left occipital region? And you can see here these high risk for rupture inflow aneurysms. There are 3 of them in the proximal P1 and the distal basilar apex. Again, these are very challenging cases to treat with open surgery, not just because of location, but also because of the associated distal AVM. This is a single device. This is a flow divergent stent. And this is a 6-month follow-up where you can see complete reconstitution of the endothelium, no filling of the aneurysms. And then the patient underwent embolization of the AVM followed by microsurgery. How about these complex cases? This is a fenestrated basilar aneurysm. We've actually published our experience with fenestrations. These are very challenging cases to treat with open surgery. And what we discovered is the way to treat this is to actually coil partially the aneurysm and then flow divert the dominant limb and deconstruct, in other words, shut down the non-dominant limb to prevent that inflow and patency of the aneurysm. And this is what you see here on the bottom right picture, 100% aneurysm occlusion and 6-month follow-up. Then we get some complicated cases, such as this broken construct that we got from another institution. You can see here if inexperienced surgeons do these procedures, sometimes the construct can actually break. So we were able to cross the construct and put a bridging device and prevent this inflow endo leak that could lead to a catastrophic rupture. Some of the lessons that were learned, this is a very good paper that was published by Dr. Myers and his group. Even if the aneurysm is in a non-intradural segment, such as cavernous aneurysms, you can still have a rupture and develop a carotid cavernous fistula, and that can be treated with complete aneurysm occlusion and embolization. The device can migrate, as I showed you earlier, in another transfer. And this is a giant aneurysm with a device migrated into the aneurysm dome. So when you're dealing with giant aneurysms, you need to use very large and long construct to prevent that accordioning of the device into the apex of the aneurysm. So if aneurysms are intradural and greater than 1 centimeter, so the recommendation currently is to coil assist these aneurysms to prevent this delayed rupture. Patients that have other hematological disorders, such as the sickle cell patient, you can see in 6-month follow-up, there was a ruptured posterior carotid wall artery aneurysm that was successfully treated. The aneurysm is gone. There's some mild in-stent stenosis, but the patients that have sickle cell or other high thrombotic disorders can, during a crisis such as a sickle cell crisis, the clumps of the sickle cells can actually increase the stenosis and put the patient at a high risk for stroke. So these patients need to be kept on dual antiplatelet therapy for longer, aspirin and Plavix, and very prompt exchange transfusion. You can see here pre and post transfusion resolution of the severe stenosis. The current devices, the new generation devices, actually have a modification of the wall of the stent that mimics the red blood cells and decreases the thrombogenicity of the stent. And we're hoping that in the future, you will not need to use dual antiplatelet therapy for these devices. And this is the Pipeline Shield was the first one that has this new surface modification technology. And these are the upcoming trials for the Pipeline Shield and the Fred X device from Microvention. And there's an upcoming Fred X trial that I will be the national PI for investigating this new concept. So in 2019, the Fred device, which is slightly different, became FDA approved. And again, the same location, petrous to carotid terminus artery aneurysm. What's very special about this device, there's part of the stent that doesn't flow divert. In other words, it works like an anchor, and it allows you to position it to bifurcation aneurysms without jailing that aneurysm. My group did the first Fred device following FDA approval. And this is an example of the Fred device from the original trial. You can see a PCOM artery aneurysm recurrence that was treated with 100% 6-month follow-up. This is the actual deployment of the device. You can see here that it conformed very nicely here to the paraclinoid aneurysm. And this is what I was mentioning earlier. Part of the device doesn't flow divert. So you can land it distally without jailing, for example, the A1 in the carotid terminus aneurysm. These are some of the cases that we've done with this new technology. This is an ophthalmic artery aneurysm. In the middle, you see the famous eclipse sign in linear flow diversion. What it means is following stent deployment, you see the stasis and half the aneurysm is completely gone. That's a very good prognostic indicator for complete aneurysm occlusion, as you see here in 6-month follow-up. These are some more challenging cases. For example, this complex trilobe PCOM artery aneurysm recurrence following a rupture. You can see here with a single Fred device placement, reconstitution of the aneurysm, and some of the stenosis within the stent. As time goes on, you can see that the vessel reconstitute and the flow within the stent improves as well. This is another example of 2 ophthalmic artery aneurysms that were treated. And again, my point with this device is the non-flow diverting segment allows you to actually deploy it distal in the carotid terminus or in a basilar terminus, obviating the need of jailing one of the other branches. And this is a superior hypophyseal artery aneurysm. You can see here deployment of the stent, a very sturdy deployment, and you'll see how the part that doesn't flow divert will go distal and not cause any trouble with the A1 segment of the intercerebral artery. This is a very resheathable device. So when we train fellows, we're actually have a lot of opportunities to be able to really be precise about the deployment. This is you can treat very complex aneurysms. You can see here this complex case with a fusiform MCA that failed the previous clip, that came for a second opinion for flow diversion, and we built a construct of these stents within the aneurysm. You can see here 5-stent construct, and on a follow-up angiogram, you can see almost complete stasis within the aneurysm and aneurysm occlusion without the need of repeat surgery and bypass in that area. What's the latest device? In flow diversion, we have junior devices. In other words, very, very small vessels. This is a pericallosal artery aneurysm that had a rupture, was coiled, presented with a 30% recurrence at the neck. And with a single device, we were able to treat the recurrence successfully. The latest in flow diversion is actually endoscopic flow diversion. And the device that we have that's FDA approved in the United States is the Webb device. And as you see here, it's flow diverting within the aneurysm. So the basket gets deployed a single device as opposed to multiple coils within the aneurysm. And then in time, that causes aneurysm occlusion. These are our cases for the trial, the Webb IT trial that established safety and efficacy of the device. And this is FDA approved for bifurcation aneurysm. So this is an ACOM artery aneurysm. You can see here down the bottom right, 1-year follow-up, 100% aneurysm occlusion. And this is how the device looks angiographically. Similarly, an MCA artery aneurysm, you can see you can have irregular aneurysms and complete aneurysm occlusion without open surgery at 6-month follow-up. Another right middle cerebral artery, 1 centimeter aneurysm with complete aneurysm occlusion. So again, the indications are bifurcation artery aneurysms. This has been FDA approved for nearly 3 years now. And one of the reasons I really like this device, and this is our paper that we published on this, is actually the treatment of ruptured aneurysms. So if you have a ruptured aneurysm with a wide neck, almost always these cases need to undergo microsurgery or clipping. Because if you use a stent, then you will have to use dual antiplatelet therapy, aspirin and Plavix, which increases the risk of perioperative hemorrhage. However, when you use the Webb device, you don't need the second agent, just aspirin or no aspirin alone. And you can see here, this is one of my patients presented with has grade 4 subarachnoid hemorrhage. You can see mainly in the posterior circulation, and this wide neck, irregular basilar apex artery aneurysm. With a single device, you can see here on the right, complete aneurysm occlusion. This is not a 6-month follow-up. It's completely following the deployment of the device. When it's sized properly, you can achieve 100% obliteration immediately. And the only remnant of treatment is really the 2 poles of the device at the proximal and distal end of the aneurysm. This is another case I treated, a ruptured basilar apex artery aneurysm. You can see here the stasis within the aneurysm. That's a good prognostic sign that the aneurysm will be gone at 6-month follow-up, and also that you've sized the device properly. Now we can even treat more complex cases. This is a ruptured anterior communicative artery aneurysm. You can see here a very wide neck with Murphy's excrescence here laterally, and with a single device aneurysm occlusion, as you see here on the right. This is again immediately after deployment, not having to wait for 6 months. This is another case, an M1 artery aneurysm treated with a single Webb device as well. This stasis within the basket, it's a very good prognostic indicator for complete aneurysm occlusion. And on the table, we can get Dyna CT to see the exact position of the device with the different bifurcation branches. And we've expanded the indication to very complex cases. This is a bilobed ACOM aneurysm in an 80-year-old male with a rupture. And this is the actual aneurysm. You can see here 180-degree orientation of the 2 different necks. And we deployed 2 different devices. Here's a Dyna CT following the deployment, almost at 90-degree angle with each other. And you can see here nice stasis within the aneurysm. And this 80-year-old gentleman didn't have to undergo open surgery at this advanced age. We have pushed the envelope again. This is treating sidewall aneurysms. So you really need to get comfortable with the device before you increasing the complexity. This is an off-label usage, but this causes a nice result. You can see here without needing a clip on a fetal PCOM vessel, we can now treat it minimally invasive, especially in patients that are of advanced age. This is another sidewall aneurysm. This is a ruptured ophthalmic artery aneurysm. You can see here it's treated with a single device. And this is the native, where you can see the device here in the ophthalmic region. The patient actually had a basilar apex at the same time treated with another device. And this is nice stasis. You can see preservation of the ophthalmic artery, and the patient's protected from subarachnoid hemorrhage. Now, if the aneurysm morphology is complex, such as this one, you don't have to fill the entire basket with the aneurysm. As you see here, for example, this Murphy's excrescence, the point of rupture is treated by secondary intent. So you block the inflow. So a lot of times you're sizing the aneurysm based on the neck and not just the entire width of the aneurysm. What's the latest with endoscopic devices? This is the Web 17 device. That is a very small device, and this is an M4 level MCA aneurysm. You can see with a single device, complete aneurysm occlusion, and you can see here treatment of the Murphy's excrescence with a secondary intent by blocking it from the circulation with the device proximally. Currently, we have an FDA-approved clinical trial that we're enrolling a brand new device that came from Europe, the Contour. This is my first case, and this is treatment of a recurrence of a Webb device. So you're treating shallow aneurysms. The Contour device is a little bit different. It doesn't have half of the dome of the Webb device, so it will allow you to treat, for example, this wide neck recurrence without having to use a very large device. So there's a lot of new technology coming out, and one of the best new technologies that I'm going to leave you with is robotics in neuroendovascular surgery. This is the current robot that's approved both in Europe in January 2018 and also in America with the FDA. Currently, just for peripheral vascular lesions, is called Corindus, and we have the second generation device here. So only for peripheral vascular, which means carotid stenting, we now do robotically. You require two teams. One team is at the bedside doing the actual placement of the sheath, and one team does the robotic drive of all the devices remotely and not present at the bedside. So this is a transfemoral positioning of a carotid stent. And you can see this is me here in the operating room, however, in an adjacent room. So I'm not exposing myself to the radiation, and I'm able to drive these devices without having to be at the bedside. This could be revolutionary, and we could be doing these procedures remotely, perhaps several thousand miles away from the patient. The advantages, again, increases precision of manipulating the microcatheters and the microwires, reducing or minimizing completely radiation exposure of the physician, and again, allowing for remote intervention. So perhaps being able to treat stroke or aneurysms in underserved areas. Well, this has already happened in the cardiac world. This is Dr. Patel in India. He completed 5 procedures 20 miles away using the CorePath robot. And this is the most exciting part of this treatment of intracranial diseases. And this is in Toronto, Dr. Pereira and his group. They don't have the FDA restrictions, so they were able to be the first to treat an intracerebral aneurysm with robotics. So this is a supracerebral artery aneurysm treated with a stent-assisted coiling, completely robotic from beginning to end. And the patient had a great follow-up and complete aneurysm occlusion. So although we're not there yet, the FDA, the CorePath has applied for FDA approval for intracranial lesions such as cerebral aneurysms, AVMs, and strokes, and hopefully pending approval. So we're able to use this new technology and treat aneurysms remotely. We'll leave you with that. Thank you again for your kind invitation, and it's a pleasure being here today.
Thank you so much, madam, for the excellent talk. And again, it's a matter of huge honor for us to have you here and to have the privilege of listening to your wonderful lecture and all the wonderful views you have shared, especially regarding robotics, which is going to be a very important topic in the near future. And there's a lot of research going on. Madam, thank you so much for sharing your wonderful talk. I don't think there might be questions for you in the chat section. Again, thank you so much for allocating and sparing your time while you were about to catch your flight today. So thank you so much.
It's my pleasure. I'm glad it worked out and I was able to give it live.
Have a Philly cheesesteak for me, please.
Oh, I will. I sure will, John. When I get to Philly, I'll grab one for you.
Thank you.
Thank you so much. Thank you, Dr. Hassan, for having me.
Thank you so much, madam. Honor and pleasure is all ours. And now we have to introduce our next speaker, Professor Charlie Tew, who's obviously all of us know him so well, and he doesn't need any introduction. But for sake of formality, I would like to have the honor of introducing him as a global neurosurgeon. And he has done a lot for those who were in need, who were refused surgery, who have lost hope. So, sir, you are a really respectable figure for us on neurosurgery. He founded the Charlie Tew Foundation and done a lot for brain cancer research and surgery and management. It's a matter of great honor for us to have you here, Dr. Charlie Tew, as a director nowadays Center for Minimal Invasive Neurosurgery in Sydney, and a consulting professor for the prestigious Duke University, USA, visiting professor in for Singapore, and as well as for Aditya Super Specialty Hospital, Jaipur, India. Sir, thank you so much for coming here today. It's a matter of huge honor to have you. The floor is yours now.
That's very kind. Just check to make sure you can hear me.
Yes, we can hear you.
Oh, g'day, John. Nice to see you again.
Thank you, Charlie, for coming.
And Mr. Chairman, how many minutes do I have?
How many minutes? 25, correct?
25 minutes. 25.
Okay.
25.
Okay, so I can talk. I can talk the leg of the chair, and I could talk for hours. So if you don't mind, could you give me 5 minutes? Just give me 5 minutes warning, and I'll stop it. But I've got a lot to say. Okay. And I thought that I'd start off with this. So,
well, you know, Charlie, I think we have time today, so you can go if you want to go a little more. That's fine.
Okay, John. Well, just please give me 5 minutes when you want me to stop, because really, this is a very important subject, and I think it's something that I'd really like the whole neurosurgical world to hear about.
Sure, we've had time free up, so we have time.
Okay. So my talk was meant to be about the oncofunctional balance of neuro-oncology, and I was going to introduce everyone to a subject called the networks, or connectomics. And it turns out that every time I give this talk, I end up walking away baffling people more than I do enlightening people, because they don't quite know the background behind the network. So I'd like to spend a bit of time talking about the networks and then how we can apply it to oncofunctional balance. So it goes like this, that as neurosurgeons, we are very ignorant of the problems that we cause or the problems that our patients present with. And it's quite interesting that if you deep dive into the literature, you'll see, in fact, that our patients don't do as well as we as neurosurgeons think they do. For example, there's a paper that clearly shows that depression is extremely prevalent in GBM patients. And of course, as neurosurgeons, we used to blow this off and say, oh, it's because they've just been given the diagnosis of a brain tumor. It turns out that patients with cancer of the pancreas, which is just as devastating, have about 40% incidence of depression versus 90% with neurosurgical patients with brain tumors. 90% of patients with insular gliomas, for example, aren't able to have an orgasm, which means they have significant quality of life impact by having an insular tumor or by having surgery around the insular region. 90% of patients say, or partners of patients say, that they're not the same person after brain surgery. Granted, 5% are better than after they have their surgery, but that means that 85% of patients or carers of patients say that they're not the same person in a negative way. 70% of patients after surgery for a hemispheric glioma don't return to previous employment. And if they do return to previous employment, it's not at the same level as they were before they had their surgery. So it's pretty clear that brain surgery has a huge psychosocial, cognitive, lifestyle, and emotional impact. And that is in the absence of any overt neurological problems. So I don't want you to think that these people don't return to work because they're hemiplegic, or they can't see, or they can't speak. These are people who have no overt neurological problems, but clearly have a problem with their brain. And I like showing these two examples because they're really very indicative of what we see with insular glioma patients. So at this stage of the talk, I'd like to make my confession. My confession is that I'm probably the worst when it comes to neurological assessment after surgery. If they walk into the room and they're not paralyzed and they can speak and they can smile and thank me for the operation, I pat myself on the back and I tick it as a good outcome. So all these patients I would consider have had a good outcome. They all had insular gliomas. I use their pictures in talks to show how good a surgeon I was. But in fact, if you do a more comprehensive evaluation of these patients after surgery, they all reported a drop in their Karnofsky performance status. So in other words, overtly good, but covertly worse. Here's an example of an insular glioma that I removed, complete resection, good-looking patient. Insular glioma, complete resection, good-looking patient. And I'm not quite sure, again, if you don't mind interrupting, John, I don't know if you can hear this, but I'm going to play this video.
Okay.
Did you hear that, John?
No, we're not hearing it. You've got to pick a option on the screen share.
So.
Yeah, if you want, you just go off the screen share and come back on.
No, it takes too much time, John. I can tell you what she says anyway.
Okay.
In other words, she's saying in the video that she's well. I ask her how she's looking after her children. She said, good. She just picked them up from school. She's going shopping. How's your speech? She goes, it's not normal, but it's probably 99% of normal. So in other words, this is a normal person going about her daily activities normally with normal speech and normal motor function. This lady, on the other hand, have you been depressed? What about your emotions? She goes, no, I'm good. I've heard you've been a little bit depressed lately. I have been because of this. But I hear that you've been angry at other people as well. And the husband taps on the knee, goes, what about my mum? She goes, what do you mean by that? Oh, yeah, when mum came around, she tried to help in the kitchen. I didn't want her there. I threw her out. I shut the door. And when my mum came around, I shut the door as well. Because I want to do things my way. I want to walk. I want to clean the mess in the house. Okay, so clearly this lady was not normal. She had problems with empathy. She had problems with depression, inability to look after her children, so much so that the husband had to take time off work to care for her children, her 3 children. So yes, overtly smiling, non-hemiplegic, no speech disturbance, but covertly basically devastated. Now, why does this happen? Well, over the century, we've blamed everything else. Initially, we used to say, oh, it's because you let the air into the brain. And then we called it, patient's emotional problems. And then we thought it was due to covert neurological deficits, such as, things like visuospatial dysfunction. And then, of course, we tried to blame everyone else. We blamed the steroids and the radiotherapy, the chemotherapy, the general anesthetic, and we blamed society because they had a disappearance disability. They had a hair shave, so they could never return to normal societal function. Myself, I used to blame brain swelling. So they'd come in, they'd look good. I'd sort of shuffle them out the door. And as they were leaving, the wife would say, look, he's just not the same person. He hasn't returned to work. And I'd say, look, come on. He's not paralyzed. He can speak. Be grateful. It's probably a bit of brain swelling. He'll get better. Of course, they never got better. And I never really gave it any sort of merit, their description of not being the same person. So we're very quick to deflect the blame. Should we accept the blame? Absolutely, we should. We destroy normal brain intentionally, and we destroy normal brain unintentionally. The intentional destruction of brain is when we access tumors from normal brain that are deep to the surface, We know that they have an oncological advantage by doing a super resection, or in other words, a supramarginal resection, taking away some normal brain. And sometimes we do a lobectomy because the literature tells us they survive longer. And then, of course, there's unintentional brain damage, such as disorientation during surgery and going beyond the margins of the tumor, and vascular injury where we inadvertently take an on-vessel. So my question to you and your question to yourself should be, is there such a thing as non-eloquent brain? Excuse me. So again, at this stage of the talk, I like to sort of deflect some of the blame from myself, because I was taught by my forefathers, and you were taught by yours, that there are parts of the brain that are non-eloquent. We use the term all the time. The right frontal lobe, parts of the left frontal lobe, the right temporal lobe, 7 centimeters back from the pole, the left temporal lobe, 5.5 centimeters back from the pole, I was taught could be taken with impunity, with no consequences, that it's non-eloquent. We're not quite sure what it does, but if you do neuropsych evaluations on people after you do a lobectomy, there's really no difference. And this narrative was taught to me, not only taught to me, but taught to me as dogma. In other words, you know, this was the absolute truth, that there are parts of the brain that you can sacrifice without causing problems. It was very clear when Glasser wrote his article in 2016 that narrative was incorrect, that in fact all brain is eloquent. And the only reason you think it's non-eloquent is because you haven't done the right test, or there is no such test to pick up the deficit that that patient has. So they've all got deficit when you go through normal brain. It's just that sometimes it's incredibly subtle, or sometimes it's not so subtle, but we just fail to either acknowledge it or to examine for it. So this introduces a whole concept of the brain networks. What are the brain networks? Well, again, I'm so sorry if I'm teaching you something that you already know, or teaching you how to suck eggs, but I'm going to assume that you knew as much about the networks as I did before I was enlightened by a guy called Mike Shigru. Mike came and joined me. Those of you who read the literature know who Mike Shigru is. He's the guy that wrote the supplementary version of World Neurosurgery when he submitted 19 papers, all on connectomics, all about 50 pages long. It was felt that it was such a seminal piece of work that it should be put in its own supplement. And so Mike Shigru is basically one of the leading figures in the study of connectomics in the world. And he came and joined me about 2.5 years ago and started talking about the networks. Well, I had no idea what he was talking about. I was certainly not taught about them, and I hadn't read enough literature to know about them. So again, my apologies if I'm teaching you something that you already know, but here we go. What are the networks? They are nodes that are wired together and fire together. They serve a common purpose, but mix parts to create high cognitive functions. They lie in a hierarchy. What is a function? A function is not the same as a network. A function, if you'd like to make an analogy, is like an orchestra playing beautiful music, all in harmony. The networks, therefore, are the different sections that have to work as well in harmony to make that beautiful sound. So the networks are the sections, the function is the overall end product. These functions are often constructed from different subcomponents of the 7 networks. Indeed, most functions come from components of various networks defined by the study of the white matter or connections, and that is connectomics. So again, that takes us back to connectomics. What is connectomics? Connectomics is our evolving understanding of the human brain. We were taught by Brodmann that there were 47 parts of the brain, and he identified where they were, and all those other parts of the brain didn't have names, and they didn't have Brodmann areas associated with them, and we considered them non-eloquent. And that map of the brain originated in 1908. So why we would think, or why I thought, how in the hell did I think that things hadn't changed since 1908? But there is a reason for it. Why did it take so long to get to this level of understanding? Well, the brain is an incredibly complex computer. We all know that. We've all said it glibly, but it is amazingly complex. There's almost 100 billion nerve cells. There's 1 trillion supporting cells. There are 20,000 synapses per cell, and there are 17 trillion electrical signals per second generated by the brain. To interpret a brain requires a huge amount of data processing. And until recently, we never had the computer potential to process all that data. So how much data is generated by the brain? Well, just for example, if you look at the lower order connectomics of, for example, a bacteria C. elegans, which has 302 neurons, it took 10 years to map the connections of C. elegans. Mapping on an axonal level requires 800 man-hours just to map 1 cubic millimeter of brain using current technology. Therefore, the data generated from 1 millimeter of cortex is 2 petabytes, which is 1,000 terabytes, which is 1,000 gigabytes. To map the entire cortex of a rat, you're looking at 1 exabyte. And to map the human cortex, you're looking at about 1 zettabyte. Now, I've never even heard that term before, but it is millions and millions and millions of terabytes that are generated by the human cortex. So you can imagine if this much data has to be processed, the old computers just couldn't do it. If you want to get some idea of how much data that is, the Human Genome Project produced about 1.5 gigabytes of data. So we're talking millions and millions and millions of bytes more than the Human Genome Project. It was sponsored by the NIH in 2009. It was at a cost of approximately $40 million, and it was the main aim of the project was undertaken by WashU, University of Oxford, and University of Minnesota. There were 1,200 subjects aged between 22 and 35 from many different families, and they all had extensive behavioural testing. Why? Because we wanted to make sure that these patients didn't have, again, covert neurological problems. They were examined by 3T, 7T, magnetoencephalography, and we used structural MRI scans, task-activated functional MRI scans, diffusion imaging, and resting state functional MRI scans. Now, again, I'm going to assume that you have my sort of level of knowledge and you didn't quite understand the differences between these tests and the normal tests that we order every day. Diffusion imaging is a sequence using an isotropic diffusion of water molecules to deduce direction of white matter tracks. So that's what diffusion imaging is, and it's usually processed through a thing called DTI, diffusion tractography, or diffusion tensor imaging. What is resting state MRI scan? Well, this has been around for quite some time, and I had no idea what it was, but it's non-task based. In other words, it's task negative state functional MRI scan based on bold signal. Bold signal is blood oxygenation level determination, and in very basic terms, it turns out that deoxygenated blood gives off a different signal to oxygenated blood. And that means that the more active a part of the brain is, the more it takes out oxygen from the arterial blood, and the greater the difference in the ratio between oxygenated and deoxygenated blood, and that gives a signal. That signal is very poor, that ratio is very low, and as a result, there are many things that negatively influence the accuracy of bold signal. So traditionally, we haven't put much credibility on bold signal because it's affected by noise, not only movement, but also the noise of your heartbeat, and therefore it may not be as accurate as we once thought it was. If you use ICA, then you can, again, it's a different type of modeling, it's a different type of processing, but essentially all this information is processed using ICA. That then allows us to develop detailed maps of the human connectome, or all the white matter connections. We then can correlate those connectomic maps with behavioral data, because we've got the data on all these people. We can even correlate it with genetic data, and we can deploy web-based informatics infrastructure and then disseminate these data sets for analytics. For example, all that work has now generated 831 hits if you put in Connectomics into PubMed, but it's all based or all distilled into this one article by Glasser et al., published in Nature in 2016. So it says that a network is a wide cortex that is synchronously active to bring about a common function. There are 7 main networks and multiple infinite networks. 2 of these main networks are input-output networks, sensory, motor, and visual. 1 is primal, the limbic system, and 4 are the main cognitive networks. These are names that, again, you may have heard of, and I hope you have, but I had never heard of until Mike Shagru enlightened me. So those networks are salience, DMN, which stands for default mode network, CEN, which stands for central executive network, and DAN, or the dorsal attention network. Where are they located? Well, roughly this cartoon shows where they're located: sensory motor, visual, limbic, CEN, DMN, salience, and DAN. So again, what we're going to have to do is relearn our anatomy so that we incorporate this new knowledge into our idea of what is eloquent and what is non-eloquent. And you'll be absolutely blown away, and I think disturbed, to see that parts of the brain that we lop off with impunity, well, I'm sorry if you don't, but I certainly did for 30 years, contain very eloquent parts of the brain called these networks. How do they work? Well, they work in a hierarchy. The most sophisticated and anthropologically latest or youngest network is a salience network. It then has functions that control the networks below it, and they in turn control or have jurisdiction over the networks below them. It seems to function in this sort of manner and align around salience. So CEN and DMN are controlled by what I call the air traffic controller, or salience. And if I could just give you an example so you understand the fine, delicate nature of the balance, it goes like this. CEN is figuratively called the on network. It's important when you're doing things. Executive functioning. When you're putting things together to create a specific purpose, like dressing oneself. DMN is called the off network, and it is active when you're not doing something. In other words, when you are using your imagination, for example, or thinking about doing something, or the whole concept of pleasure or pain is controlled by the DMN. It turns out that the CEN, when upregulated, has to downregulate the DMN and vice versa. So you can't have both upregulated at once, and if you do, that is equivalent to schizophrenia. Schizophrenics have a problem with the salience network. In other words, they can't upregulate one as the other is downregulated, and vice versa. And that's why their brain is just not working well. These higher cognitive networks are joined by white matter tracks that, again, I had no appreciation of how important they were. The cingulum, for example, in the cingulate gyrus, is probably the most important white matter tract in the brain. It connects the DMN to all the other higher cognitive networks. And the posterior cingulum, or posterior cingulate area, is probably the most connected part of the brain. And again, it's a part of the brain that I thought was non-eloquent. And I thought it was non-eloquent for a good reason, and that is because when you destroyed it, there were no covert problems in terms of hemiparesis, speech, or vision. So, like, I don't have enough time to go into the exact location and all the different parts, or they're called parcels of each network, but I'll give you a rudimentary summary of these networks. The default mode network, remember, it's active during rest and sleep, and it's located in the anterior cingulum, posterior cingulum, and the lateral parietal area connected by the cingulum. The salience is middle cingulate area, SMA, FAT, that's the frontal tract, and the insular region. And remember, it's incredibly important in the hierarchy. It's probably the highest in the hierarchy. Central executive network, again, I hate to tell you this, but it's frontal pole, SMA, and posterior parietal area. DAN is the dorsal attention network. It's very important as well because it controls input and output of various sensations, and therefore it has to be dampened when you're thinking about something. In fact, if you have DAN, you can't focus, and you can't focus on thought or focus on activity. Again, this orchestra concept, where they all have to work in total synchrony in order to create a function. And for example, we know where the initiation axis is, and the initiation axis is incredibly important, and it's almost like a hub or a central relay station for all many different networks. Language is another network, and it is becoming more and more complex. No longer can we think of language in this old model of Broca, Wernicke, and articulus between the two. It is now a whole world complex. There's now parts of the brain that we had no idea was associated with language, such as even the posterior fossa. 55B here was never even named before. It's part of the laryngeal motor area, P belt. So these are parts of language that now makes the language network incredibly complex. So it's not just speech and phonemic and semantic speech, it's accessory language and motor language, verbal language, and so a very, very complex network to create language and comprehension. Ventral attention network is quite unique. It's only on the right side of the brain. And again, it's a good demonstration of how we do have two different halves of the brain, and they do have to communicate well with each other to make a well-oiled machine. Limbic system, I don't have to go into. It's anthropologically the most primitive part of the brain, and therefore it controls things like survival, sexual arousal, hunger, thirst, fight and flight responses. Sensory motor, you know well. So I'd like to summarize at the end here by saying this, that no longer can we accept the old idea of a brain being eloquent and non-eloquent. It is a primitive version of brain anatomy and functioning, and it is very, very unsophisticated. If we want to pick up our game and use the information that is now at hand, we have to change the way we think about the brain. No longer can we accept that cutting through so-called non-eloquent areas is not going to have some impact. Sure. It may not have an impact to our very primitive neurological examination. In other words, that's what I used to do. I used to get them to do a pronated drift. I used to get them to speak, and I used to check their visual pathways. And if they could do all those things, to me, it was a successful neurosurgical operation.
Excuse me, Charlie, giving you the 5-minute warning, okay?
Absolutely. Given the information we have to make our approach to the brain much more informed and much more balanced. Now, I'm not saying to you that you have to necessarily change your surgical or your oncological approach, but you have to do it in an informed way with the patient knowing exactly what they're going into. So it goes like this. It is true that every patient is an individual. Every patient has their own individual intention and goal of surgery. So when I speak to a patient, I say, look, for oncological ideal, I'd like to take out all this tumor and I'd like to take a little bit of normal brain around it. And then I used to say to them, but you have a 5% chance of a hemiparesis, a 16% chance of visual defect, et cetera, et cetera. I never mentioned the fact that their emotions may be different, their sex life may be different, their ability to interact with people around them, their ability to show empathy, to acknowledge pain, pleasure, use their imagination was going to be different, because I had no idea where those functions were subserved. I had no idea which parts of the brain controlled those very covert but important emotions. Now I do. So now when I say to a patient, look, I'd like to take out this tumor, there's a 5% chance of hemiparesis, but unfortunately, there's also a 50% chance that we're going to make you depressed or give you anxiety or take away your ability to enjoy sex. And then, of course, they can make a well-informed consent. If they choose not to have surgery, it's their prerogative. Then, of course, you stick to not damaging those networks in and around that tumor. If they choose that they want oncological ideal, they want to live as long as possible and they're willing to accept a deficit, then, of course, they do it with their eyes wide open and your eyes wide open. So what I'm saying is, to achieve that oncofunctional balance, we now have to incorporate this added information about the networks into our decision making. And by way of example, a right frontal lobectomy, for example, could potentially cause all of these deficits: initiation of thought and movement, the ability to multitask, working memory, mood, imagination, theory of mind, ability to process social situations, executive functioning, coordination of complex movement, ability to dance or to coordinate movements together, drive a car, dress oneself, interact with authority, and indeed interact with anyone around them, sexual performance and pleasure, urinary continence, handling of complex machinery, and the list goes on and on and on of all the functions that potentially could be damaged with a right frontal lobectomy. And I never even talked about these functions with my patients. I simply talked about hemiparesis, speech, memory, and vision. So I'd like to conclude by saying our previous knowledge of cortical and subcortical anatomy has been superseded. The HCP has illuminated our understanding of both brain structure and function. Incorporating this knowledge into the principles and practice of brain surgery is absolutely essential. It's mandatory. If we ignore these networks, we are not giving our patients the best possible treatments, and we're not allowing them to make informed consent. This revelation of the HCP challenges the concept of eloquent versus non-eloquent brain. And I would contend to you that there is no such thing as non-eloquent brain. Thank you very much.
Thanks so much, sir, for the wonderful talk. Sir, thank you so much for the very deep insight into this very important issue of brain cancer, brain tumors, and all the eloquent part of the brain. We now have the privilege of inviting our next
Yeah, hold on, Nora. We have some questions here. We want to take them. Okay, Uday Gupta, could you come on the panel, please, and ask your questions of Charlie? Go ahead, Uday. It's your chance. Are you there, Uday?
Oh, look, if I've gone over time, John, I apologize, and we don't have to take questions out. I mean, I've got the chat program here. I can respond to them by
Yeah,
typing.
okay, that will be fine. That will be fine. Whatever question, he had a question about fellowship, et cetera, et cetera. So please answer those questions on the chat.
I'll answer them on the chat.
Sir.
Okay, thank you. Okay,
Thank you so
Nora.
much, sir.
Okay, Nora, we're back on track. Go ahead.
Thank you so much, sir. First of all, Dr.
Sorry
Samis.
for interruption. Okay,
Yes.
thank you, Professor Teo, for this excellent presentation. Unfortunately, I didn't show your slide, but I heard it all the time. Thanks again for accepting my invitation. And now we're back.
Okay, Nora. I guess we're going to go on with Carlos. So I'd like to say a few words about Carlos. Carlos, are you there?
Hello. Yes.
Yeah. Okay. I've been working with Carlos for a long time. We did a lot of webcasting in Latin America with Neurosurgery TV, and I'll let Nora do the proper neurosurgical introduction. Go ahead, Nora.
Thank you so much, sir. First of all, thank you so much for giving us the honor of presenting your very wonderful work and sharing your wonderful the treasure of your knowledge with us today. Sir, everyone knows you quite well. We've been following your lectures lately, but for the sake of formality, Professor Carlos is a neurosurgeon from Hospital General Universitario de Ciudad de Real in Spain. He has done a lot of work with special interest in neuro-oncology and research, and he has also supervised and conducted several workshops and webinars. Sir, thank you so much for coming today and for sharing your views on this very important topic. Sir, the floor is yours now. Sir, can you share the screen?
I think he's setting up now.
Sorry, I looking for a.
Yeah, the screen share. I've been having problems today in Zoom. I don't know if Nora, you noticed that a couple of speakers have had problems with sharing the screen.
Just a moment.
Mm-hmm.
Dr. Carlos, yeah, okay, so he's the co-host now. Yes, it's not.
Yeah, he's working on getting the screen share going.
Yes.
No luck, huh? I've not seen this happen with Zoom before. Okay, I believe he went off. He's going to rejoin. Maybe that'll work. So just hang in there. Nora, can you move your camera? Your camera is kind of low. We can only see half your head.
Yeah. I can see that. I just
There he goes. Okay.
Thank you so much, sir.
Good afternoon for everybody, and thank you very much for this possibility to speak with you. In this afternoon, we will speak about awake craniotomy protocol from brain gliomas. Is an experience from Spain in the Ciudad Real, in the university hospital. We now say that in many cases, when the patient had some problems with some lesions in the brain tissue, the first question that we are doing is what we will do with these kinds of lesions. If the lesion is located near of eloquent areas, such as speech, language, or visual centers, or in a motor or sensory areas, what will they do in these cases? What is the risk of the permanent deficits in the language, speech, motor, and sensory function in these cases? Maybe if we see some kinds of these lesions, we can wait and see until the tumor causes some neurological deficits. Or maybe we can do in a biopsy, then after radiotherapy or chemotherapy. Or we can think about the surgical treatment. If we decide a surgical treatment, what kind of options we can choose? We can do it under general anesthesia, or we can select an awake surgery. If we do it in a awake surgery, we can decide if in one or more sessions. So on an awake craniotomy, in an ancient times, was used for trepanation to treat seizures and remove a variety of pathological conditions. There are a very described history of these kinds of surgery in the described by Dural history of awake craniotomy for brain tumor and spread in the Asia. So on awake craniotomy is another techniques, Renaissance maybe. In the modern era, they are described very well for Penfield, who used in the epilepsy treatment. Thereafter, Penfield and Pasquet write on a surgical and aesthetics aspects of these kinds of surgery. And awake craniotomy is going on due to improvements in anesthesia techniques, the development observed in the neuroimaging techniques, and the development of neuromonitoring techniques. So before they speak about awake craniotomy, we can ask about how many people are studied so much harder in the knowledge of the functionality of the different brain areas. One of this is the French neurologist, Paul Broca, who described anomia in one kind of lesions in the brain structures. Thereafter, in the modern area, so many investigators, so many doctors studied very well the different brain tissues, brain areas, such as drawings by Evelyn Royland, who is studied about their defects and their impairment after occupying lesions in the brain area. And awake craniotomy was the first description in the intraoperative applications of direct electric current into the human cortex was do it for Robert Bartholow in 1874. So many years passed between they are describing the modern methods and principles were pioneered by in the 20th century by Krauss to describe it, the map of human motor cortex. Thereafter was developed by Kirschen, Forrester, and Penfield. Penfield and Ullmann as working very well in epilepsy surgery. Royle and Eveling, Schmidt, Eisner, we describe it firstly in oncological surgery. Berger was the first who applied the direct electrical stimulation method for mapping eloquent cortical areas for oncological neurosurgical purpose, who are describing the localization of cortical and subcortical motor and sensory pathways. Thereafter, Duval extended and codified the indication of a direct electrical stimulation of cortical and subcortical areas. In the next decades, this technique has spread all over the world. The wave craniotomy protocol was used before in epilepsy surgery, such as was said, oncological surgery, in deep brain stimulation, and in other kinds of surgical procedures. The main indication for the wave craniotomy is to operate near of eloquent brain areas on different procedures, such as testing the treatment modalities such as deep brain stimulation, peripheral nerve stimulation, motor cortex stimulation. And the other thing is that the people who are passed under wave craniotomy have a shorter hospital day. The principal or the main objectives of the wave craniotomy is the assessment and identification of the functional neurological outcome of the patients with lesions in eloquent brain areas. We can do it a pre- and post-operative assessment of language function in patients whom surgical resection are includes or is close language areas. We can detect and assess the patients at risk of post-op aphasia, and we can reduce to the minimum the functional impairments after 6 weeks of post-op. A wave craniotomy requires one team with an experienced neurosurgeon, an anesthesiologist, shape neuroanesthesia, neuropsychologist, neurophysiologist, and a very good surgical nursing team. But the first and the major requirement is the patient who can cooperate, who can training for this cooperation with a hemodynamic and stability, secure airway, patient and alert. We can very observe about the environment, giving to the patient a comfortable lying position and a temperature, and to look about the noise. The main is the excellent communication with the patient. In the intraoperative monitoring, we can have a routine monitoring such as blood pressure, pulse oximeter, blood pressure monitoring, Vis monitor, control of diuresis. But the most important is to ensure the patient comfort. About the anesthesia techniques, you can use local anesthesia, escape blockade, ensure an adequate sedation and analgesia. But more, again, it's very important to maintain a communication with the patient and ensure their comfort. This in the pictures, you can see the sites where you can do it, the trunk blockades on the skull blockades, you can use for the local anesthesia short and long acting agents with or without epinephrine. We can see about which one has what kind of cardiac toxicity the seizures provocation. We can know about the propofol decrease the potential of the seizures. In our institution, we always use lidocaine and bupivacaine combined. The objective of the intraoperative neuromonitorization is to help provide basic, advanced, and fast monitoring of certain neurological functions at risk during surgical procedures. We can know the change in neurophysiological responses should alert the surgical team to make adjustments during the procedure. We need, I said before, a neurosurgeon with experience who believes in neurophysiological monitoring, who understands and knows limitations of the neuromonitoring, who know the correct monitoring of each surgical type, who understand the cause of technical changes, and ready to act appropriately in the time. We need one anesthesiologist who will be familiar with your neurophysiological monitoring, be knowledgeable of anesthetic effects on neuropsychophysiological parameters, be willing to adjust anesthetic techniques to accommodate the responses, be able to identify physiological and treat the different pharmacological changes, who provide support the blood pressure during surgical change. It's important. An anesthesiologist who check the position and possible nerve compression, check and increase the blood pressure, the anesthetic agents that can convert to a total TIVA, optimize the hemoglobin, use a muscle fluorescence as showed for the case, who optimize the temperature of the patient. The neurophysiologist who know the interpretive neurophysiological experience, knowledge of the type of surgery and kinds of anesthesia, ability to differentiate and find solutions to surgical, technical, physiological, and pharmacological changes, to have an important, good communications with the surgical team. We need a neuropsychologist who is familiar with our conditions, who have a good technical knowledge of a neuropsychological test in pre and intraoperative conditions, and important, who have a good communication skills with the patient and surgical team. We can use an electrical stimulation, and we know about the excitatory phenomenon and inhibitory phenomenon. There is an excitatory phenomenon as a sensory motor cortex and visual cortex and auditive cortex, and an inhibitory phenomenon such as language, memory, and higher cognitive functions. In this picture, you can see how we can do it, the speech area stimulation or speech area mapping. One can do it to the stimulus in the first time. We given a visual stimulation for the patient, and we can analyze the response given for the patients during this stimulation. In these pictures, you can see the cortical and subcortical stimulation. You are knowing the inversion phase of the central sulcus. In the second pictures, you can see the motor area stimulation, such as in the abductor stimulation or the abductor area. On a cortical map, key points as we need this as a good standard. It's a real predictor of functional outcome. This procedure is used to map in the brain and applying the current directly to the cerebral cortex by inducing temporary and localized activation of the disruption. The cortical mapping varies according to the studies and the institutions. The cortical mapping, we can do it under general anesthesia by motor evoked potentials or somatosensory evoked potentials, and in awake craniotomy with a stimulation from one area of the cerebral cortex. We can have responses, verbal, movement, emotions, and sensations during these procedures. The speech testing is doing to identification of the brocasalivary induced speech arrest, identification of other cortical language areas by reading and words compression, such as in Wernicke areas, by data presented to or performed by the patient. And a polyglot patients may be a great challenge. The language areas may be a multiple within the craniotomy. The distribution beyond the area of Broca and Wernicke, it's very different. What is about the mosaic distribution? Approximately says 1 to 2 centimeters, and 50% of cases are separated. They can be in a parietal, lobar, and frontal cortex. You can help these kinds of evaluation preoperatively by PET or functional MRI. For patients with to awake craniotomy protocol, the inclusion criteria are tumors adjacent to eloquent areas, example, left peninsular tumors, tumors in pericentral gyrus, but they can be monitored under regional anesthesia as well. Recurrent or untreated lesions near or within the supposed language areas, Broca or Wernicke. The age between 15 and 70 years, be fluent in Spanish or other language, but spoken under compression. And mentally oriented, no severe aphasia before surgery. The exclusion criteria, absolutely sleep apnea, obstructive, claustrophobia, dementia of patient, and relative contraindications or exclusion criteria, epilepsy, refractory to drug treatment, airways of difficult access. The complications may be seizure, conversion to general anesthesia, respiratory depression, airway obstruction, oxygen saturation decrease, arterial hypertension, nausea and vomiting, and other things. But very important is the complications related to the patients, such as a need of sensation to urine, feeling cold, dry lips, itching of the nose. The imaging needed for this kind of surgery is as an MRI compatible with neuronavigation, MPH axial slice of 0.8 millimeter thickness. This study can be fused with DTI and or fMRI. In the neurolinguistic evaluations, we can use a formal neurolinguistic test, such as an Ashner aphasia test. This consists of 5 subtests: handling test, repetition test, writing language test, visual naming test, and underlying test. In our neurolinguistic evaluations, Substance errors will be classified as known, minimal, discrete, moderate, or severe according to the rules of Ashner aphasia test. Preoperative patient's information training, and at least 3 days before surgery, patients should be informed in detail about the process of intraoperative monitoring. The patient should be familiar with the material used for the stimulation and trained to perform the test. Operative management overall assessment establish a good relationship with the patient, inform the patient about all stages of surgery and others such as control of drugs, special anticonvulsants, or medications may be a great challenge for these kinds of surgery. The patient position is very important to increase the comfort of patients, to reduce the intraoperative stress and anxiety, to allow the correct visualization of presented stimuli and comply with the requirements of the surgeon. As said before, anesthesia techniques, and we can observe about pre-medications. What's about the basic monitoring? We need doing a bladder catheterization. We can decide if we are doing a totally wake craniotomy, just with local anesthesia, or we can do it on a wake sleep craniotomy. In this picture, you can see the areas that will be blocked, the trunks or nerve trunks or the scalp blockade. For the electrical neurostimulation, we have two possibilities, such as a monopolar stimulation or bipolar stimulation. The monopolar stimulation, paramedic stimulates trying to 5-7 with another stimulation, intensity of 2 to 16 milliamperes, frequency of 250 hertz, pulse duration 0.2 to 1 millisecond. The advantage of monopolar stimulation are mainly the risk of crisis is very low, 1.8%. Also, you can get with an AMG response, so you can measure the amplitude and latency of response and compare the previous care. The disadvantage is mainly the less focal stimulation than with bipolar. And with this type of stimulation, we cannot perform a language mapping. The bipolar stimulation or bipolar mapping, we are doing with an interelectrode distance of 5 millimeters. Stimulations involve times of 5 milliseconds, 2 milliamperes, and with a frequency of 50 to 60 hertz. The stimulation intensity angle gradually increasing to a maximum of 16 milliampere. In the literature, they are seeing that we can extend under 20 milliamperes. If a post-discharge intensity appears to be of a 2 millimeter below the post-discharge, and mapping should be performing at this intensity. The post-discharge threshold observed in a boring region should not limit the intensity of stimulation. After stimulating the cerebral cortex, the patient must be observed to view movement. In the language area, deficit should be assessed after it has achieved a carefully baseline, such as after performing a test of visual naming objects displayed for more than 1 minute and at 5 seconds intervals. With bipolar stimulation, an area will be considered eloquent if the patient has movement or has an error of language consistent of at least 3 separate triads. The mapping thresholds is defined as the minimum carrying required to induce a motor response or alteration of language after increasing the stimulation intensity to trigger a response, the post-discharge results. The main advantage is that bipolar stimulation is more focal and can map the language area because the stimulus during 5-7 seconds. The major disadvantage is the risk of seizures. It's about 10-25%. We need to have used a concomitant electrocorticography. The bipolar stimulation can induce a tonic muscle contraction, making very difficult to the measures and compare this response to previous. We need to use, in these cases, the electrocorticography to monitoring the brain activity of patients continuously searching for the presence of this post-discharge activity in the absence of clinical signs of seizures, or such as known as a no-convulsive seizures. This is the capture that data that we shaved during the awake surgery, type of lesion, localization, symptoms, if the patient used or not anti-epileptic drugs before surgery, where are stimulated areas, the stimulated areas, if they have an umbral or post-discharge, milliamperes, umbral mapping discharge, if we have some kind of deficits, localizations, and the proximity of the eloquence area. The language test, we are using a visual naming test, and a word generation test, an understanding sentence test. The test should be performed 3 days before and after surgery within 21 days and 1 year after. And a visual naming test, the test is a robust activator of the essential and non-essential lingual cortex, especially the broadcast area. The word generation test, we need to use a word generation, is known as a robust activator of the frontal language areas. The answer to name objects present in auditory form requires the patient to say the name of object that has been described. So it seems that the test also activates language areas in the frontal lobe. The understanding sentence, the patients are presented with 2 identical phrases at all except for 1 word that is replaced by a synonym or a different word. The patient should listen to this pair of sentences and decide which of the 2 has a literal meaning. The test is a pointed activator of the perisylvian cortex. During the wake procedure, just I would say that control of blood pressure is important for with electrolyte level of consciousness. Maintain antiemetics, antiprophylactic, anticonvulsants, analgesics. If any of the complication, infection, seizure, neurological dysfunction, bleeding, cerebral edema, or intracranial pressure increment, we need to do a cranial CT control. Thanks.
Okay, very good. Very good.
Thanks.
Nora?
Thanks a lot, sir, for the amazing talk and the wonderful points you have shared. This really means a lot because it is, there are young neurosurgeons like me, especially, who are just looking forward to know all of these points. Thank you so much again, sir, for the huge honor you have given to us by delivering your wonderful talk with us today. Let me have the pleasure of introducing our next speaker, Dr. Xiao Ching Chen, who is currently.
Yes.
Thank you so much for joining us here. It's a matter of great honor and pleasure for us. Dr. Xiao Ching Chen is currently working as a neurosurgeon at Taipei Veterans General Hospital, And he has a lot of interest in research work and neurosurgical neuro-oncology, especially. So we are really pleased to have him here today as our speaker. Dr. Shao Chen, this floor is yours now.
Can you hear me? Zoom asked me to reopen this software.
Yes, we can.
Zoom is acting crazy today.
Yeah.
You can't open the screen share. Is that the problem?
I think he's having the same problem as most of them today. I don't know what's wrong with you.
Yeah, well, it's happened with Carlos and Diu Pujari.
Sir, I guess you have a few questions in the chat box. Professor Carlos, a few people want to.
Yeah, Harshad has a question. Go ahead. Yeah, go ahead. That would be a good time to ask it if you want.
Dr. Shao, I think, can you please test your screen share now? We are having a lot of trouble now today with the screen share function.
There we go. Yeah. Okay, we're starting.
Okay.
Not quite yet.
Taking a bit too long.
Did you see? No?
Not yet. Not quite yet. It looks like you're on the way. There we go. Good. There we go. Make it presentation mode.
Okay, so you can see me now.
Yes, we can see you now.
This is full screen?
Perfect, perfect.
Okay, first, thank you for Professor Hassan. Thank you for the kind invitation. And let me join this great event. And thank you, Noor and John, for the great hosting. And I'm Shao Qingchen from Taipei Veterans, from Zhenxing General Hospital. And today I'm going to give a short talk about fiber checks and the lateral service and its surgical application. In the past 2 decades, we have had major progression in diffusion tensor imaging and also the human connectome project. And this arose many neurosurgeons' interest in the old fiber dissection technique. And I'm one of those guys. So I spent 1 year in Istanbul with Professor Yashagil and Professor Ture to learn this technique. And it is my honor today to share something I've learned from these grandmasters. So this technique, the girls' fiber dissection, this is not a brand new thing. And in fact, this has been the major method how we learn the brain anatomy. And since this is Cairo Symposium, I just want to point out that the term, the brain, is first coined and documented in the Edwin Smith papyrus. But we do not know much about white matter until 3,000 years later, the 16th century, the Italian anatomist Marcello Malpighi, he first used a microscope to prove that white matters are composed of fibers. And also, he improved the brain fixation by boiling the brain in water. And Steno and Thomas Willis, they separately describe the scraping method. We are still using this scraping method to dissect white matter tracts and remove the gray matter today. The Raymond Fusons, he described the scraping method and he improved the brain fixation by boiling the brain in oil, and he described the semicentrum overlay. But the major progression is by Johann Christian Heil, a German anatomist. He developed the modern fixation technique, which is soaking the brain in alcohol. Nowadays, we still use this technique. And by the help of this technique, he see a lot of different things from early anatomists and makes a major progression of the white matter tracts dissection. And until the mid-19th century, the 20th century, Joseph Klingler, he frees the brain after fixation. And nowadays, we're using this frozen technique to improve the fiber dissection. And in the 20th centuries, the 2000s, Professor Yashagir and Ture, they revitalized this fiber dissection technique. So basically, the fibers are classified into 3 categories. the association fibers which interconnect neighboring or distal cortical regions at the same hemisphere. There are short association fibers, such as U fibers or arcuate fibers, and there are long association fibers, such as cingulum, uncinnated fasciculus, arcuate fasciculus, superior and inferior longitudinal fascicular. And another category, the second, is the commissural fibers. Commissural fibers cross the midline and interconnect matching areas of the two different hemispheres, such as corpus callosum and anterior and posterior commissure. And the last part is the projection fibers. The projection fibers connect the cerebral cortex to the brainstem and spinal cord, such as coronal radiata and internal capsule. So when looking at the lateral surface of the brain, nowadays we can easily recognize the different lobes which were demarcated by Pierre Gauchelet in the 19th century. We usually discuss the lesion as it was located in the frontal or the temporal or the occipital lobes. However, Professor Yashagil proposed that while dealing with intra-axial lesions, we should try to be more precisely. We should describe it at the location with the gyri-based information. For instance, we should describe it at the precentral gyrus, the supramarginal gyrus, or the middle temporal gyrus. Nonetheless, we frequently neglect that more gray matter, about 2/3 of it, was hidden in the deep sulcus than presenting on the surface. After removing the gray matter, we immediately see the subcortical short association fibers or U fibers connecting the adjacent gyri. And if we remove the gray matter and short association fibers along the Sylvian fissure, we will find this long association fiber tract that runs backward from the superior temporal gyrus, course upward through the parietal lobe, and then goes anterior toward the frontal operculum, surrounding the insular lobe. As everybody already knows, this is the arcuate fasciculus that connects the Wernicke's area and the Broca's area. But as Professor Tao says, there is much more than this. And by the side of the arcuate fasciculus, the superior longitudinal fasciculus is located deep to the middle frontal gyrus, inferior parietal lobule, and middle temporal gyrus. It also encircles the Sylvian and insular lobe, connecting the frontal, parietal, occipital, and temporal lobes. But actually, for the past 200 years, the AF and the SLF were considered a synonym, which means they're the same. Christian Heil first described this AF-SLF system in 1909, and Carl Friedrich Budak recognized his observation. In the late 19th century, Joseph Dejerin and Karl Wernicke adopted Budak's designation and both conceived these fascicles as a unitary system. And in the late 20th century, when the fluorescent isotope tracers were introduced, the AF and the SLF were finally separated. I just want to point out they could be differentiated by the DTI technique too, but it is not possible to precisely delineate or demarcate the margin between the AF and SLF by this girl's fiber dissection technique. And the SLF first, second, and third, which was written in recently published papers, could not be differentiated by this technique either. So after removal of the insular cortex, review the extreme capsule. The extreme capsule is the principal long association fiber bundle of the superior temporal region. It connects the superior temporal cortex to the prefrontal cortex. And removal of the extreme capsule, you will see the claustrum, the gray matter in the region of the insular apex, and the external capsule. The external capsule conveys fibers from the frontal, temporal, and parietal region to the putamen. And this picture is from the Gray's Anatomy, and I drew the red mark, which stands for the claustrum. Lateral to the claustrum is the extreme capsule, and medial to it is the external capsule. And the deeper portion of the extreme capsule and the external capsule consists of fibers of the occipital, frontal, and uncinate fascicula. These fiber tracts are located beneath the basal portion of the insula. The uncinate fasciculus connects the temporal pole to the orbital aspect of the frontal lobe. Because the orbitofrontal cortex is very close to the temporal pole, the most medially situated fibers in the fascicles are curved as the U fibers that cover the bottom of the socket. The uncinate fasciculus has been considered part of the limbic ring. In the medial surface, the cingulum connects the whole limbic lobe, except the most anterior part. The uncinate fasciculus connects the separated frontal and temporal region and makes the limbic lobe a ring. A removal of the external capsule reveals the putamen. A removal of the superior longitudinal fasciculus exposes the posterior portion of the occipital frontal fasciculus. The occipital frontal fasciculus is a long association fiber bundle. It connects the occipital and the frontal lobes as it passes through the basal portion of the insula, immediately superior to the uncinate fasciculus. And if we remove the putamen and the globus pallidus, we will see the internal capsule, which separate the corpus striatum into the caudate nucleus and lentiform nucleus. And we will also see the anterior commissure. The anterior commissure might probably be the first described fiber tracts. It was first noted by Riolani in the 17th century and followed by a number of other early anatomists, including Raymond Fusons and Felix Victazil. Some fibers of the anterior commissure merge with the uncinate fasciculus at the temporal pole, but most fibers are directed posteriorly and eventually merge with the occipital frontal fasciculus to form the sagittal stratum. In classic descriptions, the sagittal stratum and optic radiation is a synonym, which means they're the same. But actually, diverse bundles of white matters were observed to contribute to the sagittal stratum, including the occipital frontal fasciculus, optic radiation, anterior commissure, inferior longitudinal fasciculus, and inferior thalamic peduncles, and so on. So again, these fiber tracts cannot be differentiated by the Girl's fiber dissection technique. Thus, the sagittal stratum may be considered the equivalent of the internal capsule of the posterior part of the hemisphere. And it is the major cortical, subcortical, afferent, and the efferent system that links the cerebral cortex with the thalamus and the pons. And medial to the sagittal stratum, lateral to the ventricle, you will see the tapetum fibers. These are callosal fibers. And the optic radiation or the temporal loop is probably one of the most complicated fiber systems. And this special view is to see how the optic radiation connects the thalamus, pons, and as well as other diencephalic and brainstem structures to the cerebral cortex. And I was frequently asked, how does this knowledge help our surgery? Do you see fiber tracts during the surgery? My answer is no, I don't see fiber tracts in my surgery, but it does help my surgery a lot. Here I will show a demonstrative case. We have a patient, 51 years old male without previous diagnosed systemic disease. And the major symptom is that he has progressive aphasia for 2 months and right side limb weakness. And preoperatively, he could barely speak a sentence. He can only speak phrase of words, and he could stand, but his right side muscle power was 4/5. And you will see the preoperative image, a huge temporal tumor. To my opinion, this is a superior temporal tumor according to the coronal cut. This tumor compresses the basal ganglia and makes the midline shift. And this is a huge high-grade tumor. We did the preoperative DTI. The yellow, the green stands for the arteriovenous fasciculus, and the red and the yellow are the superior-longitudinal fasciculus, and the purple is excellent tract, which might not be very important in this case, and the blue one is the corticospinal tract, and the white one is the active radiation. The tumor closely attached to these fiber tracts. Can you hear how he speaks? I don't know if anyone speaks Mandarin here, but he could barely say any sentence, just words.
Don't understand Mandarin, but we hear him talking.
Okay, so it was during Chinese New Year, and we suggest him to be operated before the holidays, but he insists he has to spend the Chinese New Year with his family. And I didn't notice that in about 10 days, the tumor growth was dramatic. And so I let him go home. But before the holiday finished, he was brought to the hospital, the emergent department, because of drowsy consciousness. And you can see just 10 days, like every 10 days, the tumor growth 50%. So I have no choice but to bring him to the operating room by emergent operation on Sunday. So I was not able to bring my whole team to do the neuromonitoring or the awake craniotomy because it's during the Chinese New Year. And to the right is frontal, to the left is the temporal, and this is Sylvian fissure. I choose to do the corticectomy in the anterior part of the superior temporal gyrus to avoid damage to the supposed Wernicke's area. And after the corticectomy, some cystic fluid turn out, but most of the tumor are solid tumors. So I like to take like each part of the tumor, I like to take some specimen to avoid underdiagnosis. And this high-grade glioma surgery can be very bloody, but to what I've learned from Professor Toure or Professor Sanford, the best way is to take the tumor like a bigger part, piece by piece, instead of take some part and stop to coagulate. If you take the tumor faster, then you can reduce the blood loss instead of continuously stop and do coagulation. But sometimes if you see vessels and it bleeds very like a lot of blood, you have to stop for coagulation too, and this is necessary. And when you toward the end of the surgery, and you have to gradually slow down because you are close to the vital structures. For instance, all of a sudden I see the bleeding, the color of the bleeding change. It become more fresh and red. And I knew this is arterial bleeding. And if you see carefully, you will see the tiny arteries. And for me, this looks like the arteries supplying the basal ganglia. So I first try to gently coagulate. And if the bleed continues, I will try to use some hemostasis agent. For instance, and this is, you see the tiny arterial vessels, and I use the fibrillar Serge cell to compress these tiny arterial vessels to avoid over coagulation, and it usually stops the bleed. Then when you see this kind of vessel, you know, also in insular tumors, you know you're approaching the end of the surgery, so you have to be very slow. And I keep taking the tumor. All of a sudden, I notice this yellowish substance, and for me, the yellowish substance looks like structures from the basal ganglia. For instance, it could be the corpus striatum. So I know this is the last part of my surgery, and I decide to stop since I don't have neuromonitoring, not the awake craniotomy team, and I think it's time to finish the surgery. And I like to put some hemostasis agent to avoid postoperative bleeding. And just at the post-operation, 2 days after operation, he speaks like he feels it's normal. He can speak as he used to be. And this is a dramatic change after the operation. And how could it be possible? He says his speech is normal. And the postoperative image shows, I think most tumor was taken. And at the end of the surgery, this is very close to the basal ganglia, and this is the internal capsule. So very close to the basal ganglia. And we did postoperative tractography. And you can see the fiber tracts are preserved, and including the optic radiation, which looks better than preoperatively. And I don't see fiber tracts during the surgery, but as Professor Gouture always say, you should know that fiber tracts was there, and you don't see it, but you should know it was there. And this is how anatomy improve our surgery. And we did pre and post-operative visual field test. And I don't know why preoperatively the right eye is much worse than the left side. And my ophthalmologist told me that it might be due to the IICP. And post-operatively, we didn't see dramatic improvement of the visual field. This is about one month after operation, and we will see if it improved. So here's the take-home message. The modern technologies are fantastic. I like IMM, IMRI, navigation, awake craniotomy techniques. They are all very helpful, but the legacy, what we've learned from the masters, the anatomical knowledge could not be overemphasized. It helps our surgery. And just with anatomical knowledge, you can do good surgeries too. And the last is the minimally invasive surgeries. Just want to echo to Professor Bashkaya, and he mentioned yesterday that minimally invasive surgery should be to the brain, not to the scalp or skin. And we should respect the normal anatomy. Professor Yashagir always says that don't disturb the normal brain structures and leave it there. As Professor Toh said, now you cannot say those are non-eloquent area. Every brain region has its function. And again, thank you for having me here, and thank you. I'm so happy to learn with everybody, and thank you.
Thank you. Thank you very much, Dr. Chen. We have a question from Harshad. Are you there, Harshad? You want to ask him on the screen? Harshad, are you there?
Yeah, I'm here.
Go ahead. Let's see your beautiful face, and please ask the question.
Yeah. Excellent, wonderful presentation on the fibers. Shown very well and superbly done. I agree with you. Okay. It is difficult to see during surgery what are the fibers when you are dissecting out the tumor. And
yes,
yeah. But can you make out whether the basal ganglia is involved or not involved during surgery? Is it possible for you to see anyway?
Yeah, the basal ganglia, since the basal ganglia, it's gray matter. So I think it's probably, you can feel that it's putamen or it's caudate nucleus or even it's thalamus. If you are an experienced neurosurgeon, when I observed Professor Gouture's surgery, he was always like telling me, this is putamen. And believe it or not, this is internal capsule, believe it or not. This is thalamus, believe it or not. And this is what, believe it or not. You don't really see very clearly the margin, but the gray matter is different from the white matter. So if you are experienced surgeon, for instance, you will see some yellowish things with spotted vessels, and it's a character of the corpus striatum. And Professor Sanford yesterday, he mentioned the same thing. So it's possible. You cannot see very clearly the fiber tracks, but for the basal ganglia, if you are experienced, you will know it is there, and it is the putamen, the globus pallidus, the caudat, thalamus. It's possible.
The yellow part which you left behind while resecting the tumor, did you felt it was a tumor or it was a normal structure with a yellow staining?
Yeah. I feel that it looks like the putamen I used to see. And so I stopped there. And the post-operative image shows that did not see obvious tumor. And the operative field, you can see it ends at the lateral side of the basal ganglia. And usually the image I show is immediate post-operation, like 2 days after operation. 3 months later, you will see some picture like Professor Tao just showed, a very beautiful margin of the putamen, well demarcated and with a cavity.
What was the histopathology of this tumor which you resected shown last?
Okay, so this is a GBM.
GBM.
Yes.
Okay. Thank you. Very nice presentation. Thank you.
Thank you so much.
Okay, Sam, do we have our next speaker ready? Oh, we're going to go with Noah. I'll introduce Noah, okay?
Okay, so
okay, Noah, I met Noah online. If anyone has spent time on the internet, they know who Noah is, especially in the neurosurgical area. And I finally refer to her as a whirling dervish. She's full of energy. And we've been working with Dr. Borba, doing a webcast with the WFNS, and Noah is working with that. So she's going to talk about some of the projects that she's done and some of the projects we're going to do in the future. So welcome, Noah.
Thank you so much for having me here. Thank you so much, Professor Xiaoqing Chen, for the wonderful lecture. First, I think I should give a little chance if Professor Jimmy Cheng is here. Professor Jimmy, are you here? Professor Jimmy Ming? If you are here, can you please show up? So if you are here, then I will certainly try to have him before I get away with my own presentation.
Oh, okay. So he may be here. Okay, that's fine.
Yes, yeah, exactly. So
that's fine. That's fine.
Yeah, exactly. So if Professor Jimmy Ming is here, can you please show up, sir? We are waiting. If you are here, kindly let us know. Or Professor Pu Hao Hung, if you are here, kindly let us know so that we can proceed with you first before I go ahead with my own presentation.
Okay, we gave it a shot, but apparently they're not here. So go ahead, Nora, take it away.
Okay, thank you so much. It's a matter of huge honor and pleasure for me to share you some of the initiatives of the WFRS Education and Training Committee that I've got the honor to organize and to look after under the direct supervision and direction of Professor Luis Forma. Can you see my screen?
Yes.
Okay, actually, I haven't quite prepared for this preparation, but I really wanted to share this up. Today is the World International Brain Trauma Day. So first of all, I would like to share a little slide upon the World Head Injury Awareness Day that is observed annually on 20th March. It is to educate the general public about traumatic head injuries. There is a rising incidence of head trauma in all parts of the world, but especially in the low middle income countries where it has achieved the form of a silent epidemic. So it is a matter of, a great concern for us, especially neurosurgeons. While we are at the end of treating patients, we should also look for all those factors that have led to all such unfortunate accidents. In case we can avoid as much as possible, that will reduce the morbidity and mortality in general and will also lead to a much healthy, healthy population. So first of all, I would like to share this. It is time to raise awareness, obviously, to prevent the head trauma as much as possible, and every small step counts. So if you think that whatever is in your capacity, whatever you can do for it, you should go ahead to prevent this very unfortunate, incident of having a head trauma in the community. So every small step counts. So better roads, road safety measures, trained drivers, the use of seat belts for car drivers, the use of helmets for bikers, speed limits and awareness campaigns from the level of schools are very important, are a few important steps that we need to take. So we should actually, we ideally should educate the school students regarding road safety and how they should, act when they are in the car or in the bike. So we actually need to educate at the very, at a very lower level, so we can have much better level of awareness in our population, in our communities. So please do have this type of psyche in your mind and educate as many people as you can. We actually wanted to organize TraumaCon 2022 today on 20th of March, but because of WFNS event and a lot of, busy schedule, we rescheduled it in April. So we are arranging a TraumaCon on TBI on 9th of April, that is next month, that will be on 5 p.m. Pakistan time, 7 a.m. EST, as well as 9 a.m. Brazil time. Please do join us because it is going to be a wonderful event. We will have the experts discussing TBI and educating trainees, students, and obviously junior neuroconsultants. So TraumaCon 22, this is our official ad. I've got the privilege of working under the direct supervision and direction of the WFNS Education and Training Committee and Professor Luis Borba himself, who is taking a lot of interest in education, in neurosurgical education at all levels, from the level of the students to the level of consultants. So it is a matter of great pleasure for me to organize all these activities under his very kind supervision and all the direction that he gives. And he's very concerned and he's doing wonderful initiatives in the field of education. And I'm really pleased to organize this TraumaCon with him under his direction and under his supervision. We will have this TraumaCon next month on 9th of April. As you can see, we have got Professor Tariq Khan and Professor Andres Rubiano. Both of them are, the aces of trauma, of neurotrauma. So we are really pleased to have them as our speakers, and they will discuss all of the important aspects of the traumatic brain injury. Moreover, we will also have, some innovative initiative of having a virtual workshop. It will be a short workshop, although we will proceed with longer ones in the future as well. But it will be a workshop that will be conducted under supervision of Professor Anila Darbar, who is the medical director of MASH, that is the Mukhtar A. Sheikh Hospital, Multan. She's doing amazing in all these things. He's been very, interested and has always been interested in organizing wonderful workshops. Her workshop is on the neuro ICU care, which is a very important topic. And I think every doctor, even if he or she is not in neurosurgery, should know about the neuro ICU care. So I think this is a very important topic that we are going to discuss in this virtual workshop. You can scan this QR code to get registered with the TraumaCon 2022. We still have our abstract submissions open. We will stop taking more submissions by 29th of March. So if you have any poster or any oral abstract, you can still send us on our email address, that is wcnmsmr@gmail.com. We have got the e-poster hall. We will showcase all the posters that we have received, and obviously this is a certified event, and it is totally free. We are doing it just totally free, and we are not getting any sponsorship as well. So it is something that we are doing with all our dedication. So the World Congress of Neurosurgery for Medical Students and Medical Residents was an initiative that I was pleased to take with Professor Luis Borba. Basically, it is a brainchild of Professor Luis Borba himself. He wanted to have an organization just for, junior neurosurgeons from the and not only just do junior neurosurgeons, but also medical students and junior trainees and junior consultants. So he wanted a course, a dedicated course for us. He wanted a dedicated course for all those junior practitioners that are practicing neurosurgery, so that they can be taught the basic fundamental concept of neurosurgery, as well as the common neurosurgical conditions and how to manage them, how to deal with all of them. So he wanted all of these, and also he wanted to touch the updates in neurosurgery, the recent advances, to a level which should be known to all of the neurosurgeons. So he wanted something like a very comprehensive, yet a concise course, because he really believes that after 20 minutes, no neurosurgeon is having, all of the attention focused towards that academic event. And it's very true. And I really appreciate, I really agree with it, because whenever I would say that I would like to have a longer one, he said, no, it's not the right way to just get the focus on the topic and do not have a very prolonged one, so everyone can actually attend it. So we will have, we divided it in a monthly 3 hours long module. We have got 11 modules, and we have successfully completed 2 of our modules, and we are left with 9 more modules in this 1-year-long course of WC and MSMR. I'm really pleased to organize this course. This will just cover the fundamental concept of neurological surgery, and will also teach the most commonest neurosurgical conditions neurosurgeons deal with on their floor. I don't think that we have got any such dedicated course before, and I think this is the need of the hour. We believe that the junior neurosurgeons needed the most, and in junior neurosurgical training, I've been a trainee myself. I've completed my training, but when I was a trainee, and it's not very long ago, just I say 4 years ago, when I see myself, I think that we always needed a course that would address the basic things that we deal with each day, so that we have a good insight. And even if we know, we should have the confidence to practice them. So it is for the very first time, this is a course that has been designed to address all those basic things that we deal with and that we should know in order to well equip a neurosurgeon to deal with all the cases he or she deals with daily and manages it with full confidence that he's doing the best thing. Please do join this course. It is a 1-year certified free course under the supervision and direction of Professor Luis Borba. This is our module 1. We were really honored to have Professor Osama Al-Mufti as our special guest. He joined us for the module 1. He rather inaugurated our module 1. It was a matter of huge honor and pleasure for us to have him. We have this module covering the aspects of neuroanatomy. We have Professor Paulo Kadri and Professor Victor Hugo Perez and Dr. Bawa Katib here. This is Professor Luis Borba himself, who always wastes enough time to look over all of those activities and do all this supervision. And it's a really wonderful course. It was a wonderful experience for us, and it was a very, we had the honor of having 1,000 registrants for this course, and during the first 24 hours, about 1,500 people viewed the recording on YouTube. This was our basic agenda for module number 1. You can see we had a wonderful faculty. Professor Luis Borba selects all the speakers himself. We later on proceeded with modules due on neuroradiology. It was especially arranged on Women's Day to celebrate the achievements of women neurosurgeons. We wanted it to be, a little special. We never wanted it to be arranged in a cliched way where we just discuss the achievements of women neurosurgeons. We wanted to show the world that what women neurosurgeons really are, that they are academically so strong and they are professionally so strong. They can deliver lectures in the most impeccable way. So we conducted an academic activity where we invited all the ACE women neurosurgeons from all around the world. We had Professor Najia Al-Abadi, who is the first African women neurosurgeon to have been elected as WFNS president-elect. We had Professor Nelsie Zenon, who is the chair of the Education and Training Committee of ISBN. We had Professor Fozia Sajjad. She will be delivering lecture today at the EWNC as well. I'm honored to be her student. She was she was one of my mentors during my postgraduate training in neurosurgery at PINS, the Punjab Institute of Neurosurgery. That is the largest dedicated neurosurgical unit in the public sector in Pakistan, one of the largest, and we have all the possible equipment present. We are giving the best treatment. I'm really pleased and honored to be a part of that training and a part of that wonderful institute. And Professor Fozia Sajjad is the first woman professor of neurosurgery in Pakistan, and she's right now chairing the WINS sector of Pakistan with the PSN, Pakistan Society of Neurosurgery. We also have Dr. Luana Gato from Brazil and Dr. Carolina Benjamin. We are also coming up with this wonderful new book, a manual for the enthusiastic neurosurgeons. Again, I will be collaborating with, I will have the honor of collaborating with Professor Luis Borba. We will cover all the aspects of all of those topics we have covered in the one-year course in this book as well. So all those topics that we are teaching in this one-year course will be included in the book. And we will be really pleased to publish it by the end of the year when we will end our one-year course. You can you can scan this QR code to follow our page on the Facebook. We will be really pleased to have you, to welcome you in our TraumaQuant 2022 on 9th of April. We will also be announcing the module 3 of our one-year long course. It will be preferably on the surgical approaches, but we are yet to finalize our speaker list. Again, thank you so much for your patient listening. And if you have more queries regarding our course and our initiatives, we will be really pleased to answer that. Thank you.
Thanks a lot, Noor, for your great job today and your excellent presentation.
Thank you so much.
Now you will introduce our next speaker, Professor Najia Al-Abadi. Professor Najia, are you ready? She is taking my name. Okay, just 1 minute. Just 1 minute, and she will start.
You see her in there, Sam?
Yeah, she taken my name.
Hello?
Oh, there you go. Okay, you're all set.
Hi, Professor Morsi, how are you?
I'm fine, thank you, Najee.
So sorry, but because I just stopped my car as I sent you, and I was in between Casablanca and Rabat, and I do my best, of course, to give a lecture. Sorry, you know that I am on my way from Bogota to Rabat, as I told you yesterday. So it's my turn to where there are some discussion maybe.
Okay, if you are not ready for now, we can shift to Professor Fawzia.
No. So tell me, I will take my time. There is another talk before mine.
No, your talk is now.
My talk is now. Okay.
Okay.
Let me try to share my screen.
Okay.
Okay, please just okay. I will do it.
No, you can introduce Professor Najia until she shares her screen.
Sure. I'm really pleased and honored to. Can you hear me? I'm really pleased and honored to introduce Professor Najia Al-Abdi. It's a matter of huge honor for me to welcome her to the EWNC event. She's the first woman neurosurgeon from Africa to have been selected as the WFNS president-elect. She has been doing some amazing work for the WFNS in neurosurgical education lately. She has organized several workshops and webinars, as well as presiding several of the Moroccan Society of Neurosurgical on-site events before the pandemic hit us. And later on, during the pandemic, she organized long webinars and courses through the platform of the Moroccan Society of Neurosurgery. She has been also supervising the Rabat Training Center for fellowships for the WFNS. It's a matter of huge honor to have her here today as our speaker. Last time I had the honor of welcoming her on our module 2 that was organized on the Women's Day. Professor Najia, are you here? I think we are all having a little bit of internet issues today.
Yeah, I think it's just an internet issue there. Well, we'll give her a second. Give her a second. Nora, could you move your head up, please? You're half in the screen and half out. We want to see your whole face.
Yeah, and then actually I connect my DSLR with my computer, so it was something. Okay.
Oh, you can't do it.
It's back in. It's back in.
There you go. There you go. We get to see the full whirling dervish.
Okay, thank you. Professor Najia, are you there?
We'll just be patient. I'm sure she'll be back.
We've got Professor Fozia here.
So she's
okay, I think Dr. Najia, yep, joined us again. Hello, Dr. Fazia. Welcome.
Okay, it's up to you, Sam, where to go from here.
She is online now. Dr. Najia, can you start your screen sharing? Okay, I think we will call for Dr. Fazia until Dr. Najia get ready.
Yeah, I think.
So we got,
yeah, I think. Are you sharing?
Dr. Najia. No, this is Dr. Najia trying. Dr. Najia trying to
Oh, okay. I think she's sharing the screen. We are all having a lot of internet interruption today, and with the Zoom, I think it's a little nuts today. You know, on Saturdays there's a lot of rush on the internet, so we usually have such problems in sharing our screens and in everything, in communications, etc. I noticed myself that my internet is it's so much slow today. I cannot even Google anything if I need to.
Is Najia there?
I think she's trying to share her screen. Madam, can you turn your video on? We can see your screen, but we cannot see anything else right now.
Okay, we will.
Okay, Sam, take charge. Take charge, Sam.
Okay, unless I contact Professor Naji again. Thank you. Professor Fawzi,
Okay, okay. Okay, sure. Thank you so much. Thank you so much, Dr. Same. And again, thank you so much for having me here as a moderator. I'm really honored and pleased to introduce Professor Fawzia Sajjad. I'm so much pleased to share that she's one of the mentors of mine from my postgraduate neurosurgical training, from the Punjab Institute of Neurosciences in Pakistan. It's a matter of huge honor for me to invite her, introduce her today. She's the first woman professor of neurosurgery in the public sector in Pakistan. And she's also the first woman neurosurgeon who has done FRCS in Pakistan, as well as she has got a lot under her belt to share.
Nur Huda, sorry to disturb you, but I'm here. I think I hope that you will can share my screen.
Okay, well, let Sam take charge. We'll let Sam take charge. Go ahead, Sam, take charge.
Okay, I am, of course.
Well, let Sam. Sam, are you there?
I am here.
Okay, take charge, please, Sam.
I am
okay, screening my, I am sharing my screen, please. Is it okay? Did you see my my slide?
Yes.
Yes,
we do.
It's okay.
It's okay?
Go ahead.
So can I go
Yep.
ahead? Oh,
It's
wonderful,
okay.
wonderful, because
Go ahead.
this is a really challenge more than surgery, neurosurgery. You know what? Because I am in the between Casablanca and my home, and sharing the screen. We having you know stable connection is really very trouble, one of my challenge in my life. So, okay, I can, Professor Morsi, I can start. Maybe I can start.
Yes, you can.
Okay, sorry, but the screen, this is something that happen with screen. Let me just check in 1 second, please. Is it possible to stop it and I will go?
Yes, try to get the good choice.
Okay. Okay, I think we will finally. Okay, so is it correct now?
Yes.
It's okay.
You
But,
see my
this is-
slide? Totally my slide?
Yep.
Yes.
The first slide.
Okay.
Okay, the slide is in a completely full screen.
Yes, ma'am.
Yep.
Okay, so thank you so much for this disturbing your wonderful and amazing webinar, because we have for at least in this time when
I'm sorry, Doc, I have to interrupt you. We're not seeing the screen correctly. Could
Okay, I don't know what happened.
Let's get it right. At the bottom, there's a.
I will solve it. Give me
manipulate it, please. We're not seeing it.
Give me 1 second, please.
Yeah, sure. No hurry. There's no hurry.
Sorry, really,
No
really,
problem.
really
No
sorry.
problem.
Because,
you need to put it on presentation or slide mode.
okay, I am just.
We're getting there.
Oh, sorry.
Okay.
Let me.
For some reason, it's just not working right.
I don't know what happened, but
yeah.
My screen.
Okay, you can try F5 button.
Maybe Why? But let me.
She's using MacBook, I guess. Madam, I think you are using the Mac, so it is a
Okay,
little
don't
different
worry,
there,
it's
yes.
okay
That's good.
now.
That's
It's
good.
okay now.
Perfect.
Is
you
it
had
okay now
it.
or not yet?
You had it.
Oh, my.
It's okay now.
Uh, is it okay now?
Yeah.
Wonderful. Okay, so I will start I can start my presentation if you want. Okay.
Okay, go ahead.
So
Go
thank
ahead.
thank you for everybody, Professor Dr. John. It's wonderful to have you with us always and supporting our all webinars. And I hope that we will see you in person in the future in this later, in person, because hopefully now we can meet in person. So let me first to congratulate Professor Morsi as chairman of the oncology in WFNS committee, and thanks him to invite me to be, of course, one of the lecturers. And I am just coming from Bogota, and I can tell you that we had really a nice, wonderful, amazing meeting. You know what? Because it's the first World Congress of the BFNS in person, just after, a few days after the stopping, to having, of course, the authorization to travel. And we had a nice time. I think that you follow some pictures in many Facebook and so on. So thank you for your invitation. All of us knows. I will start my. Are you hearing me, please? Oh,
it's okay.
Yes.
And the slide is better.
Okay, and the slide is perfect. Everything is
Okay.
good. Okay.
Yes. Perfect. Perfect.
Concerning the first, sorry, just I'm going to go back. So all of us you knows that this location of meningiomas represent a real challenge for neurosurgeon, because the thin relationships between the neurovascular structures and tumor, especially when the size of these tumors are very important, such as the most cases of our series in Morocco and the low LMIC, low and middle income countries. And concerning the epidemiologic aspect, it's this variety, that's very well, it represents 10% of meningiomas. They are usually big when diagnosis, and they are benign, but high rate of recurrences comparatively to other locations. Let me share with you our series since 2005, little than more 100 now. In my experience is more than 500, but I have taken only the more 120 maybe 20 to 45 cases, because the documentation is well done. So there are different variables of location, as you know, in there and in the anterior skull base that we will go over. So many classifications are published in the literature, and all of them join the Cushing classification. And all, of course, the Cushing classification is the first one according to their anterior skull base location. There are some in the middle midline. Okay. So I will start with the first one is the ethmoidal and the frontoethmoidal, also known as olfactory of Grove meningioma. This location represents, as you know, 8% of the anterior skull base meningioma. And this CT scan in this slide, it shows the implantation on the crista galli, which is partially calcified. And you see the importance of the perilesional of course, edema, and frequently they could be bilateral, as you see here. And you can see its impact on the olfactory, of course, growth and the compression on the frontal lobes here. And you can even see the erosion in the skull base on the CT scan. Is shown in this slide here in the CT scan. And exceptionally, they could be cystic. Is it? I think. Where is it? It's not on the slide, but I will show you one cases of of course.
I think we're having some bandwidth issues.
Please, what do you say?
Oh, the internet's just slowing us up a little bit. It's okay. Go ahead.
Okay. The second variety is the Trigeminal sphenoidal meningioma, and this. Let me show you this head X-ray shows a meningioma of tuberculum sella, which extend to the planum, to the planum sphenoidal with a balistering of sphenoidal sinus. I know that a few of us, of course, using now the X-ray, you are go through directly to CT scan and MRI. But this is if in low and middle income country, if they didn't have in some places CT scan or MRI available, that they can suspect the diagnosis on X-ray. This is very important. It's a message for LMIC. This is this blistering of sphenoidal sinus. And the MRI of the same patient, you see the meningioma is really isoantenous in the MRI. At the same time that they compress the frontal lobes and sprays the chiasm. And the second case shows a big tumor with important perilesional edema. I am insisting on that and highlighting this fact of edema because this is very important to prepare the patient for surgery. So, the third and fourth variety are tubercular sella and diaphragm sella meningioma. They represent around 6% of meningiomas in this location. And the first case shows the difficulty to identify the real insertion, and it also shows the tumor englobing the arteries of anterior circle of Willis, sometimes the pituitary salt. This can predict preoperatively the hard management of this tumor and the high complication rate. So the second case here, it represents a medium-sized tuberculoma, sella meningioma. Tuberculum, not tuberculoma. I am more. I am a little bit speaking sometimes about tuberculoma. This is this lapsus. So that we can specify is extension into the sella turcica. It has no edema. However, on the MRI, the limits are distinguished, easily showing the diaphragm cellage between the tumor and the gland. You see the enhancement of the tumor and the chiasm divided of compressed, but it is not the frequent situation. Most of the time, it's per-operative consultation. And the third case shows hyperostosis of the tuberculum planum and a part of sella on the MRI, hyperostosis, tumor, and the gland. So here you see the diaphragm sella meningioma. There are three types. Type 1 is originating from the upper leaf of the diaphragm cellar anterior to the pituitary stalk, presents with unilateral visual defect disturbance and visual field defects. The type B is originating from the upper leaf of the diaphragm sella posterior to the pituitary sulc, causes fewer visual disturbance, memory disturbance, and pituitary occur. And the type C is originating from the inferior leaf of the diaphragm cell, and this bitemporal anopsia and hypopatuarism are common. So the another location of in this anterior skull-based meningioma is sphenoid ridge meningiomas. They are classified into 3 groups: deep inner medial clinoid type. In this first kind, there's 3 types according to the classification and Osama al-Mefti, and the lower clinoidal, super and lateral clinoidal, and optic canal location. The second, of course, location in this sphenoid ridge meningioma is alar and middle type, and the third is general and or lateral type. So the sphenoorbital meningioma is intraosseous tumor. Usually they causes significant hyperhaustosis, and this tumor always spread like a carpet. Involves lesser wing and the sphenoidal bone, orbital cavity roof, lateral wall of orbit, and the bony is most of the time apart. Many may include in this invasion and anterior clinoid process, superior orbital fissure, optical lateral, and sphenoidal and ethmoidal sinus, as most of the time are invaded by this tumor in this type. So the last one is the cavernous sinus meningioma. So this tumor, as you know very well, may start inside and spread outside, or start outside the sinus. May involve very vital sinus neurovascular structures, may involve optic nerves, chiasm, pituitary gland, and stalk. May invite also sometimes the sphenoid sinus and clivus and petrous bone. It's one of this is particular in this location. So you see this slide. We need some armatorium to to operate these patients, and it needs some tools like a good surgeon. It's not tools, but this is one of the challenges neurosurgery. So when we start really this surgery, of course, we need many years. We need many years to be more masters in these fields. And high-end operating microscope, cutting loops, microscope, neuronavigation, endoscopy, and so on. So, principle of meningioma surgery: always look for cranial nerves, circle of Willis, branches and perforators, pit sulc, and hypothalamus. Focusing on preserving the function is very crucial, important, and avoiding, of course, a lot of brain retraction. And the last message is don't touch the vein. It's very important, very important. So the gold standard of the treatment of meningioma is surgery that should be done whenever it's possible with low morbidity. These tumors are usually hemorrhagic, so we should plan transfusion to reduce the bleeding. We should always start by the insertion zone and perform the resection on block when with the size, of course, of tumor allows it. You see on this film the coagulation of nourishing pedicle, but if the tumor is huge, start by debulking first, and sometimes shrinking it by bipolar, as I'm doing here in this video, and coagulating and remove it by fragmentation. For this surgery, we need maximum of tools. Bipolar, as I said, I mentioned just before, laser dissection. Some others use neurovascular. I never use it in this of course, location, because we need to have a good knowledge of anatomical landmarks. It's in my opinion, it's enough. So you need to the target of surgery in these especially kind of tumors. Total removal is our, of course, goals, but we need also to preserve functions and avoid injury, especially an intracarotidal artery and the anterior carotid anterior complex, optic nerve, chiasm, and their vascular supply, pituitary stalk and olfactory nerves. This is a very important thing to say, during the surgery. We have to have a good knowledge of course, of the anatomy. And you know that the most variety of the chiasm, in more than 80%, it's normal chiasm. You give here a corridor to go between the optic nerves and here the carotid nerves. But in 730 respectively, you can have a prefixed chiasm and posterior and post-fixed chiasm, and it's a little bit more challenging surgery, because you don't have a real corridor to do surgery easily. So what are the main surgical approaches we can use to reach the tumor of this area? Let's start with the bifrontal approach. First of all, after the flap bone, we start with exposition and control the suprasagittal sinus. The advantages of this approach are large control of the dural implantation, dissection of the dura, draining the bone. Inconveniences of this approach are opening of the frontal sinus, which exposed to infection, late control of posterior part of tumor, and more cerebral retraction and conductive olfaction. This is very important. This is the quality of the life that we need to look for very carefully, of course, of our patient. Here is CT scan of 54 years, and the old woman operate by this approach before and after surgery with good outcome. Here, unilateral frontal approach still frequently used. It's of course today the only one that I will use in my daily practice is the one we usually use, but it depends on the size of the tumor, of course. But the advantage as respect of the contralateral frontal lobe and the sagittal sinus, of course. Inconvenience are narrow approach and more traction on the frontal lobe. Usually it's of course the right lobe. I will show you some cases where this is unilateral approaches was performed. The first case of meningioma or of sphenoidal planum, little bilateral on the right side. You see on this video, here is the medial line, and here is a cranial. Sorry, but come back. Cranial. Okay, you see the video. Right side, you see the film, and is the middle line, and is cranial base here. And we start by coagulation, of course, this insertion here, and removal by progressive fragmentation on the tumor, and see the frontal lobe without retraction is not the frequent situation, because in this patient is old patient, and of course the frontal lobe was a little bit retracted. This is a very interesting case. A 40 years old woman diagnosed 1 year later. The patient refused the operation. When I saw her, she had a gamma glucose scale at 9, and the tumor size was more than 10 centimeters with the bilateral and posterior extension. So we started firstly by in a unifrontal approach for decompression and reduction of the tumor. After clinical improvement, we performed the second operation on the other side. She left better after 3 months, but there was still a residual fragment posteriorly, maybe radiosurgery, and I just saw him a few months before this presentation, and she had I sent him to the gamma knife with this a small residue, and she had of course a good outcome. We at that time, when these cases is from I think 2015. So maybe you could be criticized for using unilateral approach, but for me it was very important to start with unilateral just to decompress and to improve the clinical fields before to use the second bilateral approach to achieving, of course, the most residual approach. And then if there's still in this case some residual posteriorly that we couldn't be able to reach it to have a radiosurgery. This is a case diagnosed as giant aneurysm of anterior communicating artery on MRI, but you will see that it's surely meningioma with another fragment to the anterior carotid artery, which obliged us to leave this part, as you see on CT scan control. When the lesion is in the middle, this approach is not indicated because the control of the posterior pole and the contralateral side is very difficult and hardly achieved. You see on this CT scan control showing the partial resection and the difficulty to achieve it. Let me please point at something very important that is said in this last Bogota meeting by Professor Majid Sami. He gave us very good advice. You always need to use the frontal, not unilateral frontal side. It's not important, to use the others different approaches as orbital, zygomatic, etc. You need only the frontal lateral, because the only cases that we need more bigger approaches when the skull base, anterior skull base was invaded and the tumor goes down and below in the fossa nasal. Okay, so you hear some these cases is very interesting. Just so the invading of all the bone here and orbital, sphenoidal, frontal, and we had long surgery, and we had also hopefully a good outcome with we see here the CT scan after the neurosurgery of the sphenoorbital meningioma surgery outcome. Okay, so frontal orbital nasal approach is, I think, one of the last that I will speak about it. We found the bilateral frontal orbital nasal approach preferable to the bifrontal approach for gaining low basal exposure and for removing the upper portion of giant meningiomas without brain retraction. This approach presented here has the advantage of 1, minimizing the retraction of the frontal lobes, 2, preserving frontal bridging veins, 3, interrupting blood supply to the tumor early in the procedure, and the 4th, optimizing internal decompression of the tumor, and finally offering direct access to both sides of and the posterior and upper aspect of the tumor permitting extra-arachnoid excision and facilitating resection of the dural origin and in any bony lesions. These third cases performed by this approach, which I have started since 2005, honestly, I found it very easy, and it has become my most favorite one for olfactory growth meningiomas. And you see, we have a good follow-up in this patient who is the wife of one of my anatomopathologist, of course. So here you can see, of course, some location in the cavernous sinus, and the surgery is not easy. We start by surgery, of course, but we let a small residual. So if we can't more, logical, we send it, of course, of gamma knife. So endonasal endoscopic resection. This endoscopic endonasal technique for resection of olfactory growths and sphenologicum meningioma is more and more used by some others. And here showing the different steps to conduct the surgery, resection of the tumor and closing tightly the dura, which represents the mainly difficulty of the surgery. Many authors insist on also on learning curve. It's very important. We can start, of course, of the to go to the pituitary, but use this endoscopic, large endoscopic and extended endoscopic is not easy, and we have only a little experience with this technique about meningiomas. So I think, can we predict the quality of the resection? In my opinion, the answer of this question is usually no, as is shown in this case. In medium-sized sphenoidal planomeningioma, we thought at first that operation can be performed easily, but we ended by leaving a remnant, as you see on this CT scan, listed stable during the 6 years of control. So do we have to offer him radiosurgery now? I think maybe in this case, I will more I will assist on very bigger bigger of size of the tumor. I will send it to the gamma knife. 3% of patients, among which neurological defect, infection after CCF on the or opening the frontal sinus. This is a really it's a good, very difficult issues. And now I am using the neuronavigation to avoid to opening the frontal sinus because I saw many patients in the last years that I operating them more than 20 years, and they come back to me with the infection. So epilepsy, etc. We don't observe any date in this series, and recurrency represent 5 to 7%. So the gold standard is surgery, as I mentioned, and as you know very well, and which complete resection should be the main aim with low morbidity. Or unfortunately, due to the importance of structures in this area, this aim is often hardly achieved. This is the reason why it's unacceptable nowadays to conceive severe morbidity that can be skipped out by completely radiosurgery, that is efficiency of the remnant of meningiomas. Skull-based meningioma represents a bad prognosis factors. Combined treatment, incomplete microsurgery and radiosurgery is recommended each time that surgery was difficult. And it is a nice Latino sentence, primum non ser, the art to cure without damaging or under all its forms. L'art de guérir sous toutes ses formes, in French. This is my first language, and let me to, of course, just tell you in French. All the authors in the letters said we should to use radiosurgery for remnant of meningiomas, no more radiotherapy for benign tumors. Please, no more radiotherapy for benign tumors, in my opinion, is a mistake. So in conclusion, resecable progressive meningioma with low functional risk should be removed at big-sized progressive meningioma, which the complete resection can induce important functional risks. Should discuss a combined approach, partial resection, and completion by radiosurgery. So thank you very much for your attention. And are you hearing me, please?
Yes, it's okay.
Okay, so I finished my talk. I'm so sorry for all this disturbance because I am on highway between Rabat and Marrakesh, and sometime you heard some loud, and sorry for that. Okay, so I will stop the sharing of my screen, and I'm here for I'm apologize, but for few minutes, if there is any question, you allow me that, because I have to move to Rabat. Thank you so much.
Thanks a lot, Professor Najia, for this excellent presentation, and for your effort to join us today. Deeply appreciate. Thank you. Is there any question from panelists?
Thank you so much.
No, do we have any questions?
No, so far I haven't noticed any question in the chat box or in the Q&A. If you have got any question, kindly drop it in the chat section, so that we can communicate it we can convey it to the speaker. I don't think there's any questions so far.
Okay, it's great, because I have to leave the highway, because I am in the highway between Casablanca and Rabat. If there is any question, maybe before you, most of the people have my contact. And Noor, you are here, and I know what you are doing for the education. And I would like to congratulate you, because in Bogota, Luis Borba, the chairman of Education and Training Committee, he has shown us what you are doing for not only for the neurosurgeon, but also for the medical student too, and it was a really amazing work, and congratulations again. So
thank you.
Professor Morsi, thank you for this wonderful job that you did in this committee, and okay, see you soon. See you very soon.
Thank you.
Bye-bye.
Thank you so much, madam. Thank you so much, madam, for the wonderful word. It means a lot to me. Thank you so much for all the support. Professor Luis Barba has been so kind, and I'm really honored to. Thank you so much, madam. Thanks a lot for the wonderful word.
Bye-bye.
Bye, ma'am.
Good luck. Bye.
Bon courage, ma'am.
Thank you. Bye-bye.
Bye-bye, ma'am. I think we can proceed with our next speaker. Okay, Dr. Same, Dr. John Bennett, I think we can now proceed with Professor Fozia Sajjad.
Yes.
Thank you. Thank you so much. I'm really honored and pleased to introduce one of my own mentors from postgraduate neurosurgical training of mine. I'm really honored and pleased to have the privilege of working under Professor Professor Fozia Sajjad, and she's the first woman neurosurgeon to have been appointed as professor of neurosurgery in the public sector in Pakistan. She's also the first woman neurosurgeon who has Pakistani woman neurosurgeon who has done FRCS, and also she's chairing the WIN sector of Pakistan Society of Neurosurgery. So it's a big pleasure to have her here with us today, and I'm really honored to introduce her here. Madam, can you please share your screen?
Good evening, everyone. Thank you very much, the organizing committee. Thank you, Dr. Noor, for inviting me and for giving me the privilege to present at this forum. I'm grateful to you and congratulations to the Neurosurgical TV on its 6th anniversary. I will present the insular glioma and comparing the results in the lower middle income country with limited resources. Insula is really an esoteric present. It's the hidden lobe of the cerebral cortex. Its anatomy is quite complex. It has pivotal role in autonomic, gustatory, olfactory, vestibular, and auditory functions. It's responsible for motor integration. It's responsible for the somatosensory inputs and pain processing. And it's also responsible for generation and planning of the motor speech. Moreover, this insula is quite in vicinity of important neurovascular structures, the descending corticospinal tracts, the striatum, the uncinate and the arcuate fasciculus, they all, and the arborization of the middle cerebral artery with the long and the short perforators, they make this area quite notorious for the excision of the cerebral cortical tumors or the gliomas. The functional MRI, due to its based on the oxy and deoxyhemoglobin signals, it make it possible to find out or to detect the brain activity indirectly and to demonstrate the speech language areas as well as the eloquent areas on the brain preoperatively, so as we can identify a safe route for identification for the access to the tumor and can safely excise that tumor. The diffusion tensor imaging, because the 3D reconstruction of the white matter tract can be obtained preoperatively by using the diffusion and isotropic images, as the water molecules can travel along the axons, and this information can helpful in 3D reconstruction of the axonal fibers, and in that way the surgeon has an ease to identify in which area the tumor, the white matter tracts are nearby to the tumor, so that they can have command on surgical and confidence in the surgical excision of the tumor in the areas like insula. Neuronavigation, although not so much helpful in the brain tumor as it's helpful in case of the base of skull tumors, but however, this is helpful in identifying that now the extent of the tumor has been reached. Now the brain mapping has totally changed the concept of excision of the tumor near the eloquent areas. The direct cortical stimulation as well as the subcortical stimulation, they are helpful in identifying the speech and language area, the descending corticospinal tracts, and in that way they are quite helpful for the surgeons to excise the tumor safely and to get the maximum safe resection without morbidity. Now, either the patient has insular glioma on the dominant hemisphere or on the non-dominant hemisphere, the brain mapping is mandatory in most of the centers of the world. This is our beautiful country, Pakistan, the population of 230 million people. This is the, with its worth seeing greenery in the plains, the elegant mountains, the splendid seashores, valleys, and the lakes. We are not a poor country. We have the world's largest reserve of the gold and copper in Balochistan. We have quite reserves of the natural gas as well as oil and number of the minerals. But unfortunately, because of the corruption, because of non-professionalism, and because of the political immaturity, we are unable to utilize all the previous gadgets which I mentioned for excision of brain tumors in our country. This is my institute, the Punjab Institute of Neurosciences. This is a dedicated hospital of 500 beds that is dedicated for the neurosciences. It has 10 operation theaters. 2 are working round the clock, 7 days a week for trauma. It has the outpatient number of almost 400 patients per day and the emergency 100 to 150 per day. Here now we are struggling for all the gadgets, the functional MRI, awake craniotomy, and all these things. And soon we will be able to get and to do surgery with the help of all these modern gadgets. Our recent data states that we basically operated 59 patients over a period of 5 years, irrespective of their age and sex. Our 61% patients had right-sided insular gliomas, while 39% has left-sided gliomas. We recorded all their data and we planned their surgery. After their surgery, we were successful in near total resection in almost half of the patients, 51% patients, and partial resection was possible in the remaining patients. Although we face certain focal neurological deficits, motor dysphasias, and motor weakness and dysphasias in few of our patients. When we collected data, we found that the seizure was the main presenting symptom in 46 patients, and followed by the weakness and difficulty in speech. We categorize all our patients according to into different zones as defined by Berger and Sinai in relation to whether they are suprasylvian or infrasylvian, whether they are anterior to the foramen of Monro or posterior to the foramen of Monro. We found that most of our patients have involvement of more than one zone, almost 30 patients, 51%. Only few followed by the patients having this single zone involvement and all zone, and then there are certain patients who have all zones involvements. We planned surgery by transsylvian route in most of our patients and transcortical routes in the remaining patients, although we were not using the brain mapping. But in the transcortical route, we selected all those patients whose tumor is involving the opercula or near to the surface and try to enter from the non-eloquent area. In the transsylvian route, what we achieved, we operated all patients with 45-degree rotation or towards the opposite side. A typical pterional flap was raised, and in that patient, we widely and longer sylvian fissure was exposed. We identified the long and the short perforators and skeletonized the middle cerebral artery branches so that we can have an access to the tumor and try to extend our dissection to the interior, superior, and inferior insular sulci. Then we also take care to avoid too much retraction of the opercula, to avoid traction, specifically superiorly, to avoid traction on the corona radiata fibers. After skeletonization, we try to coagulate the small perforators because most of the blood supply to the insular tumor, they are from the short perforators of the M2 and M3 branches. But we take care not to avulse these vessels near the middle cerebral artery. And we also take care to look for all the vessels that are extending postero-superiorly, or in other words, the longer perforators, because they are supplying the corona radiata, and we try to save them. We extend our dissection anteromedially and try to identify the lateral lenticulostriate arteries. After doing all that, we carefully, with the help of bipolar and sucker, try to emulsify the tumor in between the different corridors and try to excise this tumor. Even we use the CUSA in case of the low-grade glioma, but try to use that CUSA in such a way that its tip first entered in the small corridor and then opened it, and try to avoid these striatum and to do a safe surgery. This is our operated case. This is our 38 years old young lady who presented with the seizures and weakness of the one half of body, almost grade 2/5. And we can see that T1 iso, T2 hyper, and heterogeneously contrast enhancing lesion that is mostly suprasylvian, involving the zone 1 and 2. And we adopted the transsylvian route and excised this tumor and were successful in excising most of the tumoral part. Unfortunately, its histopathology came the GBM, and then she was referred for radiation therapy. On her follow-up, she was fine, and there was no increase in the size of the tumor. This is another patient having a huge size tumor involving all the zones. And this patient presented with hemiplegia of one half, seizures, and with a bad Karnofsky. But we operated her and tried to remove the tumor and try to save her life. This turned out to be a grade 3 glioma. In many patients in which the tumor extension was into the temporal lobe, as well as the means the tumor has involvement of suprasylvian as well as the infrasylvian compartment, in such patients we did initial the temporal lobectomy here. And then this is the temporal side, this is the frontal side, and then we remove the remaining part of the tumor by skeletonizing the branches of the middle cerebral artery and to excise the tumor very carefully and gently. What we achieved, our results, they demonstrate that we are able to get a near total resection in almost half of the patients, in 51% patients, and partial resection was possible in 49% patients. Although our patient developed the focal neurological deficits and dysphasia in 1/3 of the population, and almost 15% patient developed motor weakness and and brain edema. As a result of that, post-operatively, we have to remove the craniotomy flap because we have financial constraints and we don't have the capability to keep our patient ventilated for 24 hours in all patients. Our almost 8.5% patients had dysphasia, and a few other complications were observed in our patients. This is the spectrum of the complication which we observed in all our patients. Out of the 8.47% patients who developed language deficit, we were able to detect the ischemic injury on post-op MRI, and luckily the deficit was not permanent, probably due to neuroplasticity, the patients they recovered. If we compare our results with the European or American good centers having cortical mapping and having all the gadgets, we found that in one of their, this is the study, they showed that 63.6% patients had intact speech pre-operatively. Out of these patients, 77.6% patients, they remained at their baseline level or improved post-operatively, while 8.4% patients have worse speech and 14% patients had new speech deficits. Gross total resection was achieved in only 60% patients. And if we compare that, we without cortical mapping and without usage of all the gadgets, we were able to attain 51% patients near total resection of the tumor. They documented that gross total resection was possible in more in the grade 3 and grade 4 patients. Probably this is true as due to the area of necrosis and soft tumor. These tumors can be excised more easily as compared to the low grade glioma grade 2, which has firm consistency. This is another study. It's showing that in grade 2 gliomas under cortical mapping, they showed a total resection only in 12.5% patient and a subtotal removal in 50%. And partial resection was possible in 37.5% patients. And they showed that language worsening is possible, was seen in 50% of the patients. This is another study from Nader Sinai, and he is the master of insular glioma, and even he mentioned that out of 115 patients, the 16 deaths were observed with all the so much sophisticated gadgets and with all these facilities. Morbidity and mortality is even seen in higher centers as well. This is a series of 20 consecutive patients in which no cortical and subcortical mapping was performed, and they found that their residual volume size is much larger as compared to the Berger's and Sinai's residual volume. So, and the more residual volume is in the zone 2, which is more in the posterior part of the insula. So what we learned that we found out that most of the Western countries and American centers, they are performing insular glioma with all the modern gadgets. Specifically, they perform as awake craniotomy. Such facilities are lacking in our circumstances. Probably one of the main reasons is the high traffic of brain tumor patients. When number of patients are operating in 8 theaters at the same time, then 1 or 2 this neuronavigation and CUSA and all these things, they are accessible for only 1 or 2 patients operated for brain tumors. So many patients are deprived of so much modern gadgets. Probably the reason is that in a populated developing countries, the tertiary care center who is receiving lots of patients from all over the country as well as from the neighboring country, the sucker, the bipolar and microscope, they are the only weapons of the neurosurgeon. The surgeon must have mastery and should develop the higher skills in the surgical excision of tumor and must have the excellent knowledge of the anatomy of the insula, where will be the central insular sulcus, the short and the longer insular gyri, and relationship with the eloquent areas. They all are important for the good excision of the tumors. Without cortical mapping, how we were successful to do all these tumors? Probably what I can conclude that we measure the dimensions of the tumor and even its depth on MRI. We assesses that the low-grade glioma on the T2 MRI and try to excise the whole T2 MRI if it's not extending into the eloquent areas. we categorizes the zones. We found out that which trajectory would be helpful to, and try to, even if we use the transcortical approach, we try to enter more interiorly through the non-eloquent area. We selected the transilineal and transopercular route according to the extension of the tumor, either remain in the depth or it's extending to the frontal or the temporal operculum. We found out that in low-grade glioma, CUSA is quite helpful in excision of the tumor, and we sprinkle papaverine as well as the papaverine soaked gauze to prevent vasospasm. And we found that this sometimes the small perforators, they went into vasospasm and temporarily. So later on, they are vulnerable to bleed. So with the use of papaverine, we can identify those small perforators and can coagulate them timely. So I must say that maximum safe resection of the insular glioma with acceptable morbidity is possible with improved overall survival and disease-free interval with mastering surgical excision. We, the people of the third world country, must start our first step for excision of the tumor in the depth of the brain in this complicated insular area. We should try to get all the modern gadgets, and we are striving for them. But it doesn't mean that without them, we should not operate our patients. If we have mastery of knowledge about the surgical anatomy as well as the surgical skill, it's possible to get the maximum safe resection even without the modern gadgets. Thank you very much.
Thank you so much, Diana, for the wonderful lecture.
Is there any question from panelists? Okay, if there is any question, please type it in chat box. Thanks a lot, Professor Fauzia, for this excellent presentation. Now we will shift to next speaker, Dr. Selfie. Welcome, Dr. Selfie. Okay, no.
Hello, we are really honored and pleased to introduce our next speaker, Dr. Selfie Oswari from Indonesia. She's a young neurosurgeon and has been active in the educational activities. You might have seen several of the Indonesian Neurosurgical Society Young Neurosurgeon Wing webinar on the net. She's also the co-chair of the WFNS Young Neurosurgery Forum. We are really pleased to have her today. She will be presenting her work on ICG application and endoscopic pituitary surgeries. So Dr. Selfie Oswari, welcome to the panel. It's really a matter of great honor and pleasure to have you here today with us. So the floor is yours now.
Thank you very much for the kind introduction, Dr. Nur Maria, and thank you very much for all the committee. And it's been an honor for me to be part of this excellent education. I hope I can share some of my experience, which is very little experience compared to previous speakers. Can you see my slide?
Yes, we can. We can.
Okay, thank you very much.
Thank you.
So, without further ado, I would like to discuss a little bit about ICG application in endoscopic pituitary surgery. So, as a preview, we know that ICG is a near-infrared fluorescence to visualize the difference in tissue vascularization. And in endoscopic ICG, it was used in pituitary tumors. In adenomas, it was found to be more hypofluorescence. So it can help to identify vasculature and assessment of blood supply to nasosacral flaps and also tumor identification. but there are no described criteria for the selection of cases in which EICG may be useful. And there has been no quantitative correlation of fluorescence to preoperative imaging. This was suggested by the group of Dr. Carrao, and they are trying to quantify the fluorescence in the comparing between the preoperative imaging and also intraoperatively how the fluorescence comes. Okay, sorry. So from the history, first agent, 2016, the initial ICG administration was before tumor removal, and the second was at the end of the procedure. So it is injected by the body intravenously and then followed by 10 cc of normal saline bolus. And then it will bind with the plasma protein. It were measured after that 45 seconds, around 45 seconds after the administration. And usually the optimal contrast ratio were present at 1 to 2 minutes. Of course, in endoscopic ICG, it will have some difference compared to other applications for ICGs. We will talk about this later. So in the benefit and limitation, in the benefit, it will be a real-time visualization, differences in tissue vascularization, and it can help us to enable to distinguish between the normal pituitary gland and pituitary adenoma. Then it can lead to complete tumor resection, hopefully, and preserve the endocrine function. And there are no adverse reaction, very minimal. But the limitation would be we need a specific ICG endoscope device, which is different from the usual endoscope that we use. And this technique stains the normal tissue after the ICG administration, whereas the tumor tissue stains to a lesser degree and with a time delay. So time is important, and also we need to, hopefully in the near future, we can quantify in the exact fluorescence so that we can compare it with the preoperative imaging. And the visualization is affected by the hemostasis of the operative field and the volume of a tumor mass. Here's an example case from the paper, 51 years old woman with a growth hormone secreting adenoma. This is the preoperative coronal MRI, T1, and this is the sagittal. And the appearance of the normal gland and the adenoma, it's under the white light. And here is with the near infrared ICG, 6 minutes after the injection. And then this is the after resection. And here is around 8 minutes after the fluorescence injection. So there are no more fluorescence, but the normal gland here, it stays a little bit longer compared to the tumors. This is another example from Dr. Carrao's paper. So here's the XLT1, this is the coronal, and this is for the patient with pituitary microadenoma, where it was thought that the normal gland visualization might be difficult intraoperatively. So they use the ICG, and then they can differentiate the gland and the tumor under an ordinary endoscope is here. But here with the fluorescence, it can distinguish better between the gland and the tumor. Here we can see in the visualization, it can help us intraoperatively to differentiate the tumor with the normal gland. Thus, we can prevent less endocrine dysfunction after operation. And here's the proposed flow chart where they can see the presentation to the stellar surface, and also they can preserve the pseudocapsule, so it's marked intratumoral bleeding, and they can have a clear differential pituitary gland and tumor post-contrast enhancement. So they are trying to make a quantified differentiation between the preoperative imaging and the intraoperative ICG fluorescence. Here is another paper from Amano Sensei. So I think he described this earlier at 2018, yes. So here's the appearance of the pituitary adenoma under the white light. And here's in the same field after the injection of ICG, but then he tried to emphasize about the distance between the scope and also where we where the field that we want to see how the ICG the fluorescence coming out. So here's in the 1 centimeters, here's in the 2 centimeters, and here's the 3 centimeters. This also will affect our subjectively seeing the fluorescence to differentiate the tumors and also the normal gland. And here's from to compare between the Verstegen et al. 2016 and Kamano Sensei et al. 2018. So the objective from Verstegen paper is to evaluate the fluorescence imaging in pituitary surgery and to assess the additional value of resecting adenoma tissue under the fluorescence guidance. They have 10 patients who was planned for transfemoral, and the ICG dose was 5 milligram to 15 milligram per patient, whereas in Amano Sensei et al., they use a exact 6.25 milligram per injection. And as a result, in 9 of 10 patients from Verstegen et al., histologically proven pituitary adenoma, the normal tissue showed a stronger fluorescence signal than the adenoma, but it stayed longer, of course, in the normal gland. And in Amano Sensei et al., after the injection of ICG, the intensity of fluorescence of tumor and normal tissue showed clear differences. And the margins from adjacent normal tissue and the surroundings of it can be differentiated clearly using different fluorescence intensities, time changes, and tissue-specific fluorescence patterns. This is another example. So here in the preoperative imaging, we can already assume where the normal gland is because it's not always visible, especially in the giant pituitary adenoma, which usually in our country, Indonesia, the low middle income country, we encounter more giant tumors. So it will be very hard to differentiate where the normal gland is. But here it showed that we assume that this is the normal gland. So when using the ICG endoscope, it can also trying to differentiate where the anterior lobes and the posterior lobes in 2 minutes of after application. And here is another example, a 59-year-old man with growth hormone producing pituitary adenoma. Here is the preoperative coronal MRI. And here we can see that the application of ICG can also help intraoperatively to show where the cavernous sinus and also the intercavernous sinus, so that it can help us to open as effectively the dura mater as maximum as possible without encounter the cavernous sinus intraoperative. This is our data in the last 2 years in this, actually in this pandemic year. So we have 93 patients that underwent the endoscopic transfemoral approach. Mostly is, of course, adenoma hypophysis for 71%, when we did around 11% for meningioma and chronic pharyngioma for 6%. For coroma. So here's the example in our hospital. Here's a patient with non-functioning pituitary adenoma, male, 65 years old, came with, of course, bitemporal hemianopsia. And here, I just, okay, I will try to make it as effective as possible. So here's after the opening and after removal of the tumors. And here's we're trying to dissect, of course, with a forehand technique. So we're using usually double suction or one suction and one dissector. Here we're using the Miranda dissector, which is very amazing. According to my opinion, it's one of the best dissector that we use for endoscopic cases. So we're trying to do a subcapsular dissection. And then with the help of ICG, we can see where this is, of course, the cavernous sinus, and then we can see where the normal gland is. Here. It will lights up more compared to the tumors. And here, we usually only use half of the dose for the intraoperative tumor identification, and we use the other half to make sure that our flap, we are using the vascularized flap, that it's also have a very nice blood supply. So after the resection, we are using the, of course, inlay only overlay technique, and then after that, for the vascularized flap, we are using the other half of the ICG to make sure that it's vascularized well and we don't have any flip, or so that we hope that the number of leakage would be low, which is it's what happened in our hospital. So this is another case, prolactinomas, female, 38 years old, and she's already on medication, cabergoline, and also Cripsa, and the patient already on medication for 6 months. After it's normalized, because it's also very expensive in our country, so we are trying to see if we can help her by stabilizing the medication, by doing the operation after medication, of course. So here, I'm sorry, I'll just have to go here. So here is after the resection, but then when we use, this is the normal gland, the pituitary stalk, the chiasm, but then after we are using the ICG, so we can see, of course, the blood will lights up earlier, after that the stalk and also the normal gland. But then here we can see that we still left some of the tumor here. So I think this is a beautiful example where we can use ICG to help us to take out more tumors safely. So we take some part of this out, and then we preserve the normal gland, of course. Okay, and here's the other half. We are using it for to make sure that our vascularized flap has a nice blood supply. Okay, this is another example in tuberculum salameningioma. We are using a double suction technique after an extended endoscopic transsphenoidal transplanum approach, transtuberculum approach, sorry, and then we are trying to dissect the tumor out, and then afterward, here we can identify the stalk, the chiasm, the optic nerve, the ACOM, the bilateral A1, A2, and then we just want to make sure that we did not take any important vessels out, and also we want to see that this is the superior hypophyseal artery is still intact, because we know that superior hypophyseal artery will give blood supply to chiasm, to optic nerve, and also the pituitary stalk. So we have to make sure that we preserve it quite well. And here is the vascularized flap that also lights up very nicely. And here is another example. This video was edited by one of our residents, Dr. Reza Arifianto. So this is a patient, 66 years old. I'm just gonna fast forward. Okay. So here we did the opening, and then it showed like a yellowish, and then we saw some of this like a jelly like grape-like, I think that's what he described. And it showed like it seems like it's a radical cyst. So then we want to see where the normal gland is. So we are currently using ICG in most of our cases, especially when it's available, of course, because we think that it will help us to minimize the complication and also to preserve the endocrine function. And one of the reason too, maybe in our country, Indonesia, it's a low middle income country. So if there's a medication that need to be taken by the patient, like for after the operation, which is a hormonal medication, not everything is available. And if it's available, it's also quite expensive. So for the patient, quality of life, it's very important to preserve the gland for us, because sometimes they cannot afford for the medication and they come with several other complaints instead of the bitemporal hemianopsia, of course. And this is another example for the extended endoscopic transfemoral surgery that we did for the tuberculum cell meningioma. So we try to preserve the superior hypophyseal artery. This is very nicely showed here, and the chiasm, and the ICG helped us to make sure that we did not break any vessels. And if we are confused or we are not sure whether the blood supply comes from just to the tumors or it's come from the superior hypophyseal artery, we also use it so that we know which arteries that can be sacrificed. So in conclusion, the use of endoscopic ICG is safe and it's feasible. It contributes to improve the total resection of the tumor and preserve the endocrine function. However, further research needs to be done to have more detailed information in ICG application for endoscopic pituitary surgery. This is some of the reference if the audience wants to read more about this ICG endoscope application for pituitary surgery. Thank you very much. This is our research assistant that helped me compiling all the data from the presentation. And in this opportunity, I would like to thank you very much. Thank Dr. Chanchili, Dr. Zade, Dr. Bernstein, and Dr. Konkam, my mentor during the fellowship, and also the Pittsburgh group, Dr. Gardner, Dr. Snyderman, Dr. Eric Wen, and Dr. Zenonos for giving me the inspiration on using the ICG for endoscopic pituitary surgery. Thank you very much.
Thanks a lot, Sophie, for this an excellent, informative, illustrative lecture. Is there any question from panelists? Thank you, sir.
There's one question, Sam. I think someone said very, very good presentation. Do you have many experience in pituitary surgery?
Thank you very much, John. Nice to see you again.
Oh, nice to see you. Do you see that question, Sam? It's on the chat box. Do you see the question?
There is a question for you in chat box.
Yeah, Maximo.
Okay.
From Maximo.
Okay.
Oh,
please answer it.
You have many experience in pituitary surgery. So what we have from the data is in this last 2 years during the pandemic area. So we have 93 endoscopic procedure pituitary surgery.
Thank you.
Okay, and now we shift to next speaker, Professor Pablo Aguilera. Please start sharing your screen. Thank you, sir. Professor Pablo.
Perfect. All set, Doc.
Dr. Moscoso, are you ready to start your lecture? Okay. Please start your. Thank you.
Okay, déjame. Sí, okay. Okay, thank you very much for inviting us into Mexico, into the Neurosurgical TV. Dr. Samed El Morsi Hassan, Dr. John Bennett from Miami, and my friend Victor Hugo Perez in Mexico. And we decided the theme we did it is going to be the treatment of wide neck aneurysm with jailing technique, or we're experienced in Tabasco, Mexico. The team we have is we're a team from neurosurgeons and therapists and the vascular. Here are my friends, my university, Universidad Juárez Autónoma from Tabasco. Tabasco, we are more than the south. We live in the southeast, with the state who can join the country because the Gulf of Mexico in the front, and our neighbors on the back is Guatemala. Okay, let's talk about minimal invasive techniques. Since 1993, that means 20 years since now, they decide to do it with the structure minimal invasive techniques, minimal neurotrauma at all, including everything from endovascular, keyhole, microneurosurgery, neuroendoscopy, radiosurgery, stereotaxy, new development techniques, and now we're trying to do something in biological fusion with Dr. Perilla from Colombia. And since 1993, they're doing a journal that's called Minimal Invasive Neurosurgery. What do we do in our town? We're still doing stereotaxy since 2003 that I came with the patient awake. We do it on spine too. High tech, better outcomes, less price. It's supposed to be the goal, the main goal. We have problems like a third developed country, and we're a small town, but we are doing okay. I think so. I'm going to show you some of what we are doing. What about the intracranial aneurysm? Intracranial aneurysm is a common brain disease. It's becoming more prevalent with a high level of morbidity and mortality. Actually, the main goals, as we know, are high blood pressure, different types of life, and for sure, at least in our town, we don't get into the main into diagnosis with tomography and too many things. With the development of medical device and the vascular stents have been widely used in the prevention of intracranial aneurysm. As we can see, we use stents, we use coils, and the resource we have at the hospital we're working at, they help us for saying the solitary. Stent assistant coils for embolization techniques are becoming popular, might be feasible and effective. What about the brain aneurysm? As we can see, we have different kind of aneurysm: globus, vitibular, multilobular, fusiform, big, pure. It can be all forms. We can do it. You can find it. Various adjunctive techniques such as balloon remodeling or cell expanding microplates to aid helicoidal embolization of this lesion. Balloon remodeling aneurysm, complex aneurysm. We can do balloon assisted coil placement too. Next. Okay. Micro stents can be deployed prior to coil placement with the microcatheter delivered to the stent strut. After the deployment of the coil without detachment, it's so-called stent jack technique, only without coil placement or after a coil occlusion performed with a balloon remodulating. I'm sorry, I'm not at home. I missed my plane. That was the thing I was telling last night. We just came from Colombia. I'm in a house of my friend's house. That I really thankful for everything. ¿Cómo es que sigue? Next. Okay. Here
Yeah, working from
And
another
this is-
computer. Go ahead, I'm sorry.
Yeah,
It's
it's my
okay, it's
computer.
okay.
It's my computer too, and the connection, but it's okay. In this study, we present our experience with a patient on whom self-expanding stent was placed before the placement coil, with the microcatheter placed inside the dome of the aneurysm and wedged between the stent and the vascular wall. A technique that has been called stent jail technique. Okay. This is one of the first, one of the cases. Female, 60 years old. She had headaches 5 years before she came into the sudden problem. The treating just with analgesic. They didn't take any image or anything. She got the worst headache of her life. We did an angiotag, we found a fissure tree, left aneurysm 12 millimeters supracrinoid, and leaving a stent for stabilize the coils inside the lesion. That was what we planned. We did it, as you know, with a puncture with the Salinger technique, with 8 French introducer, right femoral axis, left internal carotid artery was catheterized, and macrocatheter was introduced with a microguide and selective located in the neck of the aneurysm. Fix the aneurysm into the aneurysm neck, performed by a self-expanding stent, and introduce coils, the spirals, and once the aneurysm lesion was completely occluded, the stent was released in the microcatheter. When the microcatheter was withdrawn, ending the pressure. Here is the thing that we did. We went into cerebral phalangiography, showed a secular aneurysm of 12 millimeters in diameter on the anterior supracranial segment of the left carotid. As we can see here, we have the solitary stent that is one of the, at the hospital, is the thing that they gave it to us. We made a coil embolization from the patient. The other one is a male, 60 years old, a spontaneous problem. He lose a whiteness. We found an aneurysm middle cerebral artery. Later on, we went through the aneurysm. We made the embolization, put it in the jail. Filling up all the aneurysm, trying to get the dome stronger. Oh. Here is where we ended. Cases carried out in our place. From 2015 to 2022, we have made 149 cases treated with jailing technique. We had the most frequent complication. 3 of them went to RTPA at the moment because they got thrombosis. We made control to all the patients from 3 to 12 months, and we have found 7 recanalizations, and we used around 2 coils with all of them. We prefer gelling technique instead of flow diverter. Are the hospital resources they gave us to us, and here is where we have a little bit more experience. Since the emergency the techniques have been very controversial, respect what's the most appropriate technique for the wide neck aneurysm. Peterson, it shows that the use between one of the techniques depends on predominant aneurysm morphology rather than the preference that the interventionist might have. Significant differences were identified in the aneurysm morphology 3-1, another technique, suggesting there is no one technique. You can change it. Most aneurysm treated where, what do? We treat it where we have more experience, like all of us, and the resources we have. Finally, the authors didn't find significant difference in effective obliteration between both modalities. Peter, there is another something is treating with coiling assisted with a stent versus coiling assisted with balloon, finding null difference in those variables in both groups. Although not having found significant difference in the degree of complications, the one group 2016, they demonstrate better degrees of 6 months occlusion with the use of stents. The technique of remodeling with a temporary placement or recapture stents has also been described in indications of cooling, assisting with the stent and ball indication, of cooling assisted with the stent and ball helping people cure smooth series with promising results. Conclusion, the technique of stent gel represents an effective adjuvant technique to exclude and embolizate wide neck cerebral aneurysm, which in trained professional no provide inconvenience. In our group, we have neurosurgeons and therapists, endovascular therapists. Here is another patient. It is not a wide neck. That was one of the things that we are doing, an occlusion after we put the stent. The patient goes well, very well, actually. What about the minimal invasive techniques? We have now 21 years since one of my patients was one at the beginning with the stereotaxy here in my town. It was a germinoma. That picture, I really like it because as soon as he got out of the surgery, the kid was doing this. Neuroendoscopy. We don't have these robots to helping us. We use the traditional neuroendoscopy, flexible and rigid. This is one of the rooms that we have, the best rooms. No, not all of the patients can afford them. Can we live for the next generations? The things, are we going to be behind? Can we be walking together? And here is regenerative biological fixation. There is something that Professor Perilla is one of the ones is helping me to develop. One of the bibliography. We would like to invite you. We're going to have the 5th International Congress and the 3rd Intercontinental Congress in Acapulco, Mexico, which is now we are doing well with COVID. We are doing well with security too. It's going to be from November 1 to the 5th. In person, please. There is the contact that we can have it. The president, Dr. Saledonio, and the vice president, my friend, Dr. Jose Ariza. Thanks to all of you. Here is one of the things we did now in Colombia. Professor Perilla, the group of neuroanatomists, Professor Alto Goel, my friend, my real good friend, Victor Hugo, and thanks to the people from Madrid who are going to be the sponsor us in 2025. I'm sorry for my English. On my place too, we're going to have the 5th International Congress in Neurosurgery, the College of Neurosurgery of the Southeast. It's going to be from the 26th to the 28th of August. My place, Villa Hermosa, Tabasco, is going to be, is your house. We are not the president. I am not the president. The president is Dr. Martin, but he told me to invite you to your house. As long as you reach here, please feel home. Thank you very much.
Thanks a lot, Professor Moscoso, for this excellent presentation. Is there any question from panelists?
Yes, Sam, there's one question in the chat.
Okay.
Do
Go
you
ahead,
see
John.
it? Do you see it, Sam?
What is your post-stenting myco medical treatment after stenting?
I don't understand. Okay, let me. Is it in the chat?
Post-operative stenting medical treatment.
I'm sorry.
And problem. Medical treatment after stent.
Medical agreement after the stent?
Medical treatment, I think.
Oh, I'm sorry. Okay, the medical. Sorry, I'm not at home. I don't have speakers or anything. I missed my plane. Okay, the medical treatment after that, we keep them with aspirin and clopidogrel. That's it. That's the only thing to do. We make a follow-up at 3 months and in a year with an angiography. As I told you, we are around the 2% of the people who can make remodeling, and we have to do again something else. Nothing else. We tell them they have to take care. After we put the coils to take care. We are in a real hot place. Don't do too much exercise or anything in 15 to 1 month, just to make sure nothing can move. That's it. The 3 of them, they went into thrombosis with the RTPA, and they did well. We hadn't have until now any dead people, but we know any death. I'm sorry, any death during the procedure, but we know it can be one of the complications, and they sign out.
Thanks again, Professor Moscoso. And now we will shift to next speaker, Professor Pablo Aguilera. Please start sharing your screen.
No, thank you. Thank you for inviting us. And one of those days, the Cairo is one of the places that I don't know. Thank you very much.
So English is perfecto, Manuel. English is perfecto.
Thanks, Professor Bennett.
Okay, Professor Pablo, please start.
Hello, Sameh. Hello, Sean. Thank you very much for the invitation. I'm really happy to be here. I will talk about this topic, this retroinfundibular craniopharyngiomas, why I still do a craniotomy for this tumor. So I don't have any conflict of interest. And we all know that craniopharyngiomas inspire controversy because they have a bimodal age distribution with a peak in children, another peak in adults. But everybody knows that total resection has been shown to reduce recurrent rate. So total resection many times can come with a lot of morbidity because of aggressive surgery. So complete resection has been shown to reduce recurrent rate, and morbidity associated with radical surgery can be really, really high. So there are many papers published about this. This is a relatively new paper of 2 years ago from my friend Fred Gentili, that we lose him this year. And he said that retrochiasmatic and intraventricular craniopharyngiomas are particularly difficult to treat and to resect because of morbidity, basically. So you can see that there are different types of retrochiasmatic craniopharyngiomas, solid, poorly solid, or cystic, or different types of tumors. So this is the location of these tumors, intraventricular or retrochiasmatic. And what we want to do is total resection. But always we have to put benefits between risk when we decide this surgery. So another discussion neurosurgery have in the last, I think, 20 years is you use microscope, you use endoscope, what to use. I think this is like all roads lead to Rome, no? We need total resection. It doesn't matter if we use an endoscope or we use a microscope or we use microscope. with endoscopic assist. So we have to use all the tools we have to get total resection in these cases. But in my point of view, microscope approach, with microscope approach, we have different options: terminal, supraorbitary, subfrontal, interhemispheric, keyhole, lot of options. And we have direct control of vascular structures. With new microscope, really the light is excellent and the view is excellent. It's 3D. Most of the endoscope are 2D. We don't have fistula, no nasal complications. So, and when we go through an endoscopic approach, that I prefer to use endoscopic approach for cellular, supracellular, or planum craniopharyngiomas. We only have the transplanum approach, and I prefer for these posterior tumors going through a craniotomy. The limitations of endoscopy, the optic nerves, carotid arteries. And if you see this article from Theodor Schwartz from some years ago, it said that endoscopic endonasal approach is safe and effective and alternative for the treatment of certain craniopharyngiomas, but larger with more lateral extension may be more suitable for an open approach. This is another article of Cohen Gadol, and it said that you can see that both approaches are similar, or results are similar. The difference may be an increase in the risk of CSF leakage when you go through a transnasal route, and maybe more damage to the optic nerve when you go transcranial. But most of the tumors that you go transcranial are bigger, so that conclusion, I think, it's not real. I use a lot this philosophy, the Ohata philosophy for craniopharyngiomas, and I always use terminal orbitozygomatic approach for this location of tumor. So why I don't use the endoscopic approach? You can see in this endoscopic view in a cadaver that the space between the pituitary gland and the optic nerve it's very small. Entering and taking a tumor from there, in my hands, I have risk to damage vessels. You can see there that the space is really small, and you have to cut. When you initiate the surgery, you have to cut the pituitary stalk. And of course, the irrigation of the chiasm comes from not only from above, also from below, from the superior hypophyseal artery. So we have to take care during the surgery. And I think the chiasm in these big and posterior tumors can suffer a lot. I use always this approach we described some years ago with my friend Alvaro Campero and Professor Roton. This is a 3-step approach to do an orbitozygomatic approach in 3 pieces. Let's keep this a little bit more fast, but you can see that this is the final view. And we dissect the Sylvian fissure, we expose the chiasm and both optic nerves and carotid arteries, and then we arrive to the lamina terminalis. As you can see there, opening lamina terminalis, it's a very useful route to take out these tumors, these posterior tumors of the third ventricle. So I will show you some cases. This is a 56-year-old girl with headache and severe visual disturbance, and you will see why the severe visual disturbance. We use an orbitozygomatic approach in this case. I will show you now the MRI. You can see a big tumor inside the third ventricle with a solid part inferiorly. This is the coronal view. And we do, as I told you, the first thing we do is we open the Sylvian fissure. We open the arachnoid in the lower part of the Sylvian fissure to take CSF out. So we relax the brain and we don't have to pull the frontal lobe. We open all the arachnoid over both optic nerves. There you can see left optic nerve here, right optic nerve here. And you can see that the tumor is exploding the chiasm, as you can see. Look, this is the chiasm with the tumor, with the big tumor inside or the cyst. So, but we continue opening the arachnoid to get more space. Here we have the right carotid artery, A1 here. We expose A1, and there we have lamina terminalis, a contralateral A1 here, left optic nerve, and look, the chiasm, we continue open. As we can open more arachnoid, we open, because that's make the surgery easy. So you can see how we finish our dissection. And now we start to take out the tumor. There was, you see the lamina terminalis. We make a small coagulation there. We open with scissors and we take the cystic part of the tumor out. And now we can work between the space of the chiasm and the carotid artery, and of course through lamina terminalis. You can see here posteriorly that liquid membrane is respect in this tumor. The tumor don't open the liquid membrane, so we don't see the basilar artery there. We cut the tumor, we take the tumor in pieces, we try not to pull, in order not to pull from hypothalamus. In this way, we try to reduce complications in the post-op. There, the view between the lamina terminalis, and we dissect the tumor, we cut pieces of tumor, we have to take care there with the carotid artery. Working in this place from below, you have to pull, you cannot see the carotid artery. In my hands is risky. That is the typical characteristic of craniopharyngiomas with calcium inside. And here we're taking, I think, the last part of the tumor. Look how we use all the roots we have. This is, there you can see the capsule of the craniopharyngioma. It's very important to remove. If we cannot remove, we can leave a small piece. And this is the final view. You can see the frontal lobe is perfect. I think the control MRI is here, yes. And you can see that we get a total resection, but the chiasm was exploded, so recovery of the visual field was practically zero. And this is the control MRI with no tumor. And this is the pre and the post-op. And the patient do really, really well, but visual field deficit, as I show you, pre-op and post-op, it was practically the same. This is another case. This is a male, a 52-year-old male with some symptoms. And you can see a big tumor, more solid tumor. And this tumor have some characteristic. You can see that this part is going posterior to the dorsum of the sella. So if you go to endoscope, it's very difficult to read this. And when we see the coronal view, you can see a lateral extension to the sylvian fissure there, a lateral extension there. So I will show you what we do. We go through an orbitozygomatic approach again. We open the sylvian fissure again. You can see that here we are not using retraction. We try always to do our dissection sharp with this scissor, a curved scissor. And we can see there the carotid artery, the right optic nerve here. We are opening through the interoptic space. We don't see tumor there, but we see tumor here coming from carotid artery and right optic nerve. So we start taking tumor from there. It's very useful in this type of solid tumors, the ultrasonic aspiration. And as with the bulk, the tumor, we start moving a little bit, cutting the tumor. We need time to do this type of surgery. We continue the debulking until the tumor becomes more mobile. We have to take care with the carotid artery because during the surgery, we move a lot, the carotid artery. There is the dorsum of the sella, and that CSF was coming from posterior fossa. And we have to take care because of the spasm over the arteries in craniopharyngiomas is very, very common. And you can see how the choroidal artery there and the posterior communicating artery, choroidal and posterior communicating artery are practically englobed by the tumor. So how we can dissect this from below? In my hands, it's impossible. You can see there the third nerve here. So we dissect the tumor from the arteries, and you can see that the tumor goes through the bifurcation, and here some perforators that we have to preserve. So we dissect the tumor down, trying not to retract the vessels, as I told you, to don't get vasospasm, and always working between the optic nerve and the carotid nerve. We continue the resection. I will skip a little bit. You can see that there we are taking the tumor that was was going to the posterior fossa. It seems that we take a lot of tumor out now, but we have a lot of tumor in, as you will see. And we continue coagulating, taking tumor out using the ultrasonic aspiration, always with the same technique. And finally, the tumor was free. And you can see, I'm okay with the time, Sameh? I will see.
Yes, we have time.
Thank you.
Don't worry.
And we are taking all the tumor out, as you can see. All the tumor that was inside the third ventricle come all together out. And there you can see right optic nerve, carotid artery was preserved in the diameter. So this is the control, the immediate post-op MRI. You can see edema here because it was immediate, but with total resection in the axial view, in the coronal view. I like to show videos of the MRI to see if there is no tumor. And this is a sagittal view, exactly in the middle. And this is the patient, 1 year after surgery, and you can see the reconstruction is very good and cosmetic result is really good. Here's another girl, and this is to show you how we manage problems when we go through transcranial. Another case, solid part below and a big cystic tumor inside the third ventricle. As you see different cases, you see that all the tumors are different. Again, we go through through an orbitozygomatic approach. You remember the first tumor with the cystic part that was like the type of liquid the craniopharyngioma have. The second case more solid. And this is how we open the dura in this case. And again, we open the arachnoid. And in this case, we see that this patient have a prefixed chiasm because the chiasm is not always in the same place. And there is the carotid artery, right carotid artery, and the chiasm here. Prefix, you can see here the olfactory nerve. And we don't have space, so we have to go and open the cyst. But we find this solid tumor posterior to the carotid artery here, and we take the cyst out, and you can see that this cystic liquid is different. It's more that the engine machine oil. And we take that part of the tumor, and then with more space, we can go again through the translamin approach. Look, the chiasm, where is the chiasm? Very anterior. And we start taking tumor out from that part. Difficult case. You can see here the Lilliquist member was open. You can see there the basilar tip there, posterior cerebral artery. And as we are taking tumor, look here. Small hole in the anterior communicating artery, in the anterior cerebral artery. And when we go through a transcranial approach, a little coagulation there, then we use the Doppler. We see that the artery was okay. We put a little bit of fascia or muscle over, and we continue taking the tumor out. With that bleeding, when you go through from below, you have to stop surgery. And we are taking the last part of the tumor there, and this is the final view. In this case, we leave a small part in the hypothalamus, as you can see here. This part don't come out with the surgery, and what we do here is radiosurgery in the posterior, in the post-op, and this patient do very, very well. And this is the post-op, as I show you. This is another case with no, I won't show you the video because I don't have it, but it's very important. This case, a 56-year-old male with these symptoms, and he was operated first by a transnasal route. And look what happened. This is the tumor, solid tumor inside the third ventricle, goes really up through the Monroe, as you can see here. And in this coronal view, we see that the pituitary stalk was anterior. And look, this was the transnasal route. A colleague gave me the photo, and we can see here the pituitary stalk and the tumor here. So to start this surgery, you have to cut the pituitary stalk and then get space here. What the surgeon was taking a sample from here and then close and send me the patient and send the patient for me. And you know, this patient in the post-op of the endoscopic approach, do diabetes insipidus and CSF fistula. So we had to operate this patient 3 months. We wait 3 months and we operated. Here was what I was talking, 4 millimeters only. To take those big tumors, it's impossible from this patient. And look, the chiasm. The risk of damaging the chiasm is very high. This was the pre-op visual field, and we do an orbitozygomatic approach, and this was the post-op MRI when we take all the tumor out, as I show you in the other cases. And this was the patient in the post-op, and the visual field was practically the same that pre-op. We published our series of craniopharyngiomas 2 years ago, 30 cases. And as you can see, most of our cases were retrochiasmatic and intraventricular. Cellular and prechiasmatic are more easy to treat. Surgery is more easy. So we are a big hospital, so we get all the difficult cases. In most of these patients, we get a gross total resection and a near total resection. If practically in retrochiasmatic, this is 61% and 67% in intraventricular. And we see in our follow-up that if we get a gross total or near total resection, the percentage of recurrence-free time is a bit better than if we make just a subtotal resection. So surgical planning based on anatomy and tumor location is very, very important in craniopharyngiomas, and understanding tumor relationship with anatomical structures is essential to get the best resection with the lowest morbidity. Thank you very much.
Okay, Sam.
Thanks a lot, Professor Aguilera, for this excellent presentation. And my question about post-operative hormonal disturbance for these patients. What is your experience and how to manage?
Manage what type of patient you said?
Post-operative hormonal disturbance.
I don't understand what you're asking. Sorry, John.
Hormonal disturbance.
No. Bueno, but if you see the article we published, most of these patients get a big problem. It is very important to have a multidisciplinary team to treat this patient. We have a very good endocrinologist. Most of the hormones have to be replaced, and most of these patients, of these big and retrochiasmatic patients, get diabetes insipidus and need to replacement of hormones for the entire life. Yeah.
Thanks a lot, Dr. Aguilera, for joining us today. Okay, next speaker will be Professor Lanzino. Just give me 1 minute to make him join.
Hi, Sam. Is he in the panel? I don't see him. You see him in the panel?
No, he has the same problem to join us, and I will fix it. Just give me 1 or 2 minutes.
Okay, what are we doing here, Sam? Are we waiting for somebody?
I am trying to make Professor Landino joining us. He had the same trouble with Zoom. I don't know what is happening today for Zoom. That's why I'm trying to solve it.
I don't see Dr. Lanzino. Are you trying to get a hold of him, Sam?
I send him links again, and I'm waiting for him.
Okay. We'll just take a virtual coffee break.
Hey,
Well, you know, Sam, maybe during this break, I'm going to take an opportunity to show people, you know, because our job is basically to try to keep an eye on the Zoom platform and the development. And one thing I like to show the people is how you can also access Zooms through YouTube. And without joining actually the Zoom. And you can give feedback, and I'll share my screen right now, Sam, just to show you until we get a hold of Dr. Lanzino. Okay, here.
Hey, John, I'm here.
Oh, okay. Okay, we'll wait then. Go ahead, Sam, could you please introduce Dr. Lanzino?
Thanks a lot, Professor Landino, for joining us today. It's a great honor, sir, to accepting our invitation. Professor Landino is a well-known neurovascular neurosurgeon, and no need for more introduction. Please, sir, start sharing your screen. Thank you.
Okay, thank you for the kind invitation, and was just traveling. Can you see my screen?
It's okay.
Okay, so as I said, I just came back from the World Federation meeting, so apologize for being a little bit late to connect. Once again, thank you so much for the kind invitation. And the topic assigned to me today is surgery for tentorial dural AV fistula. Now, with all the options that we have available today, we can tailor our surgery and our approach to a patient with the tentorial dural AV fistula based on the technology that we have available, and we need to be cognizant that different resources are available in different parts of the world. But as I will try to show, is that really surgery, despite advances in endovascular techniques, remains a very important therapeutic modality for these lesions. Now, in an ideal world, if we have all the different therapeutic modality at our disposition, what are the reasons why we choose one therapy over the other? So, well, for me, it's definitely, I'll always go for the safest. And of course, safest, again, has to keep in mind, safety has to keep in mind local logistics and resources available. The one that is most effective in solving the problem. And then, of course, if we have different therapeutic modalities that offer the same safety, the same effectiveness, then the concept of less invasive procedure is definitely more appealing from a patient perspective. Now, when we look at the classifications of dural AV fistulas, and especially if we can consider the infratentorial ones that are the most common ones. I think for simplicity, it's important to distinguish in between median, paramedian, and lateral. And again, a dural AV fistula is nothing but a different arteries converging into a single draining vein which emerges from the dura. So along the tentorium, at any point where we have a bridging vein, that if we think about the infratentorial ones that are by far the most common, everywhere we have a drain which drains into the dura of the tentorium, then we can have a dural AV fistula. And to keep in mind this classification scheme and to keep in mind where the veins are will help us to identify the culprit and the therapeutic target, even in those fistulas that might appear very difficult if you just look at the angiogram. So just a few cases to illustrate the point. A 61-year-old who had been followed with the serial MRI scans for an incidental CP angle meningioma. You can see in 2017 on the left, the MRI in 2021. And if you look here, you see that between and compare 2017, 2021, you can see that on the right, on top of the right cerebellar convexity, you can see the appearance of more prominent veins. And again, scrolling and comparing comparable slides. Now you see a prominent vein on the right side on the T2. And as you go medially, a varix. And at this point, you can see here, we can compare with the 2017, you can see the vein, but there was definitely no varix, and now it's much more prominent, which again brings home the point that these fistulas are acquired lesions. Because of the interval documented development of a varix, in this case, we would consider surgery. Before doing surgery, we did an angiogram, and you can see a very well developed posterior meningeal branch that converges into a draining vein. And you can see that there is also a Vermian distal branch of the superior cerebellar artery. And with the dural fistulas, we have learned that the superior cerebellar artery does have dural branches, as well as many other intracranial vessels do. So this would be one that we would classify. You can see this, everything converges into this single draining vein, and this draining vein emerges from the dura underneath the tentorium. These are classical fistula that have a consistent anatomical and radiological appearance, and usually are immediately off the midline underneath the tentorium. This would be a posterior median / paramedian dural AV fistula. And then you can see as we go into the later stages of the angiogram, you can see the varix that we had seen on the MRI. And this also brings home the concept that in a dural fistula, of course, this patient did not present with the hemorrhage, but let's assume for a second that this patient would have suffered an hemorrhage. Well, in this case, this patient, the hemorrhage more likely would have originated from this venous varix that is far remote from the actual point of fistula. So, as I said, this brings home the concept, very important for our younger colleagues, that in a patient with the dural fistula, you can have a hemorrhage that is remote, that is far away from the actual point of the fistula. Again, this case, the fistula, the actual point of fistula, it's immediately underneath the tentorium, immediately on the side of the falx cerebelli, but yet the venous varix forms very distal from the actual point of fistula. This is same patient. It's the AP view. And again, the AP view is critical because, as I said, usually these veins, they emerge from the under surface of the tentorium on one side of the midline. And you can see that from this left vertebral artery injection, here is the connection, and here is the retrograde draining vein, and you can see how the actual point of fistula is off the midline immediately to the left side, and these are later views of the left vertebral artery injection with the varix, and then again the arterialized venous drainage system that makes a loop back into the transverse sinus. So is there a correlation? It's just a coincidence to have a benign tumor and a dural AV fistula. And actually, over the years, we have seen a few of these cases, benign tumor, mostly benign tumor, usually larger than the one we saw, that are associated with the dural AV fistula. And I will send you to this publication to identify possible reasons why that could be such an association. So as I said, that this is a medial posterior tentorial dural AV fistula. What are our treatment options? Surgery, excellent options. As you will see, it's pretty straightforward once you identify the point of fistula. Radiosurgery does not work for purely tentorial dural AV fistula. In our experience, at least, radiosurgery is very effective for the classical transverse sigmoid sinus, dural AV fistula, cavernous sinus fistula, but for whatever reason does not work for those fistula with the single multi-hole fistula with the single draining vein, not directly associated with a major dural sinus. Embolization would have been a very excellent option in these patients, but if you really do the balance, embolization is never without complication. In this case, we felt that surgery was a pretty straightforward option. Sitting position, very important in this case, because really you need that cerebellum to fall down in order to identify the draining vein that emerges from the dura. And again, remember that in many of these patients, since there is arterialization of a large portion of the venous system of the cerebellum, there is some degree of cerebellar edema. So it's important that you maximize the effects of gravity in order to expose the draining vein. And in this case, a standard midline suboccipital craniotomy, because despite the fact that we have seen this, we would expect to be on immediately on the left side of the midline. It's nice to have a bilateral exposure. And here is the video. I hope that you can see the video, but you can see here, this is a patient in the semi-sitting position, falx cerebellar in the middle, and you can see the arterialized red draining vein. Here we are cutting the falx cerebelli because we like to obtain a 360-degree exposure of the arterialized draining vein, so we can see around, we can see in front to make sure that we are really at the point of convergence. Here you can see with ICG fluorescent, we confirm early opacification and dense opacification of the arterialized draining vein. And as I said, once you understand, once you localize the treatment, it's really pretty straightforward and consists in interruption of the either coagulation and division or clip occlusion of the draining vein. Now, this is another case in question to show a similar type of posterior medial, sorry. Sorry, I'm in the hospital, could not cancel the overhead message. So this is another case. Again, this is a different clinical presentation, but again, to bring home the message that once you understand these fistulas, the pattern is fairly consistent. I'll go quickly through this middle-aged man with progressive imbalance, nausea and vomiting. You can see on the CT scan large amount of cerebellar edema extending into the middle cerebellar peduncle, suspected fistula, cerebral angiogram, dilated the posterior meningeal artery, and you can see everything converges into this single draining vein, which is immediately underneath the surface of the tentorium. So you can see this is the origin of the draining vein, and then there is, as you can see, arterialization and venous hypertension extended to most of the cerebellar system, hence the amount of edema on the CT. Again, midline suboccipital craniotomy, sitting position, and you can see that again the arterialized draining vein, the falx cerebellar. This one, it's on the right side of the midline. And again, it's important to separate the vein just to make sure that, and also to be sure that sometimes there can be adhesions that you can see, you can release that this is the actual emergence of the vein, and it's not related to adhesions. And this one was treated with the clip ligation. So it's important to visualize the entire venous draining system to make sure that you are indeed, and you can see here ICG fluorescent before and after placement of, here is the clip, there is no visualization of the early draining vein. So I was saying it's important to get the 360-degree exposure to make sure that you are in the most proximal portion of the draining vein as it emerges from the dura, to avoid the risk of closing the vein to distal and still be left with the residual fistula. And here you can see these fistulas are very gratifying lesions to treat, because you can see in this case the patient had the dramatic response with this 6-week follow-up CT scan with the complete resolution of the edema. So this is the posterior median / paramedian group of infratentorial tentorial dural AV fistula. Then there are the ones that are also close to the midline, but they are anterior, and they typically involve the vein of Galen system. Whenever possible, we like to treat this with embolization. I'll show a case that we elected to treat with surgery. This is a 44-year-old man who had been complaining of increasing headaches, and you can see here on the MRI, you notice that there is an enlarged, lateral mesencephalic vein. Lateral mesencephalic veins anastomosis with the vein of Rosenthal, and you can follow here after the anastomosis. You can see that there is a dilatation dilated vein, and this is on the angiogram. You can see here is a this is a dilated branch of the middlemeningeal, is the petrosal branch of the middlemeningeal, which goes into a large draining vein somewhere here. And then, as you could see on the MRI, there is through the vein of Rosenthal anastomosis to the lateral pontomesencephalic vein in this particular case. This is an AP view, very important because it shows how the communication is very close to the midline where the vein of Rosenthal enters the galenic system. You can see that there is an arterialized vein of Galen, and look, very important because it's going to be very important with the intraoperative correlation. There is somehow connection delayed, but connection across the other side to the contralateral vein of Rosenthal. Here is the angiogram. As I said, that this can be very difficult to interpret on the angiogram because it's a low pressure shunt, so it's sucking blood from everywhere. It can be very difficult to identify the exact point of fistula, but in this case, you can tell it's on the right-hand side, close to the midline, and then you can see. But nowadays, we have so many tools. So look on the CT angiogram, you can see exactly the point of emergence of the arterialized draining vein immediately at the level of on the right of the midline, at the level of the galenic vein, and then you can follow. So again, this is a tentorial dural AV fistula, exclusive retrograde venous drainage. Patient is symptomatic because of increasing headache, and we decided to treat. And once we have identified the exact point of the fistula, we know that in this particular case, we elected surgery. But if you had immediate access to the fistula through a transarterial route, or potentially a retrograde transvenous route, embolization would have been a good option. But if we consider that the risk of surgery were just the risk of the exposure, once you understand the treatment strategy and the morphology and architecture of the fistula, we felt that surgery could have been done under very close direct control, and that was our choice. Again, this is an anterior medial paramedian or galenic type of dural AV fistula. Again, gamma knife, for whatever reason, does not work very well for this type of fistula. And so in the semi-sitting position, we did the median paramedian exposure. So you can see this is a bilateral midline suboccipital craniotomy. You can see that as we open, you can recognize this median vein that is partially arterialized because of but this is not the culprit of the fistula. The fistula is much more anterior at the level of the vein of Galen. So, but this vein is arterialized because the arterialization of the venous system spreads and has involved in a retrograde fashion many other veins draining the cerebellum as well as the pons. So in this case, the goal is to go and expose open widely the quadrigeminal system, and you can see here the large arterialized draining vein that comes into view. And then the key is to follow that arterialized draining vein all the way to its entrance into the galenic system. You can see here is the precentral cerebellum. So the vein in question, the ICG, is very helpful. So it's the dilated vein of Rosenthal, and you can see, as I said, as we saw in the angiogram, so this is on the right side where the point of fistula is right here, and you can see here that on the other side, there is early opacifications of the contralateral vein as the arterialized blood drains across, as we had already, we were expecting based on the angiogram. In this case, as I said, once you identify the point of fistula, the treatment is fairly straightforward because of the importance of the veins involved in this region. We want to make sure that we were interpreting everything correctly. So I first placed a temporary clip, repeat the ICG fluorescein, and now you can see lack of opacification of the ipsilateral vein of Rosenthal, and only in a normal venous phase you see opacifications of the contralateral one that is now draining, and after that a permanent clip was placed across the arterialized draining vein once we had made sure that we were interpreting the anatomy and the physiology correctly. And this is the pre and the post angiogram. So again, this is an example of a tentorial fistula of the so-called galenic type as defined by Dr. Lawton. And these typically involve our anterior along the midline or immediately off the midline, with the draining vein that it's usually one of the tributaries. The emerging draining veins is one of the tributaries of the galenic system. At times can be the actual vein of Galen itself. Now, this is as we move along the surface of the tentorium, we have seen the median, immediately paramedian, infratentorial types, posterior and anterior. And then the one that is the most common one is the lateral tentorial dural AV fistula. And again, this is another type once where you understand the treatment and also the actual angioarchitecture of the fistula in terms of the communication between the dural feeders and the draining vein. It's fairly stereotypical. And in this case, all you have to do is, once you understand the morphology, the angioarchitecture, these fistulas are basically involve the superior petrosal vein. So once you know exactly where to find the superior petrosal vein, that's where these fistulas are located, and the occlusion of that arterialized vein, once again, without any need to cut the dura or to coagulate the incoming feeders, occlusion of the proximal portion of the arterialized draining vein is the key for the successful treatment of dural AV fistula. So this is a lady, 69-year-old, had suffered imbalance and dizziness for over a year, diplopia for 6 months, and you can see on the MRI there are enlarged veins. And as I said, once you understand the fistula, you can tell already on the MRI, here is the point of fistula. It's where the vein of Dandy, the petrosal vein, emerges from the dura at the level of the superior petrosal sinus. Again, on the angiogram, you can see this is a dilated petrosal branch of the middle artery. On the angiogram, these fistulas can be quite intimidating. But again, once you understand the concept and you understand the basic angioarchitecture, then they have a fairly stereotypical, and you can see nowadays with all the tools that we have available. This is an expert CT that is done at the time of the angiographic injection. You can see here, you see the enlarged draining vein emerging from the petrous ridge. You can see this patient had attempted embolization, but they were unable to reach distal enough to occlude the proximal portion of the draining vein. And as I said, this might look very difficult if you look at the angiogram, but once you decodify the anatomy, actually they are fairly straightforward, and they are very gratifying. And the treatment, okay, again, it's occlusion of the proximal portion of the draining vein. Here is a subaccipient retrosigmoid craniotomy. You can see here is the tentorium. Here is the petrous ridge, where the vein of the petrosal vein joins the petrosal sinus. You can see here all the incoming dural feeders. They join and they converge into the proximal portion of this large arterialized draining vein. And once you separate the arachnoid, and be careful because sometimes there is a small nearby vein that is actually functional, it's not utilized by the fistula, and you can see then the treatment either with clip or coagulation and ligation. It's fairly straightforward and very effective, and actually very safe because it's nothing more than a simple retrosigmoid craniotomy. Just one warning: if you use a clip, a surgical clip, be careful because some of these fistulas, especially if they have been evolving over many years, they have a large, they have calcifications of the arterialized draining vein, and an aneurysm clip, even a very strong permanent clip, might either fail to completely occlude the calcified vein, or might actually slip because of the heavy calcification. So, and here you can see this is the post-op CTA. You can see the clip parallel to the petrous ridge where the arterialized draining vein emerges. And here on the right side, you can see this is on the post-op day one. This is thrombosis within the venous varix and the proximal portion of that arterialized draining vein. And this is the MRI, the pre and the post-operative MRI 6 weeks later, and you can see how there has been regression of those large veins, and this is partial regression and thrombosis within the large proximal venous varix. That this is the pre-op. This is one last case, again, to show this a different patient, a lateral tentorial dural AV fistula, just to show how the intraoperative appearance, it's fairly similar. And once you understand that the lateral type, you can see the angiogram, you can see the point of fistula and the arterialized draining vein, which again drains eventually into the galenic system. But the fistula, point of fistula, it's along, again, at the junction of the tentorium and the petrous ridge. You can see all these dural vessels that eventually converge into a large venous varix. And you can see here, this is a small associate component that was coagulated and divided. And this is a clip occlusion of the proximal portion of the arterialized draining vein. And you can see the pre and post. So you don't need to do anything but close that proximal arterialized draining vein, just the proximal segment, and the actual communication is within the two leaflets of dura. So the incoming blood has no way to drain, and that's usually the end of this dural fistula. Now, just briefly to say that while the infratentorial ones are fairly common, the supratentorial ones are less common, probably because there are less bridging vein from the upper surface of the tentorium to the undersurface of the temporal and occipital lobes. This is a patient who presented with a supratentorial hemorrhage, and you can see this in this case, the patient was treated with endovascular embolization, and you can see here the onyx cast following the slope of the tentorium. In this case, the draining vein was supratentorial, hence the small supratentorial hemorrhage. And once again, I thank you for the kind invitation. And I think that once again, the goal was to show that these dural fistulas, especially in the tentorium, they can be very dangerous. They often present with hemorrhage or progressive neurological deficits. But really, once you have decodified the anatomy and you understand that the fistulas are right there where normally there are bridging veins, then the treatment becomes fairly straightforward. Surgery has still a very important role. Embolization is a very good alternative when you can do it safely and effectively. For whatever reason, radiosurgery does not work very well for this particular type where you have a single draining vein. Thank you very much for your attention and for the kind invitation. And I'll remind you, you're all invited. Dr. Perry Seldas organized a very beautiful anatomical dissection course at the first weekend of June. You're all invited to join us and to visit us. Thank you.
Thank you so much, sir, for the insightful talk, sir. We are all huge fan of yours and all the work you always share. So I think the maximum attendance is of your lectures most of the time. People are yearning to learn from you. And sir, it is a huge privilege for us to have the opportunity to listen to all your wonderful knowledge and all the wonderful words that you share. And we totally agree that even with the endovascular in our hand right now, we all should be well equipped with the surgical procedures, because obviously there are certain pathology that still needs the classical surgery. Thank you so much, sir, for the wonderful lecture. I think if there are some questions in the chat box for you.
So, good evening, sir. Hello.
Hey. Yes.
Hi. So that was a very nice presentation, sir. So I had previously also followed a lot of your publications and seminars, especially in the JNS, that retractoless pain surgery and other vascular topics, and which were very informative and very good, sir. So I was asking, sir, is there any observership or fellowship programs in minimally endoscopic surgery with you?
Sorry, can you, the question is there any minimal invasive endoscopic?
Put the question on the chat.
Fellowships.
So the question is if we have minimal endoscopic fellowship, is that correct? Minimal invasive endoscopy. So we do have a very active clinical skull-based fellowship, which of course includes minimal invasive endoscopic approaches. And also Dr. Perry Selda has an anatomical lab that focuses a lot on newer minimal invasive endoscopic techniques as to apply to the skull base, but also to other neurosurgical approaches.
How to read
this excellent presentation.
And
now we will shift to next speaker, Professor Maya.
Hold on, Sam. I want to show Dr. Lenzino something. Hi, Dr. Lenzino. How are you doing?
Good, great. Hi, John.
How was Bogota?
It was great. It was a great meeting. We had a good week.
Amazingly cultured city. Did you get to go see some of the museums?
I didn't make it to the museums, but we had a couple of afternoons. The meeting program was really intense, but a couple of afternoons where I was able to go around Bogota. There were a couple of very interesting sites that I visited.
So how to contact you? So for the same, sir, should I how to contact you?
I apologize. I had to quickly put together my presentation, but Dr. Peri Selda in her presentation will have some of the links both to our course, I think, and also to our direct contacts.
Okay, I'll just do it later, Dr. Lanzino. Okay, carry on,
Okay.
Sam. Carry on, Sam. Sam, do you want to introduce Maria?
Okay.
Sure.
Okay. Next speaker, Professor Maria will introduce you.
Sure, I would love to. It's a matter of great honor and pleasure for me to introduce Dr. Maria Perisalda to the webinar. She's a really accomplished women neurosurgeon. She's working currently as associate professor in Mayo Clinic and has a lot of contribution in neurosurgical education. She has organized several webinars, has delivered her very amazing lectures and many of the webinars, and also she has organized several workshops. So it is really a matter of great honor to welcome you here at this at our webinar on the updates on neurosurgery. So the floor is yours, Dr. Maria.
Thank you very much for the very kind invitation. It's difficult to follow such an impressive talk by Dr. Lanzino, but I'm very happy to be here and really honored. Let me just share my screen here. Do you hear me okay?
Yes, we do.
And do you see my screen?
Yes, we do.
Thank you very much. So I'll try to summarize the essential surgical anatomy aspects in the management of anterior cranial basement angiomas and middle cranial basement angiomas here. And this is some of the work that we did at Dr. Roten's lab, but most of it is done at the Roten Surgical Anatomy program at Mayo Clinic in Rochester. So just to introduce the concepts that you all know of the anterior cranial base, the posterior limit is the sphenoid ridge here, which is the lesser wing of the sphenoid. And just a couple of notes about the anatomy here. This is actually the roof of the orbit. As you know, crista galli, cribriform plate, and then the flat part here of the sphenoid bone called the planum. And then we see the optic canals, and this is the anterior limbus of the sphenoid and the tuberculum, and in between the prechiasmatic sulcus. The middle fossa, then we have the pituitary fossa here, and the middle fossa between the lesser wing of the sphenoid and the petrous ridge. And just looking at building the skull base from behind, we can see the frontal bone, and in between the frontal bone notch, we have the ethmoid bone, cribriform plate, crista galli of the ethmoid, and then just lateral to that, we have the fovea ethmoidalis just below. This is just the roof of the ethmoid cells, and then articulating posteriorly the sphenoid bone. We can see here the optic canal that faces medially the sphenoid sinus, superiorly is formed by the extension of the lesser wing of the sphenoid, and laterally and inferiorly by the optic strut. Just a better view of the sphenoid bone with the planum, the limbus of the sphenoid that we'll see in different ways throughout the lecture, and this is the tuberculum. Paying attention to the clinoid processes, the anterior clinoid process here, middle clinoid process is inconstant, but when it is, it's localized exactly here, just inferior and medial. And this is the dorsum and the posterior clinoid process. Another view with the representation of the optic nerve in the optic canal and the carotid artery, the cavernous carotid artery, and we see the relationship between the anterior clinoid and the middle clinoid and the carotid artery in the carotid sulcus, here facing the nasal cavity, in particularly the sphenoid sinus. and laterally surrounded by the anterior clinoid process. Important to know the anatomical variations of the middle clinoid that we published in the past. And this is in 30% of the cases, we actually find a middle clinoid process, and this is a small one. And then we have here the kissing clinoids. Remember that the carotid artery is going to be just there. And here is the corticoclinoid ring that is the most infrequent, but we can actually look at that in the preoperative CT when we're going to do either the nasal approach, looking at taking out the middle clinoid, or an intracranial approach, looking at doing an anterior clinoidectomy. This is the anatomy we want to know, because we don't want to break or twist the tip of the clinoid process. Here, if it's forming a corticoclinoid ring, because it can be dangerous to the carotid, you want to carefully drill and leave the tip of the clinoid there. So we're going to go back and forth between endonasal and intracranial anatomy. So from anterior to posterior, we have the frontal sinus, we have the ethmoid sinus, and the sphenoid sinus. And here we've resected the anterior clinoid process. And here part of the optic nerve has been removed, and we can see this anatomy of the ophthalmic artery, just medial and facing the sphenoid sinus. That's going to be very important for our endonasal approaches especially. And then just another note here to look at is the ligaments that are surrounding the clinoid processes. This is the interclinoid ligament. This is the anterior petroclinoid fold and the ligament that goes behind it. And this is the posterior petroclinoid fold. In between the three of them, just in between both anterior and posterior clinoid process, we find the third cranial nerve. So the tip of the anterior clinoid is going to be attached to this, these two ligaments, and that is what we have to dissect when we remove the tip of the clinoid. This is an endonasal view, a medial view. This is the orbit and the area of the brain that we can have access to from an endonasal approach, especially midline, the gyrus rectus here. And then in between, you know, this is the tuberculum and the attachment of the diaphragm of the cella. And this is the area that we can really have access to in the suprasellar space with an endoscopic endonasal approach. So here another picture with just reinforcing the same concept. So some of the tumors that we can find, some of the meningiomas, this is a patient in his 60s with really severe personality changes noticed by the wife. And he eventually had MRI, had this very large tumor in the arteriocranial base, no olfaction, and really great amount of edema. Here we chose to perform a bifrontal approach like this, raising the pericranium. These are pictures by Dr. Villani in our lab. Performing the craniotomy. In this case, we did nothing was necessary to remove the supraorbital bar, and just drilling and removing the mucosa of the frontal sinus that we will obliterate later on with the fat and pericranium and a little bit of temporalis muscle. And then we divide the superior sagittal sinus as close as we can to the crista galli, just to have this intradural view. And this is the intradural view that we get. This is the crista galli, the end of the attachment of the falx and the olfactory nerves. And this is going posteriorly, how we can look at the optic nerves and the optic chiasm and the pituitary stalk, the carotid artery. So here we are facing, this is the limbus of the sphenoid, and this is the prechiasmatic sulcus right there. So we can also have access to the lamina terminalis, which will be important for some pathologies. And for instance, a tumor like this, we can argue endonasal versus open approaches. If the dural tail doesn't go beyond the level of the optic nerve, I think it could be considered an endoscopic approach for this, as you can remove the lamina papyraceae and really reach lateral and push gently the fat of the orbit aside to resect that dura there. And in this case, the patient had no olfaction as well, and we chose to perform an endoscopic endonasal approach that the patient also preferred. And this is the traditional opening for this. We have to remember that the nose is a healthy tissue that we have in these cases. So Dr. Pinheiro came up with the idea to just perform a superior ethmoidal approach, leaving even both middle turbinates on. And we perform in all these cases a draft of the frontal sinus, followed by a superior ethmoidectomy and sphenoidotomy. In this case, we performed that as well, but just limiting superiorly the resection of the nasal cavity structures. Once you expose the dura, you have to coagulate the anterior and the posterior ethmoidal arteries and divide them. Usually you want to coagulate them closer here, because if you tear them from this area too close to the orbit, they can, the artery can retract and can form an intraorbital hematoma that can compromise vision and can be an emergency to drain it. And so when we remove this is removing the crista galli. And when we open the dura, we have to open all around the tumor and then coagulate and divide the falx. And after we do that, this is the area, these are the gyrorecti here, and the frontal orbital artery, and here is the place where the olfactory tracts are that have been removed. And this is a very short video showing the approach and a little bit of the resection of the tumor. And this is just going above the middle turbinate on both sides. You can see the middle turbinate right here. And then you have access to the tumor. And this is exactly a very similar image to our dissection. And of course, the volume, the tumor, and we're gonna fast forward to the end of the procedure, where you can see that this approach really didn't restrict us in the resection, and that's the collagen graft followed by a nasoseptal flap. And this is the postoperative result. So what happens when tumors involved, the lateral aspect of the anterior fossa, cavernous sinus, and middle fossa? So then a lot of the tumors are central on the anterior clinoid process and the sphenoid ridge, as you know. And so to look at this anatomy, we're going to go step by step. This is the right side. This is the optic nerve, the carotid bifurcation in an anterior and middle cerebral artery. And this is the third cranial nerve and PCOM right there. So if we peel the dura back, we're going to see the superior orbital fissure and just below the anterior cranial process and the cavernous sinus contents. The fourth cranial nerve, this is the carotid artery, and this is V1. And if we dissect these structures, we can see this is the anteromedial triangle between V1 and V2 that gives access to the sphenoid sinus. And this is the anterolateral triangle that also gives access to the sphenoid sinus. And another point that we can have access to the sphenoid sinus, and in the intracranial, in the open approaches, of course, a source of CSF leak is the optic strut that has been removed here, and also medially to the optic nerve and the optic canal. This is also the sphenoid sinus. So multiple ways we can communicate the intracranial with the endonasal space, and we have to obliterate that really well with fat or a piece of muscle. Here we can see the sixth cranial nerve very nicely, just medial to V1 in this dissection. And this is another dissection showing the same concept of the sphenoid sinus, medial and lateral to the optic canal. And another picture showing, this is the anterior clinoid process, and showing here how we, the nerves that go to the superior, through the superior orbital fissure. We have the third, we have the fourth cranial nerve, 6 and V1. And what we can see is that I want you to focus on the fourth cranial nerve. Is really superficial. It's just the same as the B1, the frontalis branch, that is just deep to the periorbital. So when we drill in this area, we have to be very careful, because here at the orbital apex, the third and the sixth nerve are intraconal, but not the fourth nerve. And if we stimulate that nerve and we have it register with microneedles in neuromonitoring, we can actually stimulate the fourth cranial nerve through the periorbital. So this is a series of dissections performed by Dr. Karstrom at Mayo Clinic and Dr. Graffio of the orbitozygomatic approach. As you know, this is the subfacial dissection and retraction of the temporalis muscle. The craniotomy, we perform a 2-piece OC usually, or a 3-piece OC, rather than a 1-piece. And then when we perform the 2-piece that is shown here, we take the orbitozygomatic bar and leave it retracted and attached to the masseter muscle. This is the meningoorbital band, and then we remove this bone of the roof of the orbit and just leave that little bit that connects towards the optic canal and the anterior clinoid process. We leave the meningoorbital band at that level. You can also divide it at that point if you wish, but it's a good reference here for the clinoid. So I usually leave it and at that point, and then carefully dissecting, drilling here with a 3-millimeter diamond. And then when we get to the limbus of the sphenoid, I usually use a 2-millimeter diamond with abundant irrigation. And then you take out the tip of the clinoid that is just attached to the to a little bit of the optic strut. And just removing the piece of the clinoid here. And then we open the dura in that way. And now we have a really good reference of the optic canal. That's why we do the drilling extradural of the anterior clinoid process and the compression of the canal, because that sheath of dura is always there, no matter how much tumor is around the optic nerve. If you try to go just intradural, the optic nerve can be really flattened and can be surrounded by tumor. But if you go extradural, and then you have at least the reference of where the nerve has to go through. So then you open the dura in this direction, looking extradurally towards the canal, and you can actually successfully open the canal and divide this dura, and then you have at least one of the anatomical structures that you absolutely have to localize early in the dissection. And then just inferior, you have the carotid artery. And just looking at the pituitary stalk here and the basilar artery in the back. This is another specimen showing the same thing after removal of the clinoid. Then you can put the endoscope and really look around. This is the, this is the contralateral third nerve, and this is the sixth nerve, but you can't really access well. You can access with some angled scopes, but this is very restricted, but you can really have a nice view there if you need. So this is a case in which I chose a orbitozygomatic approach just because the tumor is really high here. And this is the postoperative result. It left a little bit of tumor on the cavernous sinus. And this is just after resection of this quite large tumor. This is the optic nerve. This is the contralateral optic nerve, and this is the carotid artery, PCOM. And then I usually peel back the dura of the cavernous sinus. I don't remove the tumor inside the cavernous sinus to protect the nerves, but I use neuromonitoring, I localize the nerve, but usually you can find a nice plane to peel it back, and then you can resect all that dura. This is another tumor in which I think an orbitozygomatic approach is appropriate. just because it allows you to look up more than just arteriovenous. And this is another case in which I also used an orbitozygomatic approach. This is a patient in his 60s who developed, he had a seizure, and that's why this was discovered. No visual field deficits. He did very well after surgery. This is a female patient who had a growing meningioma, asymptomatic, and once we documented growth, this tumor was resected. And usually these tumors have a certain amount of hyperostosis that can be very intense. Not in this case. And when you dissect the dura, this is the meningoorbital band and the orbit. So you really have to look for that little plane, and that is located between the periorbita and the optic canal. And just once we decompress the optic canal with the 3 millimeter and 2 millimeter, we can really, I drilled a little bit more further that clinoid, and just when you think that you have it all dissected, just remove carefully and make sure that you don't have a cortical clinoid ring there. There's always some venous bleeding around that, and you can just control it with gel foam or Surgiflow, etc. So this is peeling back. This is the dividing the meningoorbital band and peeling it back. And at that point, that has been all extradural. No tumor has been removed. So here is looking, this is the optic canal, and this is going down towards the optic canal dura. So you know that to decompress, you have to open the dura in the optic canal, but you have it localized. You know exactly where the optic nerve is going to be. And this is opening the dura of the falciform ligament and the optic canal. And here, once we have peeled back the dura of around the middle fossa and around the cavernous sinus, then we have the dura with the tumor that we can actually resect. This is the optic nerve, and this is already decompressed. If the tumor doesn't go through this arachnoid or go past this arachnoid, I don't open the arachnoid because I think that's not necessary, and it saves you some subarachnoid blood getting into the cisterns. And this is just removing that tumor and cutting this. At that point, you just have the edge. This is the superior orbital fissure and a little bit of the cavernous sinus dissected here. And this is the dura that we are going to divide, and it's going to go with the tumor. And just this is the final result. This is the dura around the cavernous sinus. A little bit of fat here in the optic strut before reconstruction with fascia lata. So this is the postoperative result. So just looking at some tumors from the endonasal perspective as well, and knowing that the limbus of the sphenoid is here and corresponds endoscopically to this area. This is the tuberculum, and this is the tuberculum intracranially, and the prechiasmatic sulcus is really the key part of the endoscopic approaches to the suprasellar region. So this is a dissection by Dr. Agosti in our lab, just through the prechiasmatic sulcus. And what we have shown here is we are not advocating for just a small opening in the bone, but this shows how much this is really the key part of the approach. So we can see that, we can see the supra and infradiaphragmatic corridor, and this is the approach that we usually use for this. Drill the planum, drilling the prechiasmatic sulcus and the tuberculum, and we can have this beautiful approach. This is the pituitary stalk. This is the PCOM and the chiasm and the ACA complex. And the ACA is right here in the frontoorbital artery. So a tumor like this small that has been growing with time, no visual problems, and really the attachment of this tumor is in that dura. It's very important to look at the attachment of the tumor. Even if the tumor sometimes goes a little bit above the carotid artery and a little bit lateral, if the attachment is really in the base of the dura, which sometimes is difficult to know, usually the outer arachnoid membrane protects you from the structures that are deep. So here we have to be very careful with the traction, but we can see that the outer arachnoid membrane, has been partially preserved there by this not large tumor at all. And then with sharp dissection and traction, and I use for sharp dissection either the micro scissors, or what I find very useful is a 90-degree feather blade, which cuts towards you, and you can actually do very nice dissection and very efficient, sometimes more than, so this is the knife. It's not the dissector, it's a knife that cuts in this area. And you can, once you take out the dural base there, then you can resect safely the tumor. And then this is tumor going towards the optic canal. And this is the final view. This is the optic canal on that side, and the superior hypophyseal branches towards the optic chiasm. So a tumor like this also looks like the base of the tumor is also favorable for an endoscopic approach. And just to finalize this, we perform more of a planum approach, of course, involving the prechiasmatic sulcus as well. This is a precellular type of sinus, so the pneumatization is not complete, but we can see that these are the optic canals, and this is a tumor that has a wider attachment. And again, always finding the arachnoid plane around the tumor. Once we have that, dural base almost completely removed, then it becomes easier to dissect the tumor. This tumor had a certain attachment there, and you have to always look for the vascular attachment that can be behind it. In this case, we saw that the anterior cerebral arteries looked a little bit, a couple of millimeters away, and this is a branch of the frontal orbital artery that goes towards the tumor, and this is the final operative view. So you can see the ACAs, this is lamina terminalis, and this is the optic chiasm, and the bed of the surgical cavity that the tumor left, and there's the frontal orbital artery right here. Then we reconstruct this with fascia lata and the nasoseptal flap. The patient did really well after the procedure. This is the postoperative MRI. So just to finalize with a couple of images of the cavernous sinus, again, images from Dr. Agosti in the lab, and just to integrate the endonasal and open view. This is the sella, this is the carotid artery, and the classical view of the optic nerve, the ophthalmic artery, and the elements in the cavernous sinus. This is V1, this is cranial nerve, this is the third cranial nerve, and just macroscopic pictures of all this anatomy. This is the cranial nerve 6, V1, and the third cranial nerve, and the vascular structures from the carotid towards the cavernous sinus contents. And just to finalize with two general pictures of the same anatomy, endonasal and intracranial, both complementary. Those are essential in the armamentarium of the cranial-based surgeon. And I just want to finalize by thanking all these, these are the current fellows in the lab and all the other fellows and my colleagues who have contributed to this talk. And I just wanted to extend my invitation to our CME course in Rochester at Mayo Clinic. And if anyone is interested in a short training course or a dissection or a fellowship, please email our secretary and head of the administration of the courses, and we will be very happy to respond to you and talk to you about options. Thank you very much for the kind invitation.
Thank you so much for your wonderful lecture, Dr. Maria Perez-Elda. You always obviously were amazing talks, and we are all a huge fan of yours. So thank you so much for the amazing lecture. Kindly check the chat section if there are any questions. So far, we haven't checked to see if any question on your talk, but there might be any question later on added. Again, so thank you so much for joining us today. It's a matter of huge honor to have you. And let me invite our next speaker, Professor Paul Gardner. Let me have the honor of inviting him to the talk today. Sir, thank you so much for joining us today. Professor Paul Gardner is a professor of neurosurgery at the University of Pittsburgh. He's also the director of the skill-based fellowship programs. We are all aware of all of his wonderful lectures. We are a huge fan of your lectures, sir. We always follow your lectures and all your research work. So it's a matter of huge honor to have you here and to welcome you here today. Sir, the floor is all yours now.
Thank you very much. And again, congratulations on these fantastic webinars. And thank you for inviting me to take part in this one. Perfect lead-in with that wonderful talk by Dr. Paraselda. I love watching the anatomy talks. I think that it's amazing to see how the detail of understanding of endonasal anatomy has only improved more and more over time through work of people like Dr. Paraselda. So thank you for that. And I'm going to lead into talking about endoscopic endonasal surgery for craniopharyngioma. And what I do is the state of the art, what we've learned about these approaches and how I manage it. This is my disclosure, which is not really relevant for this. And the basic concept here, and this is a slide from Dr. Corral that I think is endlessly useful, where with a microscope, you can zoom in very much on any view that you have, but only the endoscope can actually go into the surgical field. And it's that ability to come into the surgical field that allows us to really change what we can do. And so the endoscope allows us to enter into the surgical field just like this. And we can take advantage of that with the endoscopic endonasal approaches. Now, I believe that these should be practiced with two surgeons working with four hands side by side. I think that's the proper way to do this. This requires taking part with neurosurgery and ENT working side by side, but it gives me the ability to do binarial dissection here. So here we can see, again, looking endonasally, the microscopic view that we might have. And that's certainly you can do a lot with that, but just simply by introducing the endoscope into the field, we're able to accomplish so much more. And so I think that that alone shows us the advantage, potential advantages we can do by doing this endonasally. Now, of course, there are separate modules of approach, and these can be anywhere from the clivus and upper cervical spine all the way up to the frontal sinus and cribriform, as we heard. I'll be focusing on the transtuberculum or transplanum approach for specifically craniopharyngiomas, and I think we saw just excellent examples of the anatomy. But the endoscopic view, just a single view, really shows us everything that we need to see for this approach. When we look at that anatomy again, I can see everything from the planum to the tuberculum and sella, the clival recess, the carotid artery, you can see optic nerve, and then the lateral OCR, of course, is a well-known, and I think has become much more well-known as the medial OCR, which is really more of the keyhole for the endonasal craniotomy. Just like for an open craniotomy, a keyhole gives us access to the frontal and temporal fossa, as well as to the orbit. This gives us access to the sella, the carotid, optic, and the suprasellar space. So very important to understand. As well, the prechiasmatic sulcus, this bulging of dura, puts us directly at the level of the chiasm. And this is important when we start looking at craniopharyngiomas because most of our opening will be just below this level and not above it like you might do with a meningioma. And then finally, the sphenoid limbus, which attaches laterally to the fold of dura called the falciform ligament. But when we look at this, this is the type of exposure that we want to do. It's a very wide bone removal. You can see we've removed even all the way out the bone of the medial OCR, and removing this is really critical in my opinion. Once we go intradurally, the critical anatomy is the superior hypophyseal vessels and superior hypophyseal arteries. And here you can see that demonstrated in this cadaver with the typical three branches giving off to the optic nerve, chiasm, and then to the stalk. So for supracellular exposure, it's critical to understand the removal of that bone of the medial OCR to have freedom of movement. This is especially critical for a craniopharyngioma because right where the medial OCR is and the diaphragma is, that's directly where the craniopharyngioma lives because it grows from the stalk. And as a result of that, the critical vasculature is the superior hypophyseal artery perforators. Of course, it can't be emphasized too many times that your resection has to be the exact same as you would do with an open approach, which is internal debulking with extracapsular dissection, gentle countertraction with sharp and blunt dissection. If you're going to reach in and pull this out or operate in a different way than you would open, then either need to adjust the technique or try a different approach. But the resection technique needs to be exactly the same. One point to me that's very critically important is that these are retrochiasmatic tumors. Every craniopharyngioma is by definition. The craniopharyngiomas can grow anywhere along the hypothalamic pituitary axis. The majority of them will start in the stalk itself. So certainly the stalk is probably the critical. Let's see if I can get a pointer here. The stalk is really our critical area, and that majority of them grow from, but they can also grow from the gland or from the hypothalamus. But if you look on this anatomy slide here, or this figure, you can tell that every single one of these locations is retrochiasmatic. So none of these are really can occur prechiasmatic. Sorry, looks like I've gotten myself stuck now here. One moment. Let me see if I can advance the slide here at all. I may have to stop my share for a moment to get this into the mode. It's not showing me on my mouse, I'm sorry. Go. Maybe that will work. There we go. So this is inherently a retrochiasmatic tumor. So as a result, it's still not showing me my mouse, is it? So these are all innately retrochiasmatic tumors. No matter what we do, they're going to show up growing from as their origin behind the chiasm. And therefore, to me, a craniotomy does not make sense to get to the origin of these tumors. It just inherently is not part of it. This is really not cooperating with me, is it? Open to suggestions for how to get out of this mode I've gotten in.
Zoom has been acting kind of strange today.
Yeah, it's not letting me see a mouse or break out of here at all. Very frustrating.
You might have to leave it and come back.
Yeah, it's not even letting me do that though.
Not even do that, huh? F5, right, Sam? Try F5, Paul.
Let me try this.
Yeah.
F5. All right, let me try that. Nope. It's really got me stuck here.
Oh, okay. Can you get off? You can't get off it totally?
One moment here. Sorry about this.
It's okay. It's happened before today.
It's happening a lot today. I think there is some issue right now.
It's Zoom. It's not you. It's Zoom.
Yeah, exactly.
I'm going to see if I can stop the share and start it all over again.
Yeah, I think that might do it.
That might work.
Oh, I can start. Okay, there you go.
Yeah, yes.
There you go.
Let's try this one more time. All right. Okay, that's better. All right, that's what I get for trying to bring up a mouse. So the critical point here is this is a retrochiasmatic tumor. By definition, it does not originate ever in front of or the chiasm. So the concept behind this is that the root of this tumor has a natural corridor from an endonasal approach. This is the two-point concept that Spetzler popularized. Well, if you look at the long axis of the tumor and draw 2 points along that, the approach that gets you in line with that is the natural approach that gives you the most access to that tumor. And that certainly applies for any craniopharyngioma. This is our early series. Obviously, multiple surgeons involved in this. And you can see here the gross total resection rate, which was about 50% early on, and I'll talk about our learning curve with that. One of the things that we learned during that is that the endonasal approach really gives us the best view of the stalk, and that gives us the best potential to preserve the stalk. So here we see an example of a suprasellar craniopharyngioma, very difficult to tell on the preoperative scan where the stalk might be. But as soon as we end up inside here, you can see here we had to do a modification on the flap because of a septal, a hole in the septum there. And here's opening up the sphenoid. And here you can see the exposure. Now, I like to open the superior cavernous sinus in this fashion where I open below the SIS and then open above it. This, I believe, was popularized first by the group from Naples. And it's really a very effective way to split the SIS. So open below it, you can even pack it off, but then open above it and then can coagulate across the SIS. Of course, I like to use lower heat or lower energy on the bipolar when I do this because, again, those superior hypophyseal vessels are going to be just deep to me there. So here you see very careful coagulation of the SIS. And then as I split that superior cavernous sinus, this will take me directly back to the tumor. I don't do this maneuver first on a planum meningioma, only on a craniopharyngioma, because I have to split the diaphragma in order to get to the stalk where this is originating. And you can see here's my prechiasmatic sulcus up above that. I don't necessarily have to open quite up to that because the tumor, again, is retrochiasmatic. So I've removed the bone so I can manipulate that dura. Here we're doing indocyanine green just to see very clearly the vasculature, make sure I'm not missing any within the cyst wall itself. And then I can open into the cyst wall of this craniopharyngioma. And again, this is just such a direct view of this that it's very hard to argue that there's a better option for getting to this tumor when I can land directly on it in this fashion. I can then internally debulk it. I have to understand what anatomy is around it, but that should not be a limitation. Here we can see the carotid. You can see the hypophyseal branches coming off. You can see the posterior communicating artery off to the left side. Carefully, again, sharply dissecting free the arachnoid, carefully cutting the arachnoid. We see the third nerve above that. I'm preserving these hypothalamic branches. There are collaterals to the hypophyseals that come off of the PCOM. And again, internal debulking and extracapsular dissection. But one of the critical points of this is by carefully doing that, I can identify, in this case, that the stalk is actually off to the right side and actually might be preservable. There's a little bit of involvement of the floor of the third ventricle, which I can sharply resect if I understand the anatomy of the hypothalamus and the floor of the third ventricle. Of course, we know we break through that all the time on third ventriculostomies without causing damage, as long as I don't cut into the actual, the meat of the hypothalamus itself. Here we're very carefully choose to coagulate one of the branches coming down into the tumor, and you can see the stalk actually preserved off to the side. And you can visualize that there's a plane here where I can decide how much of the stalk do I want to leave. If I leave a capsule of tumor on the stalk, it has a much greater chance of recurring. However, I want to be able to make that choice for the patient as to whether or not I want to try to preserve stalk function. There's definitely a trade-off there when you have a case like this where that capsule itself can be a source of recurrence. So I tend to be as aggressive with that as I can, even if it means losing stalk function, because eventually they'll lose it if you leave any tumor behind. And here you see our final view, and the stalk's very clearly preserved, and then just a piece of collagen inlay, and then nasal septal flap over top of it. And there we can see our reconstruction. And here you can see we were able to preserve it. And actually in this patient, she was able to preserve her function as well, and still to this day has it. Here's another case with stalk preservation. Again, presenting with vision loss, but does not have any loss of function. A much more solid tumor in this case, but again, retrochiasmatic, so it's going to push the chiasm forward. Again, this is showing the removal of that medial OCR area. You can see the bone over the carotid, the bone over the medial optic has been removed, and we'll even take this up to the sphenoid limbus, exposing the prechiasmatic sulcus. I will not necessarily open the dura that far, but it's important to have that ability to at least manipulate there. It's cutting across the superior cavernous sinus. This was before we had that feather blade that Maria mentioned, which is one of my favorite instruments for opening the dura here, because I think it's really quite safe. And you can see by splitting that SIS, I land again directly on the tumor. I know I'm below the chiasm. That's by definition the relationship of this tumor, and I can do sharp and blunt dissection. This is obvious tumor here. It's not vascularized, so I know it's not the stalk. And as I start working back through the tumor, I recognize there's our stalk posteriorly. I can decide how aggressive to be with that area. And here you can see where the tumor originated from the central part of the stalk. So I can choose here how aggressive to be with that. I'm able to, I feel, dissect it safely free. There's a little bit of the tumor that's also stuck to the bottom of the chiasm, or really the right optic nerve in the genu. And I can decide again to leave that. If this is an older patient, perhaps I might leave that residual, or if I'm not as comfortable with that microsurgical dissection there. But able to, with sharp dissection, safely release this from the optic and get a complete resection in this case. Look around with an angled endoscope to ensure we have a complete resection. And there we see our final view, again with stalk preservation. So in the patients who had intact pituitary function in our series, actually able to maintain function in a third of those. Of course, a large number develop hypopituitarism, but even a smaller number will actually get some improvement in pituitary function. Very rare, but that's sort of the holy grail. It's like hearing preservation in a medium-sized acoustic neuroma. Really should be our goal, but we don't always accomplish it. DI is less common, able to avoid that, and that has a huge impact on quality of life. If you look in adults versus children, in children, we're much less likely to be able to preserve function. I think that might have something to do with the type and the size of the tumor and how late they present. The greatest fear of the craniopharyngioma is damage to the hypothalamus. That's when patients really end up in a nursing facility or don't recover or have really even more dramatic problems than that, like hypothalamic coma. Here's a patient who had been treated previously with P32. And you can see it keeps recurring again. If we don't treat the root of this tumor, we're not going to get rid of it. And you can see here, this is a example of calcification of that carotidoclinoidal ring that Dr. Paraceldo was talking about. This is its attachment on the middle or medial clinoid, but again, a very wide exposure. Now, in this case, you can see we've opened a little higher perhaps than was necessary, opened up onto the falciform ligament to have a little more room to manipulate, but you can see truthfully that wasn't necessary. Simply opening up below that would have been given us plenty of room. We don't need to see the posterior frontal lobes and end up with a slightly smaller dural defect. You just have to convince yourself that that's what's necessary. Now, this tumor very clearly is blowing out the entire tuberous area and hypothalamus. This is not a tumor that we're likely to be able to preserve function. You can see the root of the stalk is completely invaded here, but you can see the hypophyseals. You can see the ophthalmic arteries looming in. And as this dissection moves along, we have this ability to decide how much we're going to dissect here from the posterior chiasm and from the hypothalamus. There's not going to be a chance here to preserve the stalk, but you can see very clearly the differentiation between abnormal, this very grayish looking diseased tissue, which is tumor, and the normal hypothalamus and chiasm next to us, and sort of slowly internal to bulk, and then decide exactly where to take that capsule. Here's a further dissection, and this allows us to very slowly and safely dissect free from the hypothalamus. So there's our sharp dissection. Its attachments are on the wall of the hypothalamus. When a tumor is on the floor of the third, that's where its attachments are. And you can see here, we're trying to cut those free to ensure we get a safe resection. There is no other approach that gives you this type of view of the attachments to the hypothalamus. It doesn't exist. And so it ends up being a bit of a blind procedure from an open craniotomy, even if you do translamina terminalis. You can see here, the gland is completely disconnected, but we leave the tissue there more than anything to help decrease the size of our defect. And here we can see the reconstruction. And here's the post-op with a complete resection, but of course, transection of the stalk. We've had no cases of hypothalamic injury. This includes hypothermia or hypothalamic coma. Visual impairment improved in the vast majority of patients. We had transient worsening early in the series, but none since then. Well, what about pediatrics? You know, people talk, if they don't have a well-pneumatized sinus or a small nose, how can you possibly access these? Here's a very calcified tumor you can see. And here you can see, we can drill out all of this area, all the way from the planum that you see in the figure on the right, all the way on the left rather. And then on the right, we'll see what happens over time is this is the patient when they presented later on, and they actually regrow the majority of their clivus in the sella as only children can do. Here's an example of a very large tumor in a child, and as is typical, it crosses over more than one module. This is transplanum and transclival. Pituitary function unlikely to be preserved here, but this you'll see has pushed the gland downward. So here we're exposing our planum, and here's the carotids on either side of the sella, and actually the gland is pancaked inferiorly. So this is all solid tumor bulging out through our tuberculum and up through the planum. So we start to debulk the tumor. Very large tumor in this child. And you might say, well, how are you going to get to the clival area without coming across the gland? Well, this is where a pituitary transposition comes in handy. And usually with a craniopharyngioma, now with most extradural tumors like a chordoma, for example, or meningioma, we'll do an interdural transposition as described by Dr. Fernandez-Miranda. But for this type of tumor, I will simply do a hemitransposition where I disconnect the gland on one side. You see all of this part is just internal debulking. But here, if I want to get to the more posterior area, there I start to see the PCA come into view, or PCOM rather, and then just more and more debulking. Now I start to try to split inferiorly, and here you can see the carotid, and I'm struggling now to get down to that lower part. So to access the part behind the clivus, I don't want to pull it up blindly. So what I'm going to do here is disconnect the gland. And I do that by cutting where the distal dural ring and the proximal dural ring attach to the diaphragma. This is essentially the area of what might be considered the carotid cave when it exists. But we see from this view, it's really not much of a cave. We have a great view of it. And now by doing this hemitransposition, I now have access to that solid lower part of the tumor that's going down towards the membrane of Lilliquist. It's going down towards the basilar. We're far more likely to damage a posterior circulation vessel than anterior circulation with a craniopharyngioma, which is something that's very important to keep in mind. Craniopharyngiomas, we think of it being a suprasellar tumor, but they actually extend from the stalk and therefore grow back into the posterior circulation. In the interest of time, I won't show all of this, but here we are now doing the suprasellar dissection. We finally start to see the optics come into view. And again, that same point, sharp dissection away from the optic chiasm, away from the hypothalamus. Here's using that feather blade that allows us to dissect back towards ourselves sharply. And you can see this almost imperceptible margin, but with a good view, with good hemostasis, we can do a very careful dissection of each one of these margins. This, of course, is a slow, painstaking process, but with a craniopharyngoma, it's worth it to avoid damage to any of these critical structures. And you can see once I get rid of this last attachment, here's that sharp dissection away from, I'm not pulling this, I'm not pulling it down and letting this snap back. I'm letting it, it's been stretched over the tumor there, but I'm very carefully, sharply dissecting it free. And here we can see up into the floor of the third ventricle, that beautiful view we've all gotten used to seeing, all the way back to the aqueduct. And here we can see we've left the gland in place, but obviously it's completely disconnected. There's third nerve and PCA and PCOM. And here's the kind of visualization we have where we know we've gotten a complete resection of this tumor. There's just some thickened arachnoid on the front part. And again, inlay graft, nasal septal flap, and here's our postoperative view showing a complete resection. So really, what are the limitations? Well, we were able to get maximal safe resection. Again, our definition of maximal safe resection has progressed over time as our surgical ability and instrumentation has improved. So I've gotten more comfortable with doing the sharp dissection off of the hypothalamus, for example. We're able to get this done in about 71% of these cases. Mid-face growth in children is not affected. We've studied this very carefully. Under the age of 7, mid-face growth is not completed. It does not seem to impact it. But what are the limitations then for this approach? What about prechiasmatic tumors, so-called prechiasmatic? Well, all we have to do is open onto the planum and understand that this is simply a portion of the tumor that has originated posteriorly and has herniated or grown in front of the chiasm. So I can debulk this if I identify the chiasm. Here I'm resecting the portion of the tumor that is, quote, prechiasmatic, but the truth is the origin of the tumor, you can see behind that on the splayed out stalk, is retrochiasmatic. So this still remains the right approach for this, in my opinion. What about calcified tumors? A soft tumor, sure, you can suction out a soft tumor. Here's a child who was sent to us with multiple prior resections. You can see they've had a transcortical transventricular approach. They've had a couple of craniotomies. They even had a tube placed into the cyst to try to control it. Here's the calcified tumor. I have the same ability, I have the same toys and the same tools to break up the calcifications as I would through an open approach. This is a terrible tumor, no matter what approach you take, but it is good to demonstrate that I have the same ability to manage these tough tumors, these calcified tumors endonasally. Here you can see a bone aspirator. We start to see the basilar come into view. You can see that catheter that's been placed into the cyst. And this tumor is densely adherent to the basilar artery. So I have to sort of hold it immobile with my suction and very carefully drill. I'm drilling onto my suction, not back onto the basilar, just drilling toward my suction to gently break this into pieces. I'm just trying to whittle it down to its minimum parts so that I can try to dissect off of the basilar. You never know where it's going to be stuck until you can visualize it. So this is, a debulking version that I'm doing. I'm just having to use a drill to actually do it. Here you can see the part going up onto the floor of the third. It's densely adherent to arachnoid. This is an ugly tumor at this point because of multiple prior treatments, including radiation, chemotherapy, etc. I know I'm not going to cure this tumor, but I try to take it to the maximal resection that I can. Again, breaking it into bits. Again, very tedious, but each one of these calcified parts I break through, I find some soft tumor. Here's the final part. Look, anytime I touch that, the whole basilar comes with me. There's just no way I'm going to be able to get that entirely off of the basilar. Here we can see, though, I've done pretty well with it just by breaking it into bits. And you can tell the parts that are simply too stuck. I don't want to risk an injury there. So I'm going to leave a little bit of this tumor adherent, keep protecting the vasculature. And this is my final accepted view where I've left a little bit of calcification. I'm sure this child probably will have to deal with further recurrence, but a pretty radical resection given the type of tumor that we were dealing with and given the calcification. But what about extensive cysts? We all see these, and especially in pediatric patients, the cysts can go down all the way down to the back of the clivus. Of course, I can access the clivus and resect the cyst. They can go into the CP angle. You can see here, I didn't resect the cyst wall here. I just drained it, and it looks like thickened arachnoid in many cases. But this recurred. This was treated with Gamma knife, which has been successful so far. Here's another very large anterior cyst, and then was resected, complete resection, but not of the cyst wall, complete resection of the solid component. And the solid did not recur, but the cyst did, and this was treated successfully with intracystic P32. But what I've learned is that these giant cystic craniopharyngiomas, if you leave the cyst, they recur. So the retroclivals all required some other type of treatment. The anterior fossa required P32. So you really need to try to get a complete resection. Recurrence in a cystic tumor is far more likely, which you can see here compared to the heterogeneous or homogeneous tumor. So the cyst is harder to get to, but it's also equally important to try to remove. This is a child we just operated this past week. And so hopefully I've learned a little bit from this, and knowing that this cyst is a source of recurrence. Endonasally, I can get into all these cysts, but that doesn't mean that I necessarily can get a complete resection. So for this, I did a combination of endonasal plus an eyebrow just for the lateral cyst. And here you see immediately post-op. And actually, we were able to preserve, believe it or not, some stalk in this case because our ability to visualize it and get a complete resection of the cyst itself by employing the additional eyebrow approach. Finally, anatomic limitations, purely interventricular. This has been a classic limitation. And as you look here, you can see on the figure on the left, if you look at the angle of the midbrain, it's been pushed up. So there's an oblique angle created by the tumor, whereas on the right, the midbrain's been pushed downward. That means that this is, the one on the left is originating infracellular and pushing up, and the one on the right is pushing down. Traditionally, we've preached that this should be removed through a translaminar terminalis, but it sort of depends on the symptoms and your ability to access. But here you can see an example of how that was done. This is a recent case, though, in a guy who presented, a 61-year-old man who had cognitive decline. And as you can see on this top cyst or fiesta image, This tumor is extending dramatically superiorly, but the solid portion, we've pushed a cyst forward. You can see on the bottom, this is very clearly creating an acute angle with the midbrain. The stalk and everything looks okay below that. So this is a purely third ventricular or starting with the hypothalamus. But given his cognitive decline, even though I thought I might leave tumor behind, I thought it was best to go endonasally to avoid causing further potential damage to his fornices by either a translamina terminalis or an or transcallosal approach. So here you can see after endonasal, and again, as I showed before, our ability to access the walls of the hypothalamus where the tumor is adherent allows me to deliver the tumor down. And here we see the postoperative view with a complete resection. And he actually surprisingly has improved cognitively even in the early postoperative period. What I can't undo is a poor hypothalamic or chiasm margin. In this case, we had a great margin. I could sharply cut it free. If it's too adherent, you will do damage to the patient if you try to push that margin. And that's really what part of the learning curve with this. So our learning curve of understanding how far we could push that has obviously improved over time. And here you can see looking over now over 100 cases, gross total resection rates improved dramatically over time, especially in that fourth quartile where now we get a gross total resection in almost 3/4 of cases. To go along with that, as you might expect, increased pituitary dysfunction. I've shifted a little bit. If I feel I can get a safe, complete resection, I usually recommend to patients, even if that means sacrificing stalk, that we do that, because the truth is long-term, if you leave tumor on the stalk, whether it's radiation that's used to treat it, whether it's repeat resection, they're going to deal with the recurrence and they're still going to lose function. So only if there's a good reason, like a child who's around the time of puberty, is it worth saving. DI rates have also risen, but not quite the same as hypopituitarism. As I mentioned, tumor recurrence was dramatically less in gross total resection. So we saw it overall in about 1/3 of cases, the average follow-up of more than 4 years. But with gross total resection, it's much, much less common. Here you can see what happened in those cases who had, instead of radiation, interestingly enough, gross total resection in our series, which is a relatively large series, was far more effective than subtotal resection plus radiation. There are certainly some studies that suggest that that might have equivalent outcomes, but they're not really within the same series. In our case, gross total resection was more effective. CSF leak remains an issue, but you can see again, over time, as we've improved, especially with nasal septal flap, you can see between that first and second quartile, that's very obviously where we introduce nasal septal flap. And here's a picture of myself with Haddad and Basagastagi, who really have saved endonasal surgery with their wonderful flap. Here we do indocyan green to often look at the flap now after surgery to see its perfusion, find that to be very useful. Other complications, you can see there one case of a thalamic infarct. That's from a PCA injury. As I mentioned, it's the posterior circulation. So we've had a couple of PCA, one PCOM, which we were able to sacrifice, but posterior circulation really is the key, and the vasculature you have to be careful of. So I think endonasal surgery can be used for virtually any craniopharyngioma. These large cysts, I think, should be addressed, and that's the only situation where I think you might need a craniotomy. And this provides a very natural inline corridor that allows us to get early stalk identification. We can see that hypothalamic margin to get the best resection, but we've got to make sure we're able to handle CSF leak. We've started in-person courses again. You can see here our Pittsburgh course where our dates are for this year, and you can see there the email for contact for further details about those dates and how to gain access to our course. Also want to invite everyone to join this free online website, which is designed as a sort of a blog or online community with everything from anatomy to quizzes to cases, examples, to help all of us learn better and have a discussion about skull-based surgery. And then finally, a new book I'm very proud of, which has a huge group of very well-known authors writing about all the different vascular considerations in skull-based surgery, everything from vascular flaps to perforator injury from both open and endonasal surgery. Thank you again for the invitation, and thank you all for your attention.
Thank you so much, sir, for the wonderful lecture. Like always, sir, thanks a lot for sharing the wonderful knowledge. I don't think that we have any questions right now, but there might be any question in the coming 5 minutes in the chat section. So again, thank you so much for sparing your precious time for the wonderful talk. So we are really honored to have you here. So
My pleasure.
Invite our next. Yes, please, sir. Yes, sir, we are moving on to our next speaker, Professor Juan Luis Gomez Amator, who is the professor and chairman of Division of Neurosurgery, Instituto Nacional de Neurología y Neurochirurgia, MVS Mexico. Sir, we are really pleased and honored to have you here. You always conduct amazing workshops in person, and it's great to have you here because you are also supposed to organize wonderful and conduct a wonderful workshop, the skill-based 360, in the coming few days. Sir, the floor is all yours now.
Hello, thank you very much for the invitation. I would like to share with you some experience in the endoscopic and endonasal transclavial treatment of ventral pontine lesions. So to start, I would like to say that the foundations of a safe surgical procedure are obviously the tridimensional anatomical knowledge, either under the stereoscopic vision of the microscope or the tactile vision of the endoscope. We need to have common sense and the courage to perform the different maneuvers that we need to deliver a lesion located in this region. Obviously, the learning curve is very important. In Pittsburgh, they have developed several systems to adequate the training of the residents and the neurosurgeons to become familiar with the endoscopic and endonasal techniques. So if we see what can we do with the endoscopic and endonasal procedures, obviously the most common lesion to be treated with these lesions is the pituitary fossa lesions. And for that, the pituitary adenoma is perhaps the most common lesion to be treated using the endoscopic and endonasal approach. But there are some other lesions that can be approached through this natural corridor that provides the sphenoid sinus, and we can have extensions on the coronal and sagittal plane in order to treat lesions such as meningiomas, cranopharyngiomas, as an excellent presentation of Professor Gardner, but also we can treat vascular lesions and also intrinsic lesions located in the brainstem. So for that reason, we need to become familiar with the limits that the endoscopic endonasal approach offers through the sphenoid sinus. So for that reason, we will define the sellar floor, the floor of the sphenoid sinus, the median canal, and the foramen magnum in order to divide three different approaches that take us to the transclavial region, so we can go inside the cranium using this very simple corridor, and we can address for a superior transclavial approach, mainly used for cranopharyngiomas, the middle transclavial approach, mainly used for chordomas, as well as the inferior transclavial approach. So how we do perform a transclavial approach? We need to identify the sellar region and the clavial recess, identifying also the position of the internal carotid artery, either by Doppler or using neuronavigation. And then we start to perform the drilling of the anterior wall and the floor of the pituitary fossa. And then we extend the osseous dissection using a telescopic diamond bore drill in order to accomplish the resection of the clavial recess, so we can take this dissection all the way to the floor of the sphenoid sinus. For the case of ventral pontine lesions, this exposure is usually enough to perform the adequate approach in this region. We need to remember that once we discover the dura mater, we need to have a proper hemostasis in this region. The location of the internal carotid artery in the transition of the petrous and paraclavial internal carotid artery is crucial in order to preserve this very important structure. Once we open the dura mater, we face the prepontine cistern, and usually there is a bleeding coming from the dura mater that we can treat very well with some surgical foam or the position of a patient if we elevate the head around 45 degrees. So the typical example for this is the clavial chordoma. In the clavial chordoma, we can use either the superior or the middle or the inferior transclavial approach. But before, we need to address the quantity of bone, dura mater, or even the cisternal compartment that is going to be treated using this technique. The presentation is a little bit slow, but one of the main important steps that we have learned treating chordomas is that once we finish the dissection, we face just in front of the basilar artery and the ventral area of the pons. So that will allow us to perform a precise dissection of certain lesions located in the ventral pons area. So, as Professor Gardner said before, one of the main steps of the surgical procedure is planning the reconstruction. And in our experience, the multi-layer reconstruction technique is the best way to avoid the CSF fistula, which in these cases account for even 30% of the cases. So adequate harvesting of the nasopediculated flap is very crucial in the procedure, and we need to use a series of layers in order to separate the prepontine cistern from the sphenoid sinus. Once this gets okay, I will continue with the lecture. There might be some problem with the presentation or the Zoom, but anyway, this multi-layer reconstruction technique will allow us to separate these areas in a good manner. What kind of instruments do we need to use? Usually, the 0-degree endoscope is just enough to treat most of the lesions that we are treating using the endoscopic endonasal approach, either by some straightforward approach as the transclival, or for some other lesions, we can use a contralateral transmaxillary approach or the parasagittal approaches, in always facing forward to the lesion. One of the main things that we need to address is that in endoscopic endonasal surgery, there is no such thing as pull and pray. Always we need to perform a careful dissection in order to see what we are treating here. I will stop sharing in order to advance the presentation, but it is very important that there are several instruments specially designed to treat lesions using the endoscopic endonasal approach. And most of them are just straight instruments that we are putting just in the front part of the endoscope, so we can work very nicely around the endoscope using two instruments. Just in a moment, the presentation will continue. I just apologize for this delay. But anyway, when we are trying to deal with the lesions located in the ventral pons area, it is very important to know that the reason to treat these lesions is because we don't need to cross any nerve, and we can preserve properly the structures that we will treating using this approach. I will continue to share my slides. I hope now it runs very well. So, for example, this patient with a very large basilar aneurysm located just in front of the pons, causing a huge displacement of the brainstem, was treated using this endoscopic transclival approach. So the reason to treat this patient that was already occluded by the endovascular team was just to decompress the aneurysmal sac in order to relieve the brainstem compression. So once we finish the middle transclival approach, we open the dura mater, and then we just immediately face the mass of the aneurysm just in front of us. There is a very straight corridor. There are no nerves around. There are just the lesion in front of us behind the sphenoid sinus. Once we open the lesion, we start to decompress the lesion using ultrasonic aspirator in order to remove the clots that face in front of the aneurysm. As you can see here, once we achieve a good decompression, then we confirm it by neuronavigation. And after this, we continue to decompress the lesion. And after that, there is the need to occlude the aneurysmal sac using several clips. You can see here we are able to lift up the lesion. We face the 6th cranial nerve behind, and then we close the sac. In that way, we help the patient by relieving the compression of the brainstem. Another case, a patient with a vertebrovascular aneurysm that was treated also using the middle and inferior transclival approach in the hybrid OR. And this allow us just to perform, as in the case before, the internal decompression of the aneurysmal sac in order to relieve the brainstem compression. Now it's blocked again, I apologize, but using this approach, then we see that we can treat lesions that extend in the prepontine area, such as some case of neurocysticercosis or some other lesions that stay in this region. And that, for example, can be used also to treat some very central meningiomas located in this area. So once we become familiar with the dissection of the clivus and the management of the Batson venous plexus, it is very easy to reach this area without having any complication. One of the main tricks that we use is we elevate the head of a patient and we use hemostatic foams that can be very safely be used when we are dealing with some bleeding coming from the venous plexuses, but never to be used when we are having an arterial compromise because of the risk of producing an embolism using these hemostatic foams. It's very important to know the anatomy and the ways that we are facing in this area. So microneurosurgery should be used as the main principle when we are using these techniques to treat this kind of lesions. And for that, we know that we can treat deep-seated lesions in the brainstem using just the natural corridors, as for example in this mesencephalic cavernoma or this thalamic cavernoma or this pontine cavernoma using the conventional approaches. So why we go to the endoscopic endonasal approach? Because if we analyze precisely the dissection of the white matter, we know that there are several spots in which we can approach the ventral pons using an anterior corridor instead of the conventional lateral or anterolateral approaches. So for example, in this case, the careful analysis of the anatomy and taking into account this very straight corridor, we can face a lesion like this one located in the ventral pons and displacing the white matter tracts, so we can have a very straight forward lesion, approach for this lesion. This is the case of a male of 29 years old. He came to the hospital with a very severe motor deficit with palsy of the 6, 7, 8, and 9, 7, 9, and 10 cranial nerves. We put him on tracheostomy and gastrostomy, and we took the patient for nutrition during 3 weeks. And when the conditions of the patient improved, we were analyzing the MRI scan. So we looked at the fibers were displaced by this lesion, which was compatible with the brainstem cavernoma, okay, in the anterior pons. So we choose to perform extended, mainly middle and a slightly inferior transclival approach to face the lesion, just as you can see here. So once the clivectomy is performed, we work lateral to the basilar artery and we approach the lesion directly. In a short moment, I hope the video will run. So the initial steps to treat a lesion like this is slightly different than the technique that we use in the interparenchymal lesions. So for the first option is to decompress the lesion to evacuate the associated hematoma. And then once we have the necessary space, we can dissect the borders of the lesion so we can deliver the active portion of the cavernoma through a very small opening, in this case located in the fibers of the anterior ventral pons. I ask for your patience for this delay. But once we take advantage of the technique, we are able to insert the endoscope in the surgical field so we can observe directly under direct vision all the angles of the exposition, so we can be sure that no residual cavernoma is left by using the direct visualization. I think I will have to stop sharing again and just wait a little bit.
We're all having issues in the screen sharing.
Yeah, I know. Just a little bit and it will run properly.
Acting up again?
We all are having the same issue.
Just go off and
sharing,
come back
sir,
on one.
probably there is-
Yeah, just leave this. Okay, can you try it now?
Yeah, it's coming. Just my computer is blocked just right now. I hope it will come very soon. Just a minute. So it is very important to use structurography in order to analyze how the white matter fibers are behaving around the lesion. This is a critical and perhaps the most important study that we can perform in these patients in order to avoid any damage to the pyramidal tract that in some of the cases lies aside or behind the lesion, particularly when the lesion is located very anterior in the ventral pons. I'm so sorry. Completely blocked.
It's not you. We've had that issue with other people.
Okay, okay.
Probably Zoom, an issue in Zoom right now.
Okay, okay. So I hope very soon it will run properly. Because now it blocked the computer.
It's a drastic measure, but you can leave the Zoomcast, come back in, like refresh it. Do you know what I mean?
Okay. But just
We
now
can try that. We can try that. Just go out of the Zoom, click the link again, and come back in.
Okay.
Let's try that.
Or we can, or Dr. Bennett, you can put him in the attended list, attendee list, and then upgrade him again and the panelist list. That will also fix the problem.
Okay. Just as soon as this goes.
Yeah, exactly. So this is occurring to everyone right now.
Okay.
Yes, sir. Probably there is some problem in Zoom.
Block now, so I cannot perform any task, but it will come surely.
It's a drastic measure, but leaving the webcast and then coming back with the same link.
Okay.
Yeah, try that. Let's try that. Just take a digital coffee break.
Yes, give me 2 minutes, and I hope this will run properly.
That's okay. We have the breaks and conferences.
I think his PowerPoint has been jammed. Like I had in the last talk. Do you remember I had the same issue in PowerPoint? I had to reinstall it. Today it ran a little better, but still I'm having a few glitches in using the PowerPoint.
It's a drastic measure, but sometimes it works. I find that rebooting my computer solves 90% of problems.
Yeah, exactly. Always does. But it usually, washes away.
Yeah, it's bizarre sometimes.
Yeah, it's very difficult because you have all the settings. Yeah,
first step I
totally
use, reboot.
Yeah, exactly. That's also several issues. I usually keep one of my presentation, the copy of my presentation in my cell phone as well, because sometimes it is much easier to use smartphone to screen share. I don't know why.
Okay, he's back. Is he back?
Oh, wonderful. Yes, working now.
Okay. Are you there, Doc?
He's using smartphone, like I said. Wonderful. I guess the smartphone.
Lo siento, no encontré DDD en tu música.
It's perfectly working, sir. But we cannot hear and see you.
Okay,
I don't know why, but smartphones are much better in using Zoom and even Microsoft Teams. I'm enrolling currently in a university course.
Here he is. Well, Doctor, there we go. Let's try it again.
Yes, sir. I'm here.
Okay, it looks like it's working. Okay, keep our fingers crossed.
Okay, so I was telling you about the precise lesionectomy that we can achieve using this straight corridor through the transclavial approach. This is the patient in the immediate postoperative period, and after 6 months, he was able to regain the deambulation, but he persisted with a brachial deficit after this. So we have used this. Okay, Jesus. We were able to perform the surgery with no further complication. Now it's blocked again. I'm so sorry.
Unfortunately, no, it's not you, Doc. It's Zoom. It's Zoom.
Yeah, I will escape again and try to come inside so we can solve the problem.
Okay, yeah, okay, no hurry, whatever. We got time. Yeah, Dr. Diopujari never had problems with Zoom before. And today was the first time. You remember the first talk?
Yeah, exactly. You know, it's happening.
He was puzzled. He was puzzled, and most other people are struck by what the heck is going on.
Exactly, that's happening. You know, I can just relate to it, but that's happening quite frequently, I guess, because there are so many programs running right now on Zoom around the world. Saturdays are really busy.
Okay, okay, we'll try it again.
This is another case in which we use also the endoscopic transclavial approach to treat this intrinsic lesion on the pons. And as you can see, we're using both hands in order to relieve the mass effect of this lesion that was causing several neurologic damage to the patient, such as bilateral pyramidal syndrome, 6 cranial nerve palsy, and in which we were able to decompress the lesion in a subtotal fashion, which turned out to be a metastasis. So we use this approach to relieve the pressure on the brainstem and to have a diagnosis, because previously we have a negative thoracoabdominal CT scan and also a negative methionine PET. So this is the postoperative result with adequate decompression of the lesion. This is an immediate postoperative MRI. And we use the same approach to treat this patient, very young female, 27 years old, who presented with acute headache and left hemiparesis and left hemianesthesia. So the location of the lesion told us that we can have a straightforward approach using the transclavial approach in order to treat this lesion. So during the surgery, we perform the transclavial approach. We do the hemostasis of the basilar plexus using both hemostatic foam and bipolar coagulation. We face the anterior portion of the pons. We displace slightly the basilar artery. We enter the cavity. We address the hematoma. And with careful dissection, we are able to perform the precise lesionectomy of this cavernoma using the endoscopic endonasal technique. We are able to inspect the interior of the cavity using the endoscope, so we can see that there are no residual lesion, and then we perform careful hemostasis using a hemostatic sponge. After that, the careful reconstruction is performed with a multi-layer fashion with a Dural substitute, a fragment of bone, also a patch of fascia lata, and then we put above all of these the nasal pediculated flap, and we put some glue in order to isolate the lesion. This is the postoperative course of the patient with the adequate decompression of the lesion. The patient was intact in the postoperative period, and she was able to regain her normal life 2 months after discharge. So the main deficit of this patient was slight hemiparesis and a slight hemianesthesia, which was taken care in a good manner. In the postoperative scan, you see there are no damage on the brain stem, and there is just the precise lesionectomy that we were able to perform using this very straightforward approach. In this area, we can see the nasoseptal pedicle flap that covers the defect. And in some cases, when we are using these transclavial approaches, we try to put in front of the nasal pediculated flap a fat graft in order to prevent any further complication and to diminish the CSF fistula. This is a patient in the postoperative period in adequate condition. She was able to walk, and she's intact in the cranial nerves because the root does not have to see anything with the nerves because we are working in the very central and ventral portion of the pons. So there's a few cases reported in the literature, and out of 751 cases in which the conventional approaches were used, just 9 cases that we record up to now were done using this endoscopic endonasal technique for pontine cavernoma. So as you can see here in this resume, we see that the most frequent complication in these cases is the CSF leak, and one case of aseptic meningitis reported by London in 2020. So we need to know that the CSF leak accounts for up to 30% of the cases in this small series around the world. So we need to be very careful with the dissection and So I can say lastly that the transclavial approaches gives a direct surgical corridor for certain pathologies located at the skull base, mainly craniopharyngioma, chordoma, etc. And some lesions located at the interpeduncular, prepontine, and prebulbar cisterns are very easily accessed through these approaches. The treatment for intrinsic lesions located in the brainstem using these techniques should be reserved for very selected cases. In most of the times, regular dorsolateral approach using either the transpetrosal approaches in combination or the far lateral approach are indicated, but for some other lesions, this approach is very direct and exposes the lesion very easily, and there is no harm for the patient. Obviously, the experience of the surgical team and a careful analysis of the case must be addressed to use these techniques in a very particular case. I apologize for the problem with the internet, but that's all I want to say. Thank you very much.
Thank you so much, sir, for the amazing lecture. We are all having the same issue right now on Zoom with the this screen share option. Thank you again, sir, for sharing your wonderful talk and all the wonderful points that you have shared. I don't think that we have got any questions right now in the chat section. However, there might be any question added in the chat section. So again, thanks for joining us today. Let me have the honor of inviting our next. Thanks a lot, sir.
Thank you.
Thanks, sir.
It wasn't you, Doc. It was Zoom.
Thanks a lot, Joan, for this excellent presentation. Okay, we will start sharing. Okay, books to Zito.
Thank you so much, sir. Let me have the honor of inviting Professor Diego Mendes Rosito, who is professor of Centro Médico Nacional 20 de Noviembre, and also a very active teacher and mentor in terms of neurosurgical workshops and webinars. We are so much fond of all of your lectures that you have shared before. Sir, thank you so much for joining us today and for providing us the privilege of listening to your wonderful lecture. So the floor is all yours now.
Thank you very much, Maria. Thank you again for the organization committee. Thank you, Dr. Same and Mursi for the wonderful organization and for pushing the education through this wonderful technology, even though it had some malfunctions, but most of the time it works perfectly. And also, John, for your magnificent work all around the world, bringing neurosurgery closer to everybody. Thank you very much. Today, I was assigned to talk about the middle fossa, unlocking the middle fossa approach. I'm going to share my screen, if you see it. Today, I was assigned to talk about the unlocking the middle fossa approach with a 360-degree perspective. I think from my point of view, talking about the middle fossa, it's so very important, and sometimes the view of how we can work all around the middle fossa, I think that sometimes is not as visualized as wide as some other entities, some other approaches. In our manual, skull-based manual that we have been working in our lab, we center 3 different regions that are the most important regions in order to master the skull base from our point of view. One of them is unlocking the middle fossa. This means the cavernous sinus and the paracellar region, but it's beyond that, because as you will be able to see in this lecture, you can use the middle fossa in order to access the anterior fossa, the paracellar region, the posterior fossa, the infratemporal fossa. So it's a view in a 360-degree fashion. The second part of our manual is the use of the temporal bone as a surgical corridor in order to use transtemporal approaches, from the anterior petrosectomy to several types of posterior petrosal approaches, and different types of posterior fossa approaches that you can use using the temporal bone. And the third, as we saw in the magnificent previous lectures, the advanced endoscopy course. This endoscopy, it's here to stay, and as we've seen by Professor Gardner and Maria Periselda also showed, magnificent lectures in why it is so important to use the endoscopic approach to different pathologies. So at the end, we consider that these three surgical corridors are so very important in order to master a great variety of pathologies from the skull base. Today we're going to talk about the middle fossa. As we said, the middle fossa, as we know, it's the middle fossa of the temporal bone of the cranial base, as it can be seen here anatomically in this green region. But the important thing about the middle fossa approach is not only locating that region. The important thing is about using it as a corridor to access different regions in all of the skull base. So at the end, we consider, as I mentioned previously, that it's some part of kind of center of the universe in a way, because we can use it as a surgical corridor to access different pathologies. It is not only doing this, that this is done in our cadaver lab, that dissecting the epidural work, it is the basis of much of this work, but it goes beyond that, as we're going to be able to see it. Here we can see a cadaveric dissection of the cavernous sinus, where we can see the 3rd cranial nerve, the 4th cranial nerve, the infratrochlear triangle here. We can see the carotid artery and the meningopophyseal trunk coming from the posterior bend of the carotid. We can see the trigeminal nerve here, and we can see the posteromedial triangle, and we can see the GSPN and the middle meningeal artery. So at the end, you will see how we use this corridor in order to access different types of pathologies. How we do it? We do it with a regular pterional approach. As you can see here, we try to always identify the superficial temporal artery, just in case there's a vascular need. We do the regular pterional approach, as it can be seen here. It is important to take the best dissection possible of the soft tissues in order to take a better retraction of the temporal muscle. And we do a regular standard pterional craniotomy. Then what we do is that we drill the orbital roof, always leaving the orbital roof like this, in order to expose the orbitomeningeal band here, as we can see here. And it is very important to dissect to identify down here V2 and in order to access in order to see V2 in this region. After we cut, as we sharply cut the meningohypophyseal, the orbitomeningeal band, we can see here that we are dissecting, and we opened the superior orbitary fissure, and we see the anterior part of the cavernous sinus. We expose the anterior clinoid process, and in this moment we did an anterior clinoidectomy in order to expose the carotid in its clinoidal segment and to unroof the optic nerve. And so at the end we have the starting of a peeling of the middle fossa by exposing the cavernous sinus, and then we continue. And then we continue with the complete middle fossa dissection. As we can see the complete cavernous sinus, we can see the GSPN and the posterior medial triangle of the middle fossa. And when we continue and we do an anterior petrosal approach, a transmechal cave approach, and we dissect the basilar artery and the fourth and the third, we can see that we have a very wide exposure of the complete skull base region. So at the end, when we are here at this point, we know that we have many routes that we can take. Of course, we're not going to do all of this in order to access, but you can do the beginning of the dissection in order to access the orbit, or to access the anterior fossa. You can access the paracellar region, the clinoidal region. You can access the cavernous sinus. You can access also the posterior fossa, either by using the transcavernous sinus approach, transmechal cave, or the anterior petrosal, or we can access also the infratemporal fossa by its roof, going to this, using this corridor. So at the end, there are many phases. There are several phases that we're going to use only when it's needed in a stepway fashion. Okay, so for example, if you're going to the orbit, we're not going to do all of the dissection, but we have to know perfectly the anatomy of the orbit in order for several types of pathology. For example, in this case, we don't have to go inside the orbit, but by unroofing it and by removing the bone that we have all around it, we decompress the optic canal and the anterior, removing the anterior clinoid process, and we improve the proptosis that this patient has. And so at the end, it's a matter of here we can see the improvement, and it's just like the first part of the approach. And also going to the tubercular to the paracellar region in the tuberculum meningioma, as we can see here, this patient, she had an acute visual deficit due to acute growth during pregnancy of this meningioma. And so what we do in this case is that we do, as I showed previously, sorry for that. As we do the standard pterional approach, we do the muscle dissection. It is very important. We consider that it's very important to do a lot of extradural work. And for example, in this moment, we are identifying we are drilling the roof of the optic of the orbit. You can see there that we went we dissected the periorbit. This is the normal, for us, this is the normal dissection of the orbit in order to see the orbitomeningeal band. We can see here the base of the anterior clinoid process. Here we are drilling the anterior clinoid process. And since this patient had an acute deficit, what we do in this case is that we like to decompress completely the optic nerve, not only from the tumor, but in its complete length, in order to have a wide decompression and remove the edema that this patient might have due to this compression of this tumor. At this moment, we are doing some dissection there of the implant site of the tumor. As we can see here, we are opening in order to access the floor of the tumor and devascularize it early. As you can see here, those are the branches of the posterior ethmoidal arteries that are irrigating the nerve, the tumor, I mean. And so at this moment, as you can see now, the tumor is basically devascularized and it's almost dead. And we can just continue the dissection in order to remove what we have of the tumor. And when we remove it, we can see that we have a complete exposure of the pituitary stalk, of the contralateral optic nerve, and the visual pathway is completely decompressed, as we can see here, without a tumor, and the patient completely improved her visual symptoms, even though she was pregnant, and the baby did well. Some other tumors are also a little bit more complicated, but we use this corridor in order to have an early devascularization in the floor of the tumor, since these tumors have so much edema, and that's what we use in order to have a wide resection, and the patient did very well. Then if we go to the paraclinoidal region, what we do, for example, here we have a large tumor that seems to be contacting the anterior clinoid process here, and it goes dorsally in order to have an important mass effect. But this part, we consider it's the most important part to understand the origin of the tumor. You can see the complete video in that publication. And so what we do is we do the same thing here. We again expose the orbit, the orbitomeningeal band here, it's exposed. And when we expose the orbitomeningeal band, we can do a dissection in order to expose completely extradurally the anterior clinoid process. This dissection, it is very important to always keep in mind the anatomical concepts of the anterior clinoid process, its relationship with the optic nerve, with the internal carotid artery, and with the oculomotor nerve. Very important to understand the attachments of these tumors. These can have these three different types of attachments, and how they behave, it's different from one another. But it is always very important to understand the attachments of the anterior clinoid process, a lateral to the sphenoid wing, to the optic canal, and to the optic strut. So it's very important to have these concepts in mind when you are doing the anterior clinoid process. At this moment, we identified that there was some kind of pneumatization, and we double checked it with the CT scan, pre-op CT scan, and we saw that it was a very vascular pneumatized anterior clinoid process. So we tried to drill the most that we could in order to devascularize the most that we can of the tumor, and then we opened the dura. And at this moment, the first thing is we are identifying the internal carotid artery. We are identifying at that point the optic nerve, the chiasm. And so we continue doing the dissection and removing the arachnoidal dissection that this tumor has with its neurovascular relationships around it. And then when we are done with the dissection, arachnoidal dissection, we can come out and remove the complete tumor, and there we can see that we have the normal anatomy of the paracellular region. And so it's very important that doing that dissection helped us devascularize that tumor. And so this is the patient, this is the post-op. The patient does fine without any complications. There are several sizes of tumors with different types of edema that it is very important to attack early on the anterior clinoid process. For example, these other tumors that go into the cavernous sinus, that it is very important to have this anatomy, to have the knowledge of this approach, and to understand the anatomy of the cavernous sinus. For example, in this case, we can see that we have this meningioma that it's involving all the cavernous sinus and the sphenoid and the petrosphenoidal junction of the meningioma. We know that this is not going to be a meningioma that it goes all the way to the tentorium. We know that this meningioma will not be something that we can remove 100%, but it is important, one, to have diagnosis and to remove it as much as we can. This patient, as we can see here, have double vision, so it is very important to do a decompression. We do the same approach. We do also a arteriovenous, as we can see here, with the dissection, adequate dissection of the muscle in order to have a wide exposure. And there we can see V2. We can see again the orbit unroofed and the orbitomeningeal band. Here we can see the superior orbitary fissure and the cavernous sinus, where we are dissecting the cavernous sinus there. Once we remove the middle meningeal arteries over there, and when we do this dissection, we are peeling the tumor from its origin. So we devascularize the tumor. Here we have the complete exposure of the middle fossa of the cavernous sinus, and we remember in our heads the projection that we have of the trigeminal nerve. So at this point, we are identifying there the infratrochlear triangle of the cavernous sinus, and we can see that it's a very fibrous tumor it's difficult to remove, and we can continue with the dissection. We know that we're not going to achieve a complete gross total resection in these tumors, but we try to decompress it as much as we can. And so what I like to do is that I like to do a longitudinal incision that comes all the way from the optic nerve to the tentorium in the posterior fossa in order to remove that thickness of tumor, as we can see here, as you can see there. And so, as you can see, what I like most about this approach is that the tumor is completely devascularized there. So we can continue and trying to clean the most that we can of this tumor in order to have a wide decompression of the tumor. It is very important there. We can see that we have all the trajectory. It's very important to identify the normal tentorium, as we can see there. We can see normal tent. And so we can see there the pons that it was contacting the tumor, and we can continue with the dissection and cleaning up the most that we can of this tumor as we are removing this big piece of tumor, as we can see there. We try to continue the cleaning up the most that we can. We can see again the pons that it's decompressed in a way, and this is the post-op, the immediate post-op. The patient continues without any worsening of the symptoms that she already had. This is, for example, trigeminal schwannomas. This is a very good approach in order to access, as you saw in the previous approach. This is the result, but it is a very good approach for these pathologies. Also, for example, in pathologies where we use it, combining it with other approaches, there's a lot of versatility. And for example, when we access the posterior fossa, as you can see here, sometimes one of the thoughts is, where am I going to find the internal auditory canal? So we did this study that we identified using the arcuate eminence as the center of the visualization in order to find an important point that we are showing here, that from this point, 1.5 centimeters that are going to be the length in order to identify the internal auditory canal. So it's very important finding for us in order to have this endpoint to be the referral point in order when we do the drilling of the middle fossa. We use that point, for example, in this case, where we have such a large tumor with a patient that it's basically neurologically intact, and such a large tumor with a big compression and with a pneumatization. What we do here, we have an important pneumatization. What we do is very important that we go to the lab, we go with and try with the fellows in order to everybody to be in the same channel in a way, in order to continue to have the same plan from the OR, from the lab to the OR. And so we do first the approach when we have those complex cases, we do that approach in the lab. And then from the lab, we decide to go to the OR when we are ready and we have all the details. And so that's what we do. And it's very important to transmit that to our younger generations in order to keep on improving our approaches. And so at the end, what we do is we combine the middle fossa approach, combining it with a posterior fossa approach in order to have a combined petrosal approach. So it's part of the versatility of this approach that it's very important. And this, the difference is, it all depends, but the difference here is that we are dissecting the middle fossa from the back to the anterior part of the middle fossa. There we are identifying the middle meningeal artery in a very straightforward way, in order to decompress, in order to dissect there the V3, and that is very important. And we can see that we have the middle fossa, we have the Kawasa's triangle or posteromedial triangle of the middle fossa, and we can continue, and we can here, this is very important, the arcuate eminence is the point that I was talking about. And that point is very important in order to find here the endpoint, in order to have 1.5 centimeters in order to identify the internal acoustic canal. Okay, and so there we are combining it with a partial posterior petrosal approach. We like to open the dura in this fashion that we just showed. It is very important, one, to deplete some CSF. And second, basically I use the posterior fossa mostly to identify the 7 and 8 complex. But the rest of the approach is more like in a fashion of middle fossa. There we're identifying the middle, the tentorium, very important to identify there the tumor, the incisura tentorial, and to be able to cut there the last cut carefully in order to be aware of the fourth cranial nerve. When we open the anterior petrosal approach, we continue, and we find very useful that point, that it's unlocking the trigeminal nerve, free it from the tumor, and be able to mobilize the trigeminal nerve. At this point, we are using the middle fossa as a surgical corridor, where we identified the 7 and 8 complex. And it is very important that at this point we have a very wide exposure of the tumor. We can see the fourth cranial nerve, and we can continue the dissection, as we can see there. And there we can see the sixth cranial nerve, and we have some tumor decompression. And as you can see, we can work from either side of the trigeminal nerve, medial or lateral to it. There we saw the basilar artery, and at that point we can see the trigeminal nerve intact. And so at the end, what we do is that we put a patch of muscle, we put some Duragen, very important, the reconstruction of the middle fossa due to the pneumatized apex, and there we can see, we can fix it with some fibrin glue. And that's how we leave, and we have a wide resection of the tumor, a gross total resection of the tumor, and the patient with a sixth cranial nerve, which was in the immediate post-op, but there on, after 3 months, she improved to 100%, and she was neurologically intact. And the last of all is accessing the infratemporal fossa through, as we can see in this dissection, we can see that on the previous case, we were working all around this region. But for example, if we continue dissecting into the infratemporal fossa, we can see the median nerve here, and we can see the posterior wall of the sphenoid sinus and the maxillary artery and the branches of B2 and the branches of B3. And so it's very important that we can access also the infratemporal fossa through its roof. And it's part of the same pterional approach, just taking in more advantage by unlocking it. And for example, in this case, we have a wide tumor that goes into the pterygopalatine fossa. And so it's a very large tumor that it's in the compromising the posterior wall of the sphenoid of the maxillary sinus. We can see that it was a very calcified tumor. And as we can see in the same approach, I'm going to go a little faster due to time. But the thing here is that just by dissecting and by doing this extradural work, we can see that the tumor was so hard that we had to drill it all the way. And we can see that at the end, we have some dissection here of the middle fossa, as we can see here. And as we are exposing the complete tumor, this is all the tumor from its roof. And we can continue with the dissection. We can continue with the drilling. Very important to mobilize it, to try to drill it because it was so hard, as we can see there. And the most important thing here is to identify B2 and B3. And so at this moment, we can see the muscles, the pterygoid muscles from the roof of the infratemporal fossa. And there we are continuing. And there we can see the limit from the orbit from B2. And I'm going to be showing, we do later on, we cut the orbitomeningeal band as we mentioned previously. The anterior clinar process, which is not needed to be removed in this case. And there we continue with all the removal. But the most important part here, we can see V2. And so we are dissecting completely what we have of the tumor. And down below, we can see the Vidian nerve. And here we could see the pterygopalatine fossa, the posterior wall of the sphenoid sinus. And here we can see V3. And so we are working between V2 and V3 in order to access the infratemporal fossa. And this is the postoperative result. And there was some small residual in the medial part. We didn't want a CSF leak. And the patient did pretty well and so many other cases that we can use, and we can complete this was a large chordoma when we completed it with a endoscopic approach in order to have this wide resection, like in this case. And so at the end, I'd like to conclude that this approach is a very useful tool in the armamentarium of all neurosurgeons, allows to access, as you could see, all the skull base. Very, very important to do a lot of lab work and to do a lot of dissections of the skull base, but it's very important to have that three-dimensional view. You are very welcome to come to our courses. Then we're having the skull base course of the middle fossa in May 19 to 22 in this year. You can subscribe here in basedecranio.com.mx. Thank you very much for your time and for your attention.
So much, sir, for the wonderful talk and for sharing your wonderful points. These are, the points you have shared are really priceless, and we are really pleased and honored to have the privilege of listening to you. And all through this virtual platform, we are all having the benefit of listening to all the wonderful points that we used to, we used to yearn to have the opportunity to listen to people like you, to the legends of neurosurgery like you. All these recordings.
Thank you,
Thanks
Maria.
a lot to both for this excellent presentation. It was always great to have you as a lecturer and as a good friend.
Thank you, my friend, Dr. Same. It's an honor. It's late now in Egypt, but thank you very much for letting us being part of your wonderful program, and congratulations for your organization.
Yeah, I'd like to invite you, Diego, to broadcast any of your skull-based presentations.
Thank you, Don.
Just let us know.
Okay, perfect. Thank you.
Okay, Sam, any closing remarks?
I will let you close this excellent Congress. Thanks, John, for these lectures and your efforts.
Okay, yeah, I'd like to thank, of course, Sam put this wonderful lineup together. I think it's the best on the internet right now, the lineup you put together. And thank you, Nor, for helping us get through. We had our bumps, but that's okay. We got through it and we presented a lot of good stuff, including Diego's presentation, which is going to be on YouTube forever. Okay.
Thank you, John.
Good day, everybody. And stick around, Sam. Stick around, okay?
Thank you.
Thanks a lot, sir.
Okay, we're off the air.
Okay.
Does Sam go? Okay. Well, yeah, that was good. We have Diego. We had problems with Zoom. You didn't have any problems.
No, thankfully. Thankfully, I was worried about Juan Luis and the problems, but it was okay, I think.
Yeah, there were no glitches, but some of the other people just all of a sudden in the middle it just stopped.
No,
a couple of presentations, but overall we got through it.
All right, John. How's everything in Miami? Everything good?
Yeah, it's getting better as most of the world, although it looks like it may be coming back. China, I don't know what's going on. I thought we were over it until I got that news from China. But in China, we talked to Ben. I talked to Ben yesterday, and he said China's really clamping down again with their security measures. So they'll probably stop it, but I don't know about the rest of the world. They're not as surveyed as much as China.
The world has been crazy in the last years, huh?
Yeah, it is so strange that we're running through this during our lifetimes.
But the good thing is that you are transmitting from Miami to all over the world, and so it's safe and it's a good educational tool, and so it's been awesome.
Yeah, we just came at the right time, and you know what, Diego? I think I told Nora this. I interviewed some people at Bogota just quickly on the floor, and it was almost full. You didn't go, right? You're in Mexico.
I went, but only one day because I had to come back. Yeah, I was busy here in Mexico, so I went for one lecture and
one day, huh? Wow, you flew all the way down to Bogota from Mexico for one day. Wow.
Yeah.
Wow, but I think it's my personal opinion that people will go back to the conferences, and sure they'll like it, but I think at the end of the trip they'll go, I spent $2 or $3 grand. I got some information, but next time I'm going to stay home.
Yeah, definitely.
I really think that now that people know that they have an option.
Are you going to Rio?
No, unfortunately, I'm not. But I know a lot of people that are. When does that start?
Next week.
Next week.
Wednesday.
Yeah, I'm going to try to televise it, but and that's one place there was somewhere I'd like to go anyways.
Yeah.
That Rio is one of them.
Of course.
But we'll see what pans out. But I think virtual will always be part of conferences, right, Nora? I think it'll be part of a conference. They'll have a section where, we're live streaming it also.
We hope that next time we can go to Egypt physically and not online.
Yeah, well, that's one. A friend of mine's a travel agent, and he said, of all the countries in the world he's been to, he said Egypt is the most interesting.
Yeah, it must be.
History-wise, is incredible. All the stuff, all the things we heard about. I finally went to Greece. I don't know if you've ever been to Greece, the Acropolis. I felt like I've heard about this place all my life, the Acropolis and stuff. And after I went there, it was like incredible.
Yeah, it must be
so worth the trip. And all the people were at the Acropolis. They were similar to me. They were waiting all their lives to see the Acropolis, and everyone was quiet. It was deadly silent.
Beautiful.
People were so like in
Amazing.
awe, and it was just looking around and taking everything in. It was an incredible experience to go to.
Beautiful.
You know, we've heard about that all our lives, Acropolis
Yeah.
and Athens and Parthenon and
Yeah.
etc.
So many things that we want to do.
Yeah, same as
Travel.
Egypt. But anyways, okay, very good.
Okay. Very
Thank you
nice
very
to
much.
see you, Nor. Thank you very
Thank
much
you
for
so
the
much, sir.
invitation. Okay.
Honored and pleased to have you, sir. I'm so happy to listen to your wonderful lecture, sir. It's a huge privilege, sir. I've been talking to Dr. Bennett about this when I started my training a few years ago. We always wanted to have the opportunity to attend all the workshops, but
Of
sir,
course.
obviously, exactly. But sir, without this virtual platform, it is not quite feasible for all of us to attend. Many of our junior neurosurgeons are left behind, and I think this is the time when we actually need to learn the most. Sir, many times, you know, many of the trainees do have affordability issues, not only affordability issues, who can afford to not get the leave. Because when I was a trainee, when I wanted to go, I was never allowed to the leave to attend because I was on a call, and everyone would ask, no, you are not supposed to go right now. So this was a huge problem for us to get the
Of
leave
course.
to go and attend a conference abroad. So, sir, this is a huge privilege right now to have the opportunity to learn through the virtual platform, and it is adding up a lot. So, thank you so much and I think you all people are the wonderful mentors who are actually sparing your time to share your wonderful talks. And this is a
Thank
high
you.
level of dedication, sir. So, really honored.
Thank you, Nor.
Does anybody in the panel want to come in? There are a lot of people there. Maybe they want to come in and chat. Maximo, Martin, Luckman. You know, a lot of people come here. They don't want to. That's okay. They don't want to talk. They just want to watch. But you're all welcome to come in. Uday, Suan, Nara, Maximo, Martin, Luckman.
Okay. Very nice to see you. I'll be getting in touch here with my family this on Sunday. And so take care, everyone. Was
Thank
very
you.
nice
Thank
to see
you very much, Diego.
Okay,
Thank
John.
you.
Take care.
Okay.
Bye-bye.
Great. Bye-bye.
Nor, take care.
Nor, you gotta call me tomorrow, okay?
Yeah,
Once you get some sleep.
Yeah, exactly.
But you know, I bet you're a late night person. I bet you keep that smartphone next to your head all night long, right?
Yeah. Yeah, exactly. That happens. I'm a late nighter, so I usually I stay awake for much long because I think there are several things that are going on all the time. So I'm trying to do my very best, give my best to everything. So I think that I'm a late nighter. So I need to get to know what there are a few tasks at home right now to look at. So I'm just excited what you do about that. So you are.
Well, I'm going to talk to Phil tomorrow, Tuesday, but first I've got to do anatomy of his website, you know, anatomy. I got to examine what it does and physiology, how it works, you know, and, you know, basically I like this, and I get the impression it's like a private Zoom. Like, in other words, they have an organization of anesthetists that have conferences. It's all private. It's not, I don't think it's not live. It's not, so it's a different concept.
No, he has just started the live concept right now. So it might
Oh,
be.
what's that? Did you talk to Phil?
Yeah, I talked to Phil. Actually.
Oh, okay. So it is, he's just starting the live ones, huh?
Yeah, he has just started the live ones.
Well, you know, I tried to join it. I don't know if you tried to join his website, but you got to have an email address from a list of schools in Northern Ireland. So it's kind of like a closed community. Have you tried to join his website?
I'm actually having a lot of interruption right now. Yeah.
No, in order to see some of the videos, you got to be a member, and I can't get in there. I think after I talk to him, he'll let me in, but you got to have an email address of a school. You know how that works, right?
Actually, I'm having a little problem right now with the internet. I'm having a lot of sound interruptions.
Okay, well, okay, Nora. Well, I'll let you go, and I'll talk to you tomorrow. I'll let you know what I'm thinking.
Okay, I'll be there. I'll be there. He's from the United Kingdom. He's in Essex. So yeah, he has actually this. He's been running this platform since quite long. He didn't have that live option before. He had just introduced that live option, so he was like very interested. He was asking.
Yeah, I tried to join a couple times, but it came down to please put your email address, and it says we don't accept that email. It's got to be from a school. And here's the list. There's a list of like 15 schools that you have to have an email.
Oh, okay, I got your point.
Yeah. So it's a private
I didn't
channel.
have that problem.
Unless I'm going to the wrong place, I don't know.
It is madall.org. Let me send you. But you both.
Yeah, you want to share it? Can you share it when you joined it, right?
I will send that to you tomorrow, the whole thing. But you know, this is the madall.org. Have you talked to him directly on Twitter? He's quite active, and if you and he's like very dynamic. If you want something, like if you want a collaboration, then he may make a few changes.
Yeah, I'll just write him and say, hey, look, I want to have access to your website. What do I do? Because they have good customer service. You see how they have the live chat and stuff.
And it's totally free. It's totally free. He doesn't take even a single penny, and it's a huge thing. And I was like, wow, will you do?
Yeah, I'd like to hear, but you know, they're hiring people and they have programmers, you know, so they must have something going on. You know what I mean? They have programmers, so they're hiring programmers. So they're doing something right. Do you know what I mean? Or they're funded by someone or something. So did you see? Did you notice that?
Oh yeah.
No,
that's
they're looking to hire people like mostly IT people. So something's going on there. They wouldn't be hiring, you know, I don't hire IT people because they cost money. So they must be doing something right.
Yeah, let's see. Let me tell.
Yeah, we'll see. We'll see. Nora. Okay, thank you for your help today. Thank you very much for your help.
Yes.
Okay. We'll see you tomorrow.